Dạ, sao? Yes. That's dạ. Your YouTube number is in. Huh? Someone is on. That's right. Okay. Yeah, good morning, everyone. My name is Dr. Moiz Adamji. I'm an emergency physician and currently in training to become a critical care specialist. I welcome you all to this training of airway management, but it's not just limited to airway management. It is also ventilation as well as oxygenation, which are key points that many of us forget. We think intubation is the last or the final blow, but we need to go through the steps before we can go to intubation. So I would like to welcome you to this 2-day course. Some housekeeping rules. Can you please keep your phones on silent? Is someone on Zoom right now? Or this is the one which is recording? Okay, I think it's a Zoom. Okay. All right. Technical issues like everywhere. Okay, I would like to know you all before we start so that we know who is registered as which hospital. All right, so let's start with the gentleman on the left-hand side on the laptop. Sir, what's your name? Where you from? And how did you find out about the course? Yeah.
Right. I'm Dr. Lamek Bonaventure Wanda. I'm from Thrive Care Clinic and Newly Clinic. Started like a month ago in Unoni. So how I had it from my fellow doctors.
Continue.
I'm Safia Saif Daharan from Thrive Care, critical care nurse.
All right, good. I'm happy to see a critical care nurse.
Morning. My name is Dr. Selina from Mwananyamala Regional Referral Hospital.
Mwananyamala. Nakumbuka nani my times when I used to refer, when we used to get referrals from Wananyamala.
Good
Very
morning.
good place.
My name is Anastasia Blas, a critical care nurse from Wimbili Orthopedic Institute.
Sawa,
I
Moi.
heard from Dr. Shamim.
Mnafanya sasa hivi robotic surgery. Mko mbali.
Okay, good morning. My name is Shamim Sulu. I'm also from Moi. I'm a medical doctor.
All right. Welcome, Moi.
Good morning. My name is Jacqueline from Mount Meru Hospital, Arusha.
Sawa. Msalimie Ndago.
Good morning. My name is Dr. Joram Pangani from Mwananyamala Hospital.
Karibu.
Good morning. My name is Dr. Fatma Hassan. I am from Shifaa Pan African.
What's your favorite number?
007.
Good morning. My name is Dr. Yonaz. I'm also from Shifaa.
Good morning. My name is Juma Omar. I'm a critical care nurse at Shifaa Hospital.
Welcome, Saifi.
Good morning, everyone. My name is Peter Kapara from Shifaa Hospital as a nurse.
Karibu.
Good morning. I am Safa. I am nurse from Thrive Care.
Karibu.
Good morning. I'm Lehema from Thrive Care Clinic.
Good morning, everyone. My name is Ayub Samsoni from Wimbili National Hospital. I'm a nurse.
Okay. Karibu. All right. May I give the mic to our faculty who can say a few words? I'll start with Dr. Ismail. Dr. Ismail is a critical care physician as well as an emergency physician. He has been working for Hindu Mandal for God knows how long now, but he has a decade of experience in emergency medicine and critical care. And he's here to teach us today about this course as well. So I would like him to say a few words before we start the course. Sauti inatoka kwa Zoom, kwa hiyo ndio maana. Sawa. Okay. All right. So that was from our local faculty. We also have international faculty. She's a critical care physician. Her name is Dr. Reena Patel, all the way from Australia. So I would like her to say a few words to our participants today.
Morning, everyone. It's a pleasure to be here. Yeah, I'm basically trained in the UK, but originally grew up in Kenya, and then I've moved to Australia 11 years ago. I work as a consultant.
All right. I'm going to recognize some senior faculty. Dr. Asha. Dr. Asha is from Moi. I believe some of you know her, and she has almost, I think, more than 20 years of experience in her field of anesthesiology and critical care. And I believe when she graduated, I was not even born. But yeah, she's a very senior person, and she's here, so I'm happy that she's here with us. All right. There's some new faces that I'm not aware of, so I'm allowing Dr. Rama to come on the stage. He's the CEO and of EMSA. So Dr. Rama, please come on the stage so that you can introduce the rest of the faculty and we begin this course.
Thank you. Thank you, Moise. Moise and I actually share almost similar experience. Most of these people that you see here are our seniors. We, from one way or another, we went through their hands. I remember Dr. Ismail Sangay, when we were working at Aga Khan. I was a very junior intern, and just after completing my internship, I was sent to ICU, and Dr. Sangay, who was actually in accident in emergency. Previously, it used to be called accident in emergency, and then sometimes comes to ICU. I had a lot of inspirations from him, and I learned a lot from him. So today, being here teaching the same class, it is actually a wonderful opportunity for me and for everyone. So for him and Dr. Asha as well. Apart from that, we have a wonderful leader and a physician actually coming all the way from Tanga, Dr. Naima Zakaria. She, apart from being a specialist, she was once my medical officer in charge at Bombo Hospital. And she has been actually inspirational all the way through the time when he was a leader, and even now when he's actually manning the ICU and emergency department. Dr. Naima, please take time to introduce us.
Thank you, Rama, for that introduction. Habari za asubuhi. Naitwa Dr. Naima Yusuf. Alivyoniambia, alivyosema Rama, mimi ni anesthesiologist au daktari bingwa wa usingizi na ganzi salama, lakini pia nasoma sasa hivi critical care. So I'm in my MSc for critical care right now. And I'm so glad that I see people from Regional Referral Hospital and ongereni kwa moyo wenu who allowed you to come, because this is the opportunity where we interact with private firms in exchanging ideas, but also in getting more knowledge. I know that where I come from and where we people work is a resource limited center, and Koyo, it's a chance to learn. ICU and EMD, as you know, our president has invested a lot. And right now, there is no regional referral hospital who doesn't have ICU, EMD, or CT scan services. So this is a very plus point from our government. Now, what we have to do is utilize those services. And opportunities like this of training is very important. So please be very flexible. Sisi wote hapa tunafahamu lugha ya Kiswahili, except for Dr. Rina, but we are all very comfortable with Kiswahili. So ask, don't consider a language barrier to be a reason of not acquiring more knowledge. So ask where you are getting stuck, because asking is not ujinga. Samnajua jamani. Yeah. So please be very comfortable, be interactive. It's my first time to be training. Kwa hiyo nikiwa nimekosea, I have my seniors around me in teaching, so watanisaidia, lakini nyie pia niambia daktari hapa hatujaelewa. Sawa jamani? Kwa hiyo karibuni sana, and let's have this very two interesting days of interactions. Asanteni.
Okay, now that the political formalities are over, we start with our course. Okay, so every one of you will be given a timetable. I hope that you have been given one. So this course is a full day course. Yeah. This course is a full day course from 8 a.m. to at least 5 p.m. But today we might end early, at least by 5, we'll try and maximize that we end. The course has 15 hours of CPD points. So rest assured that you are going to get your CPD points through EMSA. Before we start the course, we have our sponsors here, who we need to thank. All right. And later on the day, we are going to give them 20 minutes to talk about their products. The healthcare company is called Janse. It's a well-renowned healthcare company which supplies intrasurgical equipments. If you have seen those nebulization masks which have a silicone ring on it, these are the people who are supplying it. If you have seen IGLs, laryngeal mask airways, then these are the people who are supplying it. So I would like him to come and say a few words, and then we immediately start our course. Please, Karim. I'm so happy to be here. By the end of the day, I hope that so much people, and I'm so happy to be part of this program. Thank you so much. Thank you. All right. Okay, so from the timetable, the first lecture that we are going to be doing, so it's basically a lecture-based and skill-based station. So first we are going to complete all the lectures, and then we are going to go to the fun part, which is the skill station. So I would like to invite our first speaker. Okay, so our first speaker will be Dr. Ramadan Chunga. If all of you, anyone who knows him personally? Okay, so he, on a personal note, he's a very good individual, a trainer by heart, a teacher. If you give him the mic, he cannot stop. He's that kind of a good teacher. And he's an emergency physician and a fellow of the South African College of Emergency Medicine. He currently works in the ship as a ship physician, but he's constantly on the phone with me whenever I want to discuss a case relating to emergency medicine or critical care. So I would welcome him first, Dr. Ahmad.
Asante Moise. Nafikiri viongozi wameshazungumza. Our leaders have already spoken with regard to you having the commitment to come to this class today. We as physicians, we echo the investment by the government, and we echo that we do have quite a number of ICUs, actually now numbering out 81 across the country. We echo the investment I've done in the emergency department, and we realize sometimes we lose our patients because of what we do and probably what we know. And for that being the case, we think airway management is one of the key things that affects our patient outcomes, And that's why we're here today. And mostly we will cover from the humble beginning of airway management with experts here to the very end of being an expert. So being a two-way traffic in terms of learning, we're going to have PowerPoints and we're going to have skill sessions. So please dive in, ask your questions. Rina is Australian, but she knows Swahili. You can ask her in Swahili. She loves speaking Swahili. So please make use of these faculty around here, make use of their expertise, squeeze them to the last drop, right? After speaking that, Moise, you can continue with the program. Thank you so much, guys. We're happy to have you here today and tomorrow.
Okay, so all right. So our first speaker is going to be Dr. Ismail. I've already introduced him. Due to time, I'm going to allow him to come and present his talk on acute respiratory failure.
Good morning again. So as we said that we'll have a two-way communication. So at least we understand each other. What's my gap? What's your gap? At least we come to a common level. So the first topic, which just to create a foundation that we know about the whole respiratory system. Okay, we're not going to talk about anything respiratory physiology, but just we'll skip that topic and go to the failure. Okay, respiratory failure. So what do we understand by respiratory failure? Anyone can comment, or I just move the slide forward? Anyone? Quiet means everyone is understood. So respiratory failure in terms that someone having some pulmonary system problems because they cannot meet up the demand. And there are so far two types of respiratory failure, type 1 and type 2. What do I mean by type 1 and type 2? Again, should I pick someone? Okay, I know the slides explains everything. Okay, so type 1 is anything related to hypoxemia. Okay, type 2, anything on hypercapnia. Okay, so type 1 is anything hypoxemic respiratory failure, whereby if you are keen in all the parameters of the blood gases, if I know we are very comfortable looking at millimeters of mercury rather than kilopascal as our unit. So anything less than 60 millimeters of mercury at room air, if it is less than that, that's considered respiratory hypoxemia. And hypercapnic is anything which is, there is a retention of CO2. Okay, so the CO2 above 50 millimeters of mercury. So let's talk about basic physiology. The basic physiology is that we breathe in oxygen, two gases, breathe in oxygen and breathing out carbon dioxide. Of course, room air has multiple gases. Okay, everyone knows oxygen, nitrogen, and small gases. Just to everyone to understand, at sea level, what we are, how much amount of oxygen we are breathing. That's 21. Is it 21%, right? And nitrogen is 78. Okay, someone said 78. So that is what we are breathing in. Of course, it has no any functional role over there, but it acts like an inert. Okay. So we are not going to talk about all the gases. We'll just focus on two gases in the whole talk, oxygen and carbon dioxide. And even in the other talks, we'll be just talking about oxygen and carbon dioxide. Of course, there are other gases like nitrogen. Okay. They also play some role in calming down the oxygen toxicity. Okay. So oxygen, to deliver oxygen, okay, or to go into the system, it all depends on these things. Okay. Pressure of the alveolar. We'll talk about that. The diffusion capacity from the alveolar to the blood circulation, ventilation, and perfusion, and which along with their matching. So just to explain in a way that I talked about the 21% which we inhale in. Okay, so that's not only oxygen purely, we get all the other gases. So this is just small portion of oxygen which comes in. This is the alveolar. This is the 1 unit in the lung, okay, of alveolar. This relies on oxygen, also carbon dioxide, small amount of water vapor, and full nitrogen. Why not the nitrogen goes into the circulation? Any idea? Why only oxygen? Or you'll tell me later? Okay, I'll skip that. We'll do on the skill stations. As Dr. Rama said, squeeze me hard to get me that information, that you don't go out from this talk empty-handed. Why the nitrogen do not get diffused into the circulation at the sea level? Okay, we are at the sea level. We are not at Kilimanjaro nor below the sea level. Okay, so it has the law of physics running around here. Okay. Now, in terms of if you are delivering oxygen, inspired oxygen, you're pushing in high amount of oxygen. So the oxygen takes a big room, and the nitrogen reduces. So it's called denitrogenation. Okay, so you are removing the nitrogen out and by replacing oxygen. Okay, so just giving you a clue, nitrogen, a hint, nitrogen acts like an inert, okay, to calm down the effect of the oxygen. Okay, you'll answer me later on in our skill stations. And in returns to if someone is hypoventilating, because hypoventilating or the oxygen supply is less, or maybe it's a diseased lung, so the carbon dioxide levels are more of equal to that amount of oxygen, and of course the nitrogen becomes higher. So coming to each and every point that we're going to talk about, the alveolar pressure to deliver that oxygen, it requires 4 things. Okay, how much oxygen you deliver, that's fraction of inspired oxygen. The alveolar pressure, it's a pressure. Okay, anyone knows about Henry's law? Okay, Henry's law says that pressure is directly proportional to the solubility of the gas. So higher the pressure, higher the push. So that's the alveolar pressure you require. And in returns, this is also depends on how much partial pressure of the carbon dioxide in exchange happens with an oxygen. And lastly is the ventilation. So ventilation perfusion mismatch, why do this happen? Okay, we'll talk about that. So ventilation perfusion, what do we understand that by this? Again, anyone want to, everyone is a bit blinded on this, or should I just give an explanation? So the alveoli, I showed you the alveoli, it's surrounded with the vessel, the ventilation, okay, and the perfusion in the vessel. Okay, this is what you saw. Okay, so it has to be in a good ratio of 1. Okay, anything skewed to the right or left, there will be a mismatch of the ventilation or perfusion. If it's skewed to this side, there's a problem in the ventilation in the alveolar level. If it is skewed to this side, there's a problem or defect in the perfusion. And what about carbon dioxide? Okay, carbon dioxide should not stay in, it has to be out. Oxygen comes in, carbon dioxide out. This is the basic biology which we learned even in schools. Okay, and here it all depends on the ventilation. Okay, apart from the oxygenation, we have to talk about ventilation. So the ventilation is a product of the tidal volume and the respiratory rate. How much you breathe out That is how you can blow out the carbon dioxide. But not only respiratory rate, but it also depends on how much the tidal volume you make up. Okay, so everyone knows what's the normal tidal volume. Say the number, any number. Sorry, come again? Yeah. So I would say approximately what we learned in physiology, 500 mLs. Okay. Now it depends on someone's height. I know we'll talk about that 6 to 8 mils per ideal body weight. It can be even 10. Okay. So as we said, it depends on the respiratory tidal volume and also the matching of ventilation and perfusion. So talking about the each aspect of the whole pathophysiology of respiratory failure. Look at the unit of a lung unit, alveoli. So this is where the pressure is applied. It's like about 100 millimeters of mercury, which is a normal pressure. This is alveolar pressure, not arterial pressure. Okay, a pressure exerted inside into the alveoli. Anyone, because there is a pressure which we are at the sea level, about 760 millimeters of mercury is hit on us, and the pressure goes down till to the level of the alveoli that comes to 100 millimeters of mercury. So how this works? This is the deoxygenated blood. You see the blue color means no oxygen. That's the hemoglobin unit. Okay, in the RBC, the diffusion happens. The hemoglobin carries the 4 molecules of oxygen. 25, 25, 25, 25 makes it 100%. That's why you end up getting your SpO2 or SaO2 100%. 25, 25, 25, 25 makes up 100%. Are we all okay? Okay. So let's talk about all respiratory causes, respiratory failure causes. These are the few of them or major of them. One of them is low inspired oxygen. Okay, if someone is taking in low inspired oxygen, which commonly happens in patients or if you maybe climb to high altitude, what happens to the high altitude? The pressure is lower compared to what you are at the sea level, isn't it? So that's low inspired PO2. Okay, so low inspired PO2. So this is a normal unit, PO2 100, and suppose that you are at the Kilimanjaro at the higher altitude. So the pressure will be on the lower side. So here, if you see the unit are well saturated to get a SpO2 of 100%, unlike here, if you measure those patients in Kilimanjaro, their SpO2 will be like 60, 70%. Okay, so we are on the same page. Other cause could be hypoventilation. Now, hypoventilation can be so many other causes. Can be because of the respiratory depressants. What are those? Or any CNS pathology or neuromuscular pathology like Guillain-Barré, head injury, okay, or respiratory depressants like benzodiazepines, barbiturates, phenobarbiturans can cause respiratory depression. Okay, so it's similar thing. Okay, so here it's a normal unit. So if the muscles are not really moving, there will be no exchange of gases happening. Yeah, so these are the things that I've explained. So this is from the CNS. These are all the causes of hypoventilation. If anyone having pathology on the CNS, neuromuscular, or in terms that if you iatrogenically cause more barbiturates or benzos. Coming to other pathophysiology or causes of respiratory failure, ventilation perfusion mismatch, and that happens due to shunting or dead space ventilation. What do I mean by shunting? Shunting means that we all know that from the right side the blood comes in, deoxygenated, goes to the lung, okay, carries oxygen, the 4 molecules of oxygen which I explained, and then moves to the whole circulation. That's why the peripheral you end up getting 100%. Now in here, we all know, have you ever knew about right to left intracardiac shunting? Tetralogy of Fallot, VSDs, SMangers. So that is more of anatomical, right to left shunting. Now there is also intrapulmonary shunting, whereby the hemoglobin, the oxygenated blood, just bypasses the lung without carrying that oxygen molecule and moves to the left side of the circulation. Okay? So this just to explain you how the shunting happens in a diseased lung. This is one of the unit of the alveoli. This is diseased, okay? So 75% the hemoglobin comes in from the left side, from the right side, passes to the lung, where the lung is diseased, and it cannot diffuse that oxygen enough, whereby the hemoglobin can carry. So what happens that the 75, you end up getting 75. But on an undiseased lung, because not all the lung will be diseased. So here, what happens, there's 75, the 25%, and you get SpO2 100. But you will not get 100% because one part of the diseased lung, okay, is producing 75. Just to mean up the values, the sets, you'll end up getting 86, 87%. So this is what you see on AO SpO2, okay? Now, good about our body, we have a good compensatory system. There is a phenomena called hypoxic pulmonary vasoconstriction, okay? When a lung gets diseased, okay, or any pathology, undiseased lung, so the pulmonary gets vasoconstricted, as to divert that blood supply to the undiseased lungs, that produces or attracts all the oxygen and binds to that like remaining hemoglobin to produce a good set amount of 100% to make up the saturations up. So this is a mechanism called hypoxic pulmonary vasoconstriction. Okay, so these are a couple of causes that I mentioned in my talk. So intrapulmonary, this is pneumonia, pulmonary edema, any lung collapse, pulmonary contusion. So these are diseased to the point that the right side of the heart, if pushing enough hemoglobin, but the lungs cannot diffuse enough oxygen to carry into the left circulation. Right, the intracardiac, as also mentioned, right to left shunt, which are ASD or VSD due to SMangers. Coming to dead space ventilation, dead space ventilation or dead space, we all know the dead space, there are two types of dead space. The anatomical. What means by dead space? By definition, it means that there is no any gas exchange happening. Okay, so anatomical from the nose, throat, till to the lung unit. Okay, that's the anatomical. Coming to the physiological dead space, it's the unit in the lung whereby there is no any exchange happening, okay, of gas. And this really explains in the graph, whereby ideally the graph has to be in a good linear form, whereby the ventilation perfusion ratio has to be 1. Anywhere if it is skewed to the left side, and what example can you think of if is skewed to the left side? What disease process? This is perfusion defect, and this is ventilation defect. If it is skewed on here, what are the examples that you are thinking of? I can be wrong, you can be wrong. Maybe just say perfusion problem. Yeah, pulmonary embolism. Okay, so pulmonary embolism. So that's a perfusion defect. Okay, so the whole graph skews to the left. What about here? the ventilation problem. We talked about ventilation, blowing out the carbon dioxide. So carbon dioxide, it is retained. So what is the example? So, sorry, you're saying? Yeah. Perfect. COPD. Okay. Thank you. At least we are interacting. All right. So diffusion abnormality. So this happens in patients with severe ARDS or pulmonary fibrosis, whereby there is a defect or maybe at the alveolar epithelial and alveolar level, to the point that the gas exchange is a bit difficult, whereby oxygen cannot diffuse well, nor the carbon dioxide can come out. So talking about the respiratory evolution to the point that they deteriorate, this is how it happens and what you can look into it clinically. So they'll have a respiratory compensation when a patient comes with a respiratory failure. Then they'll have sympathetic stimulation, tissue hypoxia, and hemoglobin. So we'll just talk each and every part. So if a patient comes with a respiratory, any type of respiratory failure, what would you see the patient on them? You can see the movements, like the patient will be fast breathing, tachypnic, accessory muscle use, as you see on the image. Recession nasal flarings are more common in children than in adults. Okay. And later on, if this keeps on happening and if you don't intervene, sympathetic stimulation, there'll be definitely tachycardic. Okay. Initially, the BP will be high. Okay, because they're trying to compensate, because the whole sympathetic goes up. They'll be sweating, there'll be anxiety, they have anxiety a bit, they'll have delirium going on, confused. And if things keep on going without any intervention, altered mental states, delirium, heart rate will start dropping, and BP will start dropping, and then you know what happens. Okay. And finally, you'll end up getting cyanosis, because all the hemoglobin, oxygen carrying capacity gets reduced. So pulse oximetry, I think everyone is using in their practice. It's a very good, powerful tool. It's a non-invasive. It gives you an idea on how much arterial PO2 is. So this is refers, like if someone having a 90% of hemoglobin saturation, it refers to somewhere 8 kPa, 8 times 8, like somewhere 64 millimeters of mercury. Okay, so this gives you an idea. But however, looking at the oxygen delivery is not only relied on saturation and PO2. It's relied on three entities. How good is your heart, like the pumping, pushing that oxygen, okay? How much hemoglobin you have, okay? That the hemoglobin can carry those capacity. If someone having an HB of 3, even if you push 100% of oxygen, it will not deliver that amount of oxygen to the rest of the body. Isn't it? True or not? Okay. If someone having an HB of 2 or 4. So you have to have all the balance, good cardiac output, good hemoglobin, and amount of oxygen that you are delivering. FiO2. Yeah. All right, so these are the SpO2 that you end up getting errors if someone having hypoperfusions, if putting some nail polishes, and these are the things. I'll not go in details. Okay, so just let's talk about here. This is in the cardiac monitor. Reduce the light. Can you guys see? Okay. What's wrong here? No, this one. What's wrong here? Okay, just tell me, what's this? Okay, this is an ECG. What is this? What does this represent? 123. Pulse rate or actually heart rate? Okay, heart rate. It's at heart rate. Okay, that's tachycardia. Someone said tachycardia. Okay, 80 by 40. Okay, okay. So that's blood pressure. Is it normal or abnormal? Hypotension. Okay. What's this 87? Saturation. So, and what's this? Okay, it said heart rate. So, by just looking at this figure, how can you interpret? What do you say? This patient is stable enough in terms of oxygenation. We just talked about 3 things. Heart has to be good, hemoglobin, and oxygen delivery. If you have to interpret, they are really tachycardic. Okay, the heart is really working hard, and it's not. Why tachycardic is trying to keep the blood pressure up. Okay, try to keep on compensating. Okay, we human beings, we cannot compensate forever. If we could have compensated forever, we could have been immortal. We would have not died, isn't it? Yeah. So that's compensation happening. Okay. Now this heart rate, is it correlating with? The heart rate is correlating with because this is SpO2, the SpO2, which gives out the peripheral pulses, isn't it? So this is, I know it's written heart rate, it's pulse rate. Is 123 correlating with the? Isn't? So it means that there's a perfusion problem. Means you have to have 123 here and 123. So in a synchronized. So it means that there's a huge perfusion defect, oxygenation defect from the heart till the. So you need to intervene in terms of the heart and providing oxygen that you can match up the heart rate with the pulse. Okay. So we have to worry and intervene for patients if they're tachypnic. Okay, this I'm talking in adults. Pediatrics, their number is a bit different. Okay. Pediatrics, these levels are normal. Okay. So don't think that, okay, Dr. Ismail said, okay, everyone is heart rates is more than 30, you have to be worried. Okay. So it's age is a fact matter. So anything above more than 30 tachypnea, you have to worry. If a person cannot complete sentences, they are confused, agitated, delirious, hallucinating. Okay. They're desaturating, cyanosed, maybe SpO2 is dropping to less than 90. And despite giving whatever the therapy that you are giving, it's not really helping. So you have to worry. And remember, that's the very important thing. Do not treat the SpO2. Okay? Treat the patient. Always correlate someone's SpO2 in correlation how they are breathing. Okay? Or how they are presenting. Okay? Normal SpO2 does not mean severe respiratory problems are not present. Means you have to correlate. If the SpO2 is 100% and then they are still tachypnic, you have to worry. So how do we treat? Okay. Treatment is, of course, giving oxygen therapy. We're talking about respiratory failure. And either you have to support whatever the modes, tools that you can provide oxygen, because oxygen, you cannot catch them. Okay. You have to put via a pressurized system. Okay. Via tank, via wall mounts. So you have to deliver that oxygen from those source and deliver to the patient via nasal prong, mask, non-rebreather, and high flow, and to invasive ventilation. Okay, I'll just skip that. So That's one of the things that we can deliver. I know I skipped the nasal prong and others. So this is one of the high flow amount of oxygen with the reservoir, which provides a higher amount of FiO2 to 100, almost like 100%, if it's given about 15 liters per minute. And there is also a big valve resuscitator. The difference in here, this is flow, automatic flow, whereas this is flow with a reservoir, but by administering a pressure, manual pressure, it's like creates an extra added positive pressure. We have a God-given pressure exerted on us, okay? And this is a man-made pressure you exert, because maybe that pressure, God-given pressure, is not really enough to diffuse that oxygen in or to oxygenate the person. So you add up extra pressure by pushing manually. There's other units coming in, high flow, humidified nasal cannula, which we'll talk in the coming talks. I'll not talk so much about it. It's more comfortable modality compared to the other thing, like NIVs. So it provides a high flow amount of oxygen to create or to mimic high positive pressure ventilation. So, and coming to CPAP, okay, CPAP, whatever the pressures that you are getting, because the pressure is coming from the tank, or tank is all pressurized with oxygen in. When you release a balloon, a pressure comes along, right? So the pressure comes up, that's the pressure pushed to the patient. It's called CPAP, continuous positive airway pressure. But CPAP here, what we refer here, by an aid of a machine, you give an extra pressure. Because the pressure which are provided from the tank, it will be somewhere to 5 to 7 centimeters of water. But here you can even push it to 10 to more than. So what this helps, it helps both high flow and even CPAP. It helps to reduce the shunting from what I discussed, that that the patient can get well oxygenation by recruiting the collapsed alveoli. Recruitment means the alveoli are well distended, whereby the gas exchange can happen. Okay, so by doing that, it improves the lung compliance and functional residual capacity. And lastly, if all those things fail and you see the patients are deteriorating, you have to escalate your therapy and think of ventilating invasively, which of course is a multifactorial. There are no simple rules. You can think of delaying or maybe initiate early. But my rule had been, if things don't go well non-invasively, earlier, like in few hours, do not delay to the next day or after 12 hours, or give it to your other colleagues a problem. So early intubation, early extubation. So yeah, so if anyone having respiratory failure, you definitely think of intubating earlier. And anyone having cardiopulmonary instability, yes, you can think of intubating and ventilating the patients. Yeah. So these are what we spoke about. Yeah. All right, so let's go with the cases. Okay. Let's interact. That's it. I skipped some slides for you that at least we move along. You know, with the case we understand best rather than looking at the slides. Okay. So we have a 43-year-old male, community-acquired pneumonia, day 1 of antibiotics. Okay, received a day 1, and gladly you have a blood gas on the spot. I think everyone well conversed with reading blood gases, right? I hope. Okay. So arterial, that's an arterial blood gas. Okay, not venous blood gas, arterial. So that's 60 millimeters of mercury, PO2. Is it low or high? High, low. Okay, I heard low. PCO2, 30. pH 7.15. I know bicarb is not given here. Okay. And respiratory rate is 35. The patient is agitated. Okay. By just looking at this one, would you, and then the patient is already on non-rebreather mask, 15 liters. Okay. And that is where he is hitting at 60 millimeters of mercury. If I have to convert that 60 millimeters of mercury to SpO2, I know it's not given here, it will be somewhere about 85 or 80%, the SpO2. So would you intubate this patient or just continue with non-rebreather mask? No, thank you. I forgot the democracy part. Okay. All right. So those people who do not want to intubate, reasons? Okay, so let's go like a case by. So this patient is first hypoxemic here. Okay, based on the blood gas. So just remember, hypoxemia and hypoxia are two different things. Hypoxemia defined as low oxygen in the arterial blood, and hypoxia means low oxygen in the tissues. Okay, so that's why don't treat only the labs. Treat the patients too. Okay. The patient has community acquired pneumonia. Okay, number one. Has been on antibiotics. Antibiotics will not work miraculously in a day. It takes some time to kick in. Okay. So you need a support the patient as not to deteriorate or die. Okay. So here there's already hypoxemia. Okay. The pH is dropping. Means that the patient is acidotic. Okay. Of course, is not acidotic because of the respiratory, but it seems like acidotic to do metabolic. Why? Because there's a perfusion problem. There's a perfusion problem. There's a lactate buildup. So lactic acidosis. Of course, I didn't give you that point. And the patient, despite on 15 liters of oxygen, that's the max that you have reached on 15 for good 1 day. And then the patient is still not meeting that oxygen demand. Means like the PO2 is not climbing up. It's like less than 75. Okay. And despite that, the respiratory rate is high. Means the patient is running a marathon here. Is running a marathon. The muscles will get tired. Muscles will get tired, okay? Is running a marathon while on the bed, not running on. Because if someone is running a marathon, they have to calm down and take a chair and then cool down. But if this person keeps on running a marathon while on the bed, you know what happens, right? And the agitated part, that's really concerning, okay? The agitated tells you like the low oxygen is going like not reaching to the brain. Oxygen is not reaching to the brain. So that tells you that there is a hypoxia happening. So here, I personally have to be worrying. Okay. I know you can buy some time putting the non-invasive modalities. Okay. But if you have reached to that 15 liters of oxygen and you're not getting a good results, I would suggest the patient to get intubated. We all clear? Okay, yeah, this is what I was just. We all okay? So I wanted you to have that reasoning, when to act and when not to act. Okay? All right, now second case. All right. 24-year-old female comes to the emergency department with history of asthma and has asthma exacerbation. Had been on salbutamol but did not take any steroids. Okay. So the peak flow rate, the normal peak flow is approximately 200 to 400. If you have, never mind about that. Okay. If you are not into doing practice on that, heart rate, 100 above. So these are the blood gas parameters. Okay. pH 7.25, PCO2 is more than 45, 51. PO2 is 315. Okay. It's more than the one on the previous case. Okay. Well oxygenated. Okay. But that one was hypoxemic respiratory failure. This is type 2, hypercapnic respiratory failure. Okay. The patient is tachypnic, of course. Okay. Now, and then, yeah, 315 on 60% of oxygen given. Okay. So that's 60%. 21% is 0.21, what we are breathing in here. And the patient is fully alert. Do you intubate this patient? Will you intubate this patient? Okay. Democracy. Intubate or not intubate? What magic you did? So you'll intubate? You'll intubate? You'll intubate? No. You'll intubate? 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 Okay. I'm seeing no one will be intubating. Okay. Why? In comparison to the previous case, why you will not intubate this patient immediately? I know the first case you were like wanting to buy time, but anyway, why you're not? See, intubation, I think there had been like a bit stigma about getting patients intubating. Okay, so just think of these things. Yeah, like I learned from a very famous author. It's called Paul Marino. He's a famous. So he put up 3 rules, very good rules. Okay, intubation and putting on the ventilation. One ground rule is number 1, intubation should not be your personal weakness. Okay, it should never be your personal weakness. It's not everyone has born with the skills of intubation while they were born from into this world. Okay, so you should not think that, okay, someone will say, naysayers will tell you like, oh, okay, you're not doing well. Practice makes perfect. Number 2, okay, it helps the patient, because if you do not intubate the patient, because at least you are giving the patient 50% chance of survival. That's a survivorship to the patient. And number 3 is not a kiss of death. Intubation is not a kiss of death. So that had been a stigma around, not only for layman people, but also even among the medical personnel, that if a patient gets intubated, that's the bye-bye story. No. We have intubated many patients. They have extubated, they have walked out. Okay, so it's a tube which you see on your nose. It's just a tube which goes into the throat. That's all. That's the big difference. That's all. Only that how you run the machine, that is where you are here, us to teach you how to take care of these patients. Okay? All right, coming back to the case. Sorry, I don't want to bore you guys. I know there's so many other talks. Moise will tell me like, okay, zip. Okay, we'll not intubate this patient. I'll answer this. Okay. Okay, forget about this. I know we're not practicing that. So this patient in asthmatic COPD, they have a baseline carbon dioxide retention, because we should not so much worried about their CO2. Their CO2s are not like 35 to 45. They can be even till 55. So we should not so much worry about these guys. They just play with their physiology. Let's play with their physiology. So if the CO2s are like somewhere less than 55, they're good. As long as they are fully alert, they're not zonking off, Okay, they're not having any altered level of consciousness, so don't worry about them. Okay. Second thing, yeah, as long as they're alert, okay, and they had been just on salbutamol without steroids. Okay, steroids. So, and we know it's asthma. So what you'll do here, what best thing you'll do? You'll nebulize them. Nebulize them back to back, okay, because they've been on inhalers. The inhalers, the dose equivalence is not similar to the nebulization, and administer steroids, because the key factor or key medicines in asthma or COPD is steroid. Give them steroids and observe them couple of hours. You'll see them, they'll start reversing. So their exacerbation gets resolved over time. So I think we're okay. So take home messages. Any questions? Any questions? Okay, so this is take home message. Shunting is the most common cause of acute respiratory failure, which is more of type 1 type. So the best thing what you can do is give high concentration of oxygen, either by mask high flow, or you can put in extra pressure by putting a CPAP or high flow nasal cannula. Thank you.
Okay. There was a study done which showed that if someone lectures you, you'll remember only 5% of what they lectured you. But if you ask questions and you discuss, you retain almost 50% of the knowledge that they gave you. So we encourage questions. I don't know, do you see horns on me? Do I look like a devil? You can ask me questions. You can ask Dr. Ismail questions. Please, let's be interactive, okay? We are going slow and smooth because we understand that we are still in the basic part. And then when we go to the advanced, by the end of these 2 days, you will be an airway expert. Trust me. Okay, so take-home messages that I got from Dr. Ismail is number one, that there are 3 types of respiratory failure. There is type 1, which is oxygen related, type 2, which is CO2 related, and type 3, which is the mixed part. Okay. However, type 1 and the mixed part have like an equal kind of distribution. But some books say that type 3 is the most common one because it usually presents as a mixed type. So you'll have oxygenation problem as well as a ventilation problem. One of the important things that I would like to tell you guys, and please take it into practice. Say you have oxygen of 89, okay? This patient comes in, you put him on non-rebreather. 100% oxygen, now you're happy. But why are you forgetting the respiration rate and the work of breathing of this patient? After 1 hour, umemwacha, and deteriorate. And then you start questioning yourself, but the oxygen was 100%. So there is 2 things in this play. There is oxygen problem and ventilation problem. And what I would like you to tell yourself is, I'll give this patient 1 hour. If within 1 hour, the non-rebreather doesn't help, I need to escalate my therapy. If you're someone who likes bridging your patients from oxygenation to intubation, then try CPAP or non-invasive, which is our next talk by Dr. Rama. So importantly, it's that 1 hour rule. So let's say I'm given non-rebreather mask, right? Patient became 100% oxygen. But you can clearly see he's getting tired and the respiration rate either will go very much up or very much down. Okay? If it goes down, the respiration rate, and you can see this patient is tired, that's intubation directly. Okay? If the respiration rate goes up, that means that patient is trying to compensate and screaming to you that, hey, give me something more. So you have to go for something more. So remember that, okay? The third thing he talked about is FiO2. Everyone knows what is fractionated oxygen? And how do you convert liters per minute into fractionated oxygen? Do you know? Anyone? Dr. Jonas? Can you convert liters per minute into FiO2? Or yes? What is it? Okay, so basically 1 liter equals to 4%. So, and we already are taking 21% of oxygen. So 1 liter times 4 plus 21. That's how you calculate liters per minute into FiO2. Okay, and the relationship between FiO2 and partial pressure of oxygen is FiO2 times 5 equals to your partial pressure of oxygen. Now, if you give 50% of oxygen, you should see on your blood gas almost 250 of partial pressure of oxygen. Then only your patient is oxygenating well. Because if you do ABG, and let's say you're giving 100% oxygen, and this person, like he said, was screaming for oxygenation. Oxygen yake 60. So patient is on 100% oxygen. He should be around 500 to 400 if we are really oxygenating them well, if the alveoli are really opening up. So remember that point, okay? Don't just look at the oxygenation, look at the respiration rate, and look at the patient, whether they're getting tired or not, okay? So our next presenter is Dr. Ramadhan Tunga. And he's going to be talking about what is the next step. Let's say if non-rebreather fails, what do we do? There is a bridging therapy.
Good morning again. An invasive. Okay. Dr. Ismail has presented a great deal of how our respiratory system works. And basically, he highlighted two functions of the respiratory system. One is to supply oxygen, and two is to take out carbon dioxide. Either of that, when it fails, is when we bring in the concept of respiratory failure. The number that we see on ABG, that how much of partial pressure of oxygen and how much of partial pressure of carbon dioxide, usually at room air. So yes, we understand we do have a lot of oxygen supply. We understand we do have a lot of oxygen supplement tools. How we use differs. What the patient has, it makes a very big difference on what equipment and how much oxygen we need to use. Dr. as well mentioned about shunt. We understand the basic principle of shunt. Hypoxia doesn't improve much by supplementation of oxygen when you have shunt, meaning that you need to do something else to have the patient actually improve the oxygenation or hypoxemia. Similarly, when a person has what we call type 2 hypercarbia, the problem is may or may not be oxygenation. Mostly the problem is ventilation. So the problem of the patient is not SpO2, it's not the saturation of oxygen. The problem of the patient is ventilation being an issue. There are so many ways we can address that. And probably I would like to give you a little bit of a situation. Let's look at how we're going to address it. So let me ask you a question. You do have someone with a saturations of 85 and is having respirations of around 18. And we do have another person with a saturations of 100%, but respiratory rate is 35. Who needs oxygen? Who can answer me? Who needs oxygen? Safia. You can pass it. You can pass it. Who needs oxygen? The person with respiratory rate of 35, but saturation is 100%. And the person who has saturations of 85, but respiratory rate is 18. Who needs oxygen? Can I have another one?
So I think I'm going to use common sense here. So if you're having a high respiratory rate, meaning you're working hard to make sure that you are getting that. So I'm going to put, with the one who needs oxygen, they're the one high respiratory rate compared to the one with low respiratory rate. That's what I'm thinking.
That's a saturation of 85. Did he got right? What do you think? So myself, I do have saturation of 85, but I'm not borrowing. My work of breathing is normal. But the other person who is having saturations of 100%, but he's breathing so hard to get that 100%, this person is borrowing, right? Mostly is going to get tired. This person most likely is maybe having a shunt somewhere, so is trying to compensate by breathing so fast, but is making it 100%. This is the person who acutely needs support of oxygen. But only oxygen is breathing hard, right? What also he needs? He also needs ventilation. And that is where we are looking at. So we're looking at two components. We're looking at the component of assisting with oxygen, and we're looking at another component of assisting with ventilation. So before you think of invasive ventilation, there are many ways that you can think of something that we don't have to intubate someone, and this is non-invasive ventilation that we can use. There are many ways of how you can deliver non-invasive ventilation. And what does it actually do? The work of breathing is being reduced because there is a bit of support that comes from the machine. Apart from that, if you had someone was breathing, you can imagine the tidal volume has gone down because of the rate, right? So it also adds, it augments on the tidal volume, but most likely, most importantly, is the element of PEEP. At the end of expiration, there should be pressure that keeps a valve open, right? But at the end of expiration, if you do have some positive pressure, then this positive pressure will keep the remaining alveoli actually open. And again, if you do have a shunt, for example, there is a pass, or we do have a collapsed alveoli, or we do have pulmonary edema, like water, then actually PEEP, or that positive pressure, will actually disperse the water, or open up the alveoli with a PEEP, and then keep them open. By doing that, you are adding surfaces where gases exchange can happen, and that's where actually you are going to improve what we call perfusion. Because on a shunt, what we have is gases exchange cannot happen because of perfusion problem, right? You do have ventilation, air comes to the alveoli, but the problem is the surface where gases exchange has to be happening. There is no contact with the blood supply. Therefore, what we call is perfusion has a problem. So therefore, when you open up the collapsed alveoli, definitely you are increasing the number of surfaces for gases exchange, and by doing so, you are adding perfusion, and therefore you are actually modulating the perfusion, ventilation, perfusion matching. You understand those concepts? So PEEP and the CPAP are integral part of assisting you with it without even considering of invasive way. And how does it do? It facilitates easier triggering and a decreased work of breathing in the presence of intrinsic PEEP. May improve lung compliance by preventing actually the collapsing alveoli. I can tell you, whenever you think of intubation, you have to think that this person is going through a very risky procedure. Work of a person who is working in an emergency department is to prevent getting this person in a ventilator. Try your level best to get this person not in a ventilator, because one, the chance of work that's required for human resource is high, because you need a nurse, you need a doctor to keep that, to be with that patient. That's one. You need resources. We need a ventilator to be isolated for that person, right? And again, this person requires an ICU bed, and we understand the cost of ICU is high. So as an emergency physician or emergency practitioner, one of your job is to see those patients that need not to be intubated should not be intubated. Because intubating a patient is actually a commitment that you're putting in on the patient, or commitment on everything, or commitment on the pocket, on commitment on actually monitoring that person until the tube is up. And some of the patients, when you intubate, getting them extubated is very difficult. So these are the things that you have to consider. So the best way to make sure that you navigate around when a person is becoming tachypnic is first to try on non-invasive methods, during which you are sorting what is the problem. A problem with pulmonary edema should not be intubated. Why are you intubating a person with pulmonary edema? Because you know, after giving Lasix, after putting the person on CPAP, after starting nitrates, this person definitely, the fluid will go away. This person after 3 or 4 hours is going to be out of need of ventilation. Why are you intubating? So non-invasive ventilation is going to buy you time on when you are assessing that patient. That's one. So it avoids other complications, local trauma, hypotension, nosocomial pneumonia, upper airway damage. These are the things that goes along with how when you start intubating a patient. It also gives you an age that you can give some rest when someone says, oh, now I'm ready. Usually we give non-invasive for 4 hours, and then you give her 2 hours relief, and then 4 hours, 2 hours relief. Whatever your physician plans depends on the patient's need. Again, the patient becomes comfortable. It also allows the person to speak, because even these ones, there are many ways. There are nasal, there are so many gadgets that you can put on to give an invasive ventilation. Non-invasive ventilation also reduces left ventricular afterload. Afterload, what does it mean? So let's say you have a person with pulmonary edema. A person with pulmonary edema, afterload is a force with which the heart is fighting to get the cardiac output to the patient, right? So if someone has got a vasoconstriction, right, peripherally, has got a increased, let's say, of fluid overload, right? So definitely, or someone has got a vasoconstriction because of hypoxia in the lungs, definitely, non-invasive ventilation can actually help you with that. looking at how you can look at it, say the maximum tension in cardiac muscle wall during respiration, best in the folding heart, and especially looking at Laplace law. And when you're giving the pressure, when you're giving the PEEP, actually it helps with the depressing of so for example, if you're dealing with pulmonary edema, it depresses the fluids, and actually the stretching of the heart muscle actually increases, and by doing that, the afterload actually goes down because the pressure that is being exerted actually gets low. In the end, it gives you clinical outcomes. People with the COPD, for example, I would like to, if possible, to not intubate a person with a COPD. If you can avoid a person with a COPD, then that avoiding non-invasive ventilation can help. Let's say you are trying to nebulize a person with asthma and they are tired. How do you think are you going to win that nebulization? The only way you can win is by adding a little bit of ventilation. So you do what we call inline nebulization with a ventilator. So either with a ventilator or a CPAP, you connect with a nebulization mask, and then by doing that, you are reducing the effort of work of breathing, but by doing so, you're also nebulizing the patient. By doing that, this person who was actually tired will be able to get nebulization without the need of ventilating this person, because I can tell you, you cannot give oxygen, you cannot supplement oxygen on a person who is very tired. You have to make sure you assist with the ventilation. People with cystic fibrosis, post-operative respiratory failure, symptom control in the patient, not for intubation, can also be assisted with an invasive ventilation, but not really. It has got it may not actually assist that much. For example, people with, for example, PCP as well, people who have got TB, if at all they are, because sometimes you can have TB with community acquired pneumonia. At that time, you can assist with giving a little bit of assistive ventilation or non-invasive, or the component of ventilation without the need of intubating, because usually we are looking at mortality benefits of doing the invasive ventilation. So during that time, actually you can give a little bit of non-invasive ventilation to while you are actually treating that patient. You can definitely start non-invasive ventilation on ARDS, community acquired pneumonia. But remember, when someone has pneumonia, how long do you think this person is going to be sick? Are you going to put someone on a non-invasive ventilation today and tomorrow remove it for pneumonia? It will take days. My rule of the thumb is, if you think this patient will require assisted ventilation or assisted ventilation more than 24 hours, that person may need invasive ventilation, because they will be tired, because an invasive ventilation requires a little bit of their own effort. If they don't give their own effort, then there will be a problem. So a person with pneumonia, with lobar pneumonia, definitely they will need extended time of ventilation. And from that reason, the consideration or your threshold to invasive ventilation should be very low. So yes, you can give a little bit of non-invasive while you are preparing. My colleague are going to speak about it later, that yes, sometimes your nasal prongs, sometimes your sometimes your rebreather mask may not be of benefit when you have a person with lobar pneumonia. And for that reason is by giving CPAP is going to assist with pre-oxygenation. And by doing that, actually non-invasive ventilation in form of CPAP, or whether it's via a ventilator or via a specialized machine, is going to be of benefit. here there is asthma and there is a COPD, non-invasive ventilation, and especially CPAP and the BiPAP. The outcome has been a little bit meaningful, especially with the use of these methods on asthma. In the ICU, Rina may explain to you how many times he has used non-invasive method of ventilation on asthmatics. Mostly on a stable patients, you can try 1 to 2 hours. It can help, but most of the time, if the progress of improvement is less, then you may consider alternative ways, and mostly is invasive ventilation. When do you consider giving someone non-invasive ventilation? You consider someone with non-invasive as a temporary measure, or with which that you know this person is going to improve with the time. And usually, as I said, for me, I usually put within 24 hours. Pulmonary edema usually takes up to 6 hours or 24 hours to make sure that the people may not be using. From that way, then we can consider non-invasive way. People with respiratory gasping patients, severe muscle fatigue, exhaustion, and severe shock, you may not really consider putting this person in non-invasive. These are kind of patients that need to be in invasive ventilation. You cannot have a person who is GCS less than 10 on non-invasive, right? As I said, they need to cooperate. They need to be with you. They need also to work with it, because they are going to synchronize your CPAP with their breathing. These people, if they are comatose, they may, remember, when air gets in the stomach, the insufflation may trigger vomiting, and definitely these people may actually aspirate. So usually it's a contraindication having someone on non-invasive ventilation if the person is comatose. And many other things. Secretion management. Someone is having, let's say, is bleeding, is having hemoptysis, or is having hematomesis. These are not the people that you want to keep them in the non-invasive, because you cannot protect the airway. So mostly the main way you can look at that, this person requires invasive ventilation modes. Fascial trauma, recent esophageal or gastric surgery are the same. They've got high risk of insufficiency and actual aspiration. So these are not the people that you may want to consider for non-invasive. The other thing that I'd like to speak with you is that when you are setting your non-invasive method, sometimes it is how you start setting from the humble beginnings of your people. The people, you cannot, even if you want to put a people of 15, even if you want to put people of 10, you don't just give the person on a mask with a CPAP with a people of 10. It's going to be very hard for that patient. Start slow. Start with the people of 2, people of 3, in an interval of few minutes. Then they become used to the pressure, and by doing that, actually, it helps. There are contraindication, infectious diseases, risk, potential transmitted respiratory infections. Of course, there are contraindications, but you can see during COVID, we have used a lot of CPAPs. A lot of non-invasive ventilations have been used. Decreased level of consciousness, actually, except carbon dioxide narcosis. If someone has got carbon dioxide narcosis, you can try, but that's going to be in a shorter time, because with time, this patient is going to gain more consciousness, level of consciousness, and be able to expel carbon dioxide. And the other parts of they are not really contraindication, but you can monitor while progressively trying to use non-invasive methods. These are part of the predictors of success. Young people, lower severity of illness, able to cooperate with a better GCS, less air leak, which means get a mask that is actually intact, well fit, moderate hypercarbia, more than 6, moderate acidemia, pH of at least less than 7.35, better gas exchange, meaning that all these things can actually work out. Meaning that the first 1 to 2 hours, if a person who have got a heart rate and respiratory rate, this one actually can work very well initially. These are the people that by using, you don't want to have a person who is very acidotic, and you are saying you are trying to have this person on a CPAP, or the person who has got a retention of carbon dioxide so much, then you think this person can actually work well with the CPAP. So you choose, you are expecting better results. You can try, but you can have better results on these patients when you do have these parameters on hand. So the interfaces, as I said, mask tolerance, fundamental important, acute respiratory failure, oral nasal, mask is preferred. Avoid the tight and comfortable mask fist. Test the variety of mask if necessary. No proven advantage for specific mask type. So there are so many, as I said, there are nozzles, they are the one on the face, but what we need to do is you make a very good fit on a mask, and when you do have that, it means even the way they cooperate with you, the way they can actually tolerate the CPAP or the any form of non-invasive is even better. This is an oral mask. We have them there in the skill station. We're going to look at them. This is that. So this is actually if you look at that, so that one, it looks like it's a little bit bigger, right? If it is big, definitely is going to have leaks. And if you have leaks, then the pressure is going to be affected. This one looks like has got a nice fit. Look at that. This is another form of mask, full face mask. But remember, this is a nasal, only goes to the mask. And you can see there are a couple of advantages you can have. When you have got full face, the patient cannot talk, which is sometimes is better because the pressure builds when the mouth is closed. When they start talking, sometimes the pressure actually leaks, and because of that, actually may not get the benefit. Usually the patient may work well when the mouth is closed. So this is how you apply. Explain to the patient, initiate the non-invasive ventilation while holding the mask in place, that you hold it on the face. As I said, start with a small peep and have the patient hold. The idea is to gain that comfort because things are coming in the face. And remember, most of the time, our patients, the time that when you give oxygen, they will be repairing the mask, repairing everything that we give. So you need to gain their trust slowly. So that's why I said, start with a small peep, have your oxygen dial to a high flow as possible so that you can have it on the patient. And the peep particularly should start slowly. Start with the 2, 4, and increase as such. And then let the person hold, because when they hold, it gives them a little bit of comfort. This is how it goes. Mask placement. There are so many different masks, and then the way you place them, we're going to show it during the skill station. Some people don't like the things on their face. They may actually repel. We do have few of these, and these are the people that you have to be very careful when you are putting the mask on. A ventilator, you can have a CPAP mask flow delivered. We have here that only a flow connecting the oxygen, and the mask is able to give you a flow that can actually generate a CPAP. But you do have the ventilators that are actually CPAP, but you do have ventilators that have got a combination of both. As I said, conventional ventilators in theory have got all. They do have CPAPs. You may adjust things as much as it is, depending on the ventilator that you have. You're going to see these in the skill stations. Most of the ventilators that we have, they are properly designed for trigger mechanism and alarm for closed systems, transition well to exhalation and inhalation only in a closed system. So basically, The ventilators that we have, you're going to see, we do have a couple of ventilators here. We're going to see, and we're going to set for you how an invasive ventilation can be set via our ventilators in a ski stations. Of course, as we say, we do have these ventilators, and it's costly. If you do have two ventilators in your hospital, and you have to use non-invasive ventilation, it means that ventilator is blocked. But you can imagine, ventilator is also expensive. And then we're going to speak about these things in the ventilations. The BiPAPs. We do have these ventilators that incorporate the BiPAP. Usually it's cheaper, compact, and simple to use. They can be in the immediate care units and emergency rooms. They are designed for rapid response to patient-initiated situations, capable of meeting high flow demands and compensating for the larger leaks. These kind of ventilators are, I don't know, Dr. Asha, do you have BiPAPs in your unit? Who has got BiPAPs in their units? Only BiPAPs, or you do have combination of ventilator that can provide BiPAPs? Okay. So the BiPAP directly, it is there. Dr. Ismail, you do have BiPAP in your unit? BiPAPs, yeah. So this is what we are talking about. You do have only BiPAP that can actually work, and sometimes you do have a separate, yes, CPAP. But yes, you can have in the ventilators connected. So as I mentioned, usually no external gas return circuit to the ventilator. They have got non-breathing respiratory valve, unidirectional acceleration system, non-acceleration system that is being attached to these machines. And by doing that, actually, the BiPAP can work as part of an invasive system that you have in your unit. This, we are going to have this during the ski stations, how to initiate non-invasive ventilations. I think we mentioned this before. Titrate frequency to stability every 5 to 20 minutes. Titrate pressure between 2 to 4 with the increment. We're going to have a look at all this. Consider gastric decompressions. How do we have gastric decompressions? How are you make sure? How will you make sure the patient has got gastric decompressions? Nani anaweza kuniambia? Mtafanyaje kuhakikisha kwamba gastric decompressions can be achieved during non-invasive ventilation? Utafanyaje? Huh? Yes? Sema tu. Kwa kawaida wagonjwa hawa wanakuwa awake. Mimi nimekuja na pulmonary edema, unaniambia kwamba niweke kwenye non-invasive. Sasa utafanyaje kuhakikisha kwamba gastric decompression? Unaelewa that gastric decompression, eh? Kwamba kutakuwa kuna air insufficient. This air insufficient actually is going to affect them, right? And they can actually trigger aspiration, right? Because of vomiting. So how are we going to make sure? Hmm? Tutajadiliana kwenye ski stations. Kikubwa, CPAP may be a very new technology. Our patient may not have had it. Maybe the time that you have that patient is going to be maybe the first time. So encourage them slowly. You need to monitor, give them support. As usually, it's going to be probably their first experience. As I mentioned, usually if you're using a BiPAP, use a IPAP of 10 to 19, keep between 3 to 8, avoid excessive driving pressure. Driving pressure is a difference. Another tip is high flow and humidity oxygen therapy dries the airway. So make sure that when you do, make sure that you must connect to humidification, because humidification helps to moisten the nose, throat, and then actually the air leak actually is going to be avoided, or nosebleeds, because unhumidified oxygen therapy usually is not the best way. So mostly use heated humidifiers, nebulizers, and heat and moisture exchangers. Anyway, as I mentioned with the COPD already, they do have air trapped in their system because of their pathology. So remember, there's usually air trapping, and PEEP during inspiration is common. So addition of PEEP to assist triggering the reduced wake of breathing, spontaneous breathing, it can help. This is one of those graphs that you can see expiration. You can see at the end there's an air leak. Troubleshooting, we are going to have a look during skill stations on how we can actually deal with the inspiratory, during inspiration and to expiration phase of resynchrony. How you can avoid air leak leading to inspiratory hang up. This is the other part that we'll look at that. The non-invasive ventilation failure, winning, or sometimes we're looking at failure. Sometimes you win because your patient is actually getting better. When you do have a person with a pulmonary edema and you see the patient is getting better, you don't have to keep ventilating this patient. Actually, you can win. Winning is kind of a step-by-step approach into getting the ventilator out. And they are talking about non-invasive ventilation. Sometimes, if every time you try to win, the person actually gets into hypoxia again, or gets back to the same condition, then you may consider getting to another method of ventilation, and that's going to be an invasive way. Usually, COPD are the best people to think of winning, because invasive ventilation has got higher mortality than actually getting the person only in an invasive way. As I mentioned, non-invasive ventilation is the method of choice for initial management of most of the respiratory failure, as either as a bridge or as a part of management while you consider or while you prepare for invasive methods. Usually, to succeed depends on the patient cooperation, success on your techniques, on how you do the vent, and choice of particular patients. Usually, it requires continuous reassessment and attention to detail. For example, you keep the patient on an invasive ventilation, you have your x-ray done, you get the patient to see, have your blood gas, and then based on the number, you can actually now carefully assess that this person actually can continue on non-invasive ventilation, or I should think on actually intubating. Intubation usually is better when it is early rather than when it is late. So non-invasive gives you a nice bridge to assess the person and make a decision whether you need to give the person into invasive ventilation. Do you have any questions? Any questions? I have not touched high flow. High flow, we're going to discuss it during a skill session. During a skill session, we're going to discuss it in detail on how the use of high flow can help bridging between the low concentration oxygen supplement devices to higher concentration oxygen supplementing devices. Also includes how we can actually use, we can differentiate between low flow nasal cannula and the high flow nasal cannula. We're going to look at it in a skill session. Moise?
All right. That was an amazing talk by Dr. Rama on non-invasive ventilation. Key points that I took away from the non-invasive talk. Number one, that obviously you have to define the same principle. You put a patient on non-invasive, right? There are two types. There is CPAP, which is continuous positive airway pressure. Imagine, have you seen a dog who is looking outside the window? And that pressure that the dog is getting, that's continuous positive airway pressure. Okay, that's how you define it. Then there is bi-level or BiPAP. The BiPAP, there are two pressures. The inspiratory pressure, which controls the ventilation, and the expiratory pressure, which controls the oxygenation. The gap between inspiratory and expiratory should be of difference of 5. So meaning, let's say umeanza na inspiration 10, weka expiration 5, and your PEEP at maybe 5. The gap, if you keep this gap of 5, you will allow physiologically the patient to breathe in and breathe out nicely. BiPAP is very good for ventilation issues, while CPAP is good for oxygenation issues. Okay? And that tiring thing, you should remember it. You put a patient on NIV. If the respiration rate is going down, patient is not tired, that's good. You did a good job. But the respiration rate is going down and the patient is getting tired, please move on to intubation. Don't waste your time. Okay? All right, good. So now that we know we are hungry and food comes first, we have a setup. Okay, it's like take away, take it and come and eat here. Okay, so it's break time for us. We'll give ourselves like 10 to 20 minutes and then we start again. Okay. Okay, everyone here? Are we missing anyone? Okay. So this talk is the cornerstone of airway. If you don't know how to manage basic airway, then forget about intubation. You'll never reach there. Okay, so the first principle in airway management is to manage the basics of airway. Okay. This is how our structure will go. We're going to start with basic airway, then intermediate airway devices, followed by everyone's favorite endotracheal intubation. And lastly, the lung sounds, because it's important to know if the airway is placed correctly or is it in the wrong tube. So it is always a first priority, airway. Like even in primary survey, we know A, B, C, D, E, right? So airway is the most important priority when it comes to resuscitation. If the person is breathing, he has a pulse, then airway should be managed first, then breathing, then circulation, disability, and exposure. Okay? Now, I'll start with patency of the airway. Whenever we talk about patency, okay, what does it mean? It means that there is a pipe, okay? And is that pipe blocked? If it's blocked, the airway is not patent. If it's not blocked, then it's patent. So now how do you know that the airway is patent and protected in a patient who's conscious? How would you know that this airway is patent and protected? So basically, if the person is talking to you, you know exactly this patient is okay, patent and protected. And many people go to until D and they look at the GCS. But in airway only, the GCS is also important. Because if there is a low GCS, then the person will not be able to protect that airway, even if it's patent. Okay? Now, in terms of patency, we are looking at look, feel, and listen, right? So looking at the patient, is he breathing or not, right? Then the hearing part, you're looking at abnormal, you're hearing for abnormal sounds like stridor, yeah, like gargling if the patient is unconscious, yeah. So here we are going to concentrate on mostly a patient who is level of consciousness is low, okay, and they cannot protect the airway. So what do you do step by step until you reach to intubation? So the first thing is you approach the patient, you have your scene safety in check, and you go to that patient, right? The first basic maneuver that many people need to know is two. One is jaw thrust, which is done in trauma patients or medical patients. Jaw thrust. Anyone know what is a jaw thrust? In trauma patient, right? And then we, in the skills session, we'll learn more. I'm just going to talk about it. And then there is head tilt, chin lift. But do you know that there is a third maneuver that you can do in order to enhance your opening of the airway? It's basically, it's not that rocket science, it's just a combination of the two. You do a jaw thrust and a head tilt chin lift on a medical patient. And I'll guarantee you that will open your airway. I've done it many times, but in that point, you will need an extra person who will help you when it comes to bagging. Okay? So first thing is open the airway. The next thing is check the chest. Is it moving or not? If the chest is moving, then at least the person is breathing. Okay? In terms of the obstruction part, what is that one thing that obstructs our airway most commonly if the person is unconscious? The tongue. See? So tongue is the most common way of obstruction. You will see a person gargling like or snoring. And then as soon as you do head tilt chin lift, the snoring is gone, right? So what is the next step? Are you going to keep that patient in that head tilt position or you're going to use something else? What airway agents will you use? So there is oral pharyngeal airway and nasal pharyngeal airway, which you can use, right? So when would I not use the oral pharyngeal airway? So gag reflex is present, we will not use the oral pharyngeal airway, right? What about nasal pharyngeal airway? When would you not use a nasal pharyngeal airway? Says? You know, this is like that, like I'm asking a question. Okay, so basically you're saying? So base of the skull fracture would be something that I have seen an NGT going to the brain. So please don't avoid the NGT and avoid the nasal pharyngeal airway in a base of the skull fracture because it can enter the brain. There is an opening and that opening can allow the entry of the nasal pharyngeal airway. Okay. So this is the chin lift. As you can see, the person is tilting the head and lifting the chin. Yeah. Opening the airway and allowing patency. Now let's say if this doesn't work, that's when you go for your oral pharyngeal airway or nasal pharyngeal airway. This is the jaw thrust. We will learn about it in the skill station, but simply you are thrusting the jaw forward and then lifting that chin part. Okay, and that's how you can. Now if you combine the two, you get the maneuver, the triple maneuver, which is basically a modified jaw thrust. So you do jaw thrust and head tilt chin lift, and if you have another person, it will really help you open that mouth. So suctioning. Now those are the interventions in the airway. The first intervention is if you see gargling, someone is like, gargling, you know the sound of suctioning, right? Like, the sound of secretions. If you hear them, you should do suctioning. Now, one pro tip, if you're doing suctioning, right, you will also know if the person has a gag reflex or not, right? So if you do suctioning and the person, that means he has a gag reflex. But if he doesn't have a gag reflex, that's your cue that, hey, guy, prepare for intubation. Hey, nurse, prepare for intubation. That's how you go about in terms of suctioning as well. In terms of suctioning, I have nurses here. How do you suction a patient? Like 3 important points to tell me.
Sorry, can you repeat the question? When the patient is having an ETT, oh. On ETT, we are using this suction protocol of normal saline and the tube. So you insert the tube on ETT, you put a little of normal saline, then you suck. In the tube, kuna kama kale ka plug ambako you have to kukiziba ili kiweze kuvuta vizuri. Yes.
In the suction catheter, there is a hole to the end. So when you rotate, it is be easier for the secretion to pass in the suction catheter.
So there are techniques of suctioning. The number one rule is 10 seconds and not more. Okay, you need to look at the saturation of the patient. If the patient is tubed or on a mechanical ventilation, every mechanical ventilation currently has that button of suction. If you press that button of suction, immediately saturation goes to 100% on FiO2. At least that way, you will prevent hypoxia during suctioning. Okay? Now, in terms of suctioning, there are different devices as well. Okay, which is rigid suction. Then we have the soft catheters like the suction catheters. Okay, so you need to know that which one will you use on which situation. If there are food particles, there are certain types of suctions that I'll show you in the skill station. It is so big, it's like this big. Okay, but what anesthesiologists, because we don't have it in our country sometimes, they use the pipe itself. I don't know, is it true that you guys use sometimes the pipe itself for big, large particles? Yeah, it's not advised, but it is what it is. We have to improvise in terms of where we are at, right? So you can do that with the suction. This is the Yonka that I was talking about. Like you can vomitus and so forth, you can use it in terms of that. This is a simple, it's Yonka. This is a dental tip, sorry. This is the Yonka. Now we talked about OPA and ANPA, and the take-home message is OPA, don't use it for a person with a gag reflex. Nasal pharyngeal airway, don't use it for someone who has a fracture of the base. Okay. All right. So let's say this patient now who is desaturating, you kept them on oxygen, you did the head tilt chin lift, you kept them in oral pharyngeal airway. On the skill station, we'll show you how to put the oral pharyngeal airway as well as the nasal pharyngeal airway. So let's just focus on the steps of going through this airway management. So you put the oral pharyngeal airway and still your saturation is not rising. Okay? And you see the breathing is not also good. What do you do next? Saturation is not rising. You have given enough oxygen. You have maintained the airway. You have suctioned the patient, but still the patient is not improving in terms of breathing. What do you do next? And this is an unconscious patient, so it's contraindicated to use non-invasive ventilation. What do you do next? Before intubation, you bag the patient, right? You do bag valve mask. Now, many of you want to do it alone, but please, if you have 3-4 people, do it together, right? You all know the C and the E technique of bagging, right? So if you use one hand, C and then E, right? For the jaw, and C for the seal. When you do that, you do head tilt chin lift and then you start bagging. Now imagine if you do both together. You do 2 hands CE technique and then you do head tilt chin lift and allow someone else to bag. You are going to get better chest rise. And when you are going to have a chest rise, if you see the chest rise is enough. Many of you or many of us, me even guilty, when I'm panicked, I do this, which is not right. Because if you look at the bag valve mass, right? That one bag, you know how many liters it is? It's almost 1.5 liters. Do I need 1.5 liters? Me. I have maybe an ideal body weight of 65. Times 6, how much do I need tidal volume? 360. And now you're giving me 1 liter. Why do you want to kill me? What will happen is that excess amount of air, two things will happen. One, air will go into my stomach. Yeah? And it will force the vomit to come out and aspirate into the lungs. Now you're causing aspiration pneumonia, which I didn't have. Number two, that excess amount of air is going to increase intrathoracic pressure. When it does that, what will happen to my heart? That increase in thoracic pressure will squeeze my heart and prevent it from refilling. So now I'm getting into hypotension because of the excess amount of air that you're giving me. So that's why we are preventing that. So when you're bagging, just bag until the patient, you see chest rise. If you see chest rise, that's good enough. All right? Okay. So I've already talked about the complications of Jonas, can you call Valentino and ask what's going on? So the intermediate airways now, all right? How many of you have used intermediate airways, like laryngeal mask airway? Have you seen a laryngeal mask airway before? How many of you have used it? You have used it. When do you use it? So in pediatrics. So basically to secure the airway, instead of intubating, you use the laryngeal mask airway, right? So laryngeal mask airway is basically a type of airway, a supraglottic device, meaning it sits at the larynx, okay? It can be done by anyone. It's a blind form of airway. So you just insert it. We'll teach you in the skill station. Just insert it until you get resistance. And that way you can buy time for those difficult intubations, for those difficult to ventilate patients, which we are going to learn about in the next lecture. So when you have that, you can use that. I have used it even in cardiac arrest. Sometimes, you know, in cardiac arrest, it's difficult to find that hole and tube the patient. So you might just put an LMA and save yourself time. Okay. What is that number one rule? That if you have an LMA or an ETT tube inside the patient, how would you bag the patient? After how many seconds would you bag the patient? How would you bag the patient? Any patient, normally. How much would you bag them? Like after how many seconds would you give another breath? That's the question. How many? Just say a number. 6. After every 6 seconds, you would bag a patient if it's an adult? Yes or no? So this is what I'm trying to ask. Is like, let's say I'm bagging the patient. Okay, 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6. So would you want to do that in an adult patient, or 1, 2, 3, 1, 2, 3, 1, 2, 3? How would you want to do it? 6, right? So in adults, every 6 seconds. If it's a child, every 5 seconds. If it's a neonate or infant, every 4 seconds. If it's a neonate, every 3 seconds. Okay, that's also very important to remember. Many of us, we are bagging, but it also depends on the clinical situation of the patient. So if the patient is tachypnic, and if you bag for them slowly, they will not tolerate. So you have to bag according to the patient sometimes. Okay? All right. So when you put a laryngeal mask airway, do you guys think that you're protected from aspiration? So it's not a definitive airway, by the way. Laryngeal mask airway is not a definitive airway. The definitive airway is only ETT and a cricothyroidotomy or tracheostomy. Those are definitive airways. And there you can be rest assured that at least 90% of the times you won't get aspiration. There's a 10% chance you can get micro aspirations. Okay? So this patient of ours, maybe you were not keen on intubating, so you put a laryngeal mask airway on the patient and it's tolerating. And now you're bagging, okay? That's when you will be waiting for your senior to come and probably intubate the patient. So this is the LMA that we are talking about. Okay, you see how it's inserted? It's inserted blindly. And this part over here is the one which is kept on the larynx part, okay? The complication is that even if you have this LMA, you are not going to be safe from aspiration. The patient can aspirate, can vomit, and you can get aspiration pneumonia, even if you have put an LMA here. There is significant leak around the cuff and can occur if there are high airway pressures, such as in asthma or COPD. Okay? Now, there are other types of tubes that you need to know. They are considered as combi tubes. But for this airway class, let's remember there is LMA and then there is ETT. I don't want to complicate matters because you will never find in our shop. I don't know if Janset Healthcare, do you have combi tubes which are like LMA? We don't, right? So let's not talk about them, but stick on to the LMAs. And after LMA, the definitive care is ETT. So these also are put blindly. You can see this is a combi tube, okay? One is for the esophagus and one is for the airway. So you can try and test. So you put the tube in blindly, and then you put the bag and you test which one is allowing chest rise, and that one is in the airway, and the other one is in the stomach. So you know exactly, like this one, this air is going into the stomach, this air is going into the. Like if you look at here, this tube, one of them is going to the stomach, and one air is going into the definitive airway. The placement is same thing. You just put blindly, okay, and you balloon the tubes. You balloon the two balloons, which it has. Here, these are the way you balloon it with the recommended amount of cc's, and there are different sizes as well. Now let's go to the tracheal intubation. Can we know what are the indications of intubation? What are the common indications for intubation? No, common mic. What are the common indications for intubation, guys? Don't worry, naleta mic for those who don't want to. So low GCS of how much? Less than 7. Okay, sawa. What else? Less than 8. Some books say less than 9, some books say less than 8. It's still in debate. Okay, but it's a correct answer. What else, Harris? Sasa nataja majina. Iwe EMSA wameweka nani name tags, I have to use them.
In airway obstruction.
In airway obstruction, like what obstruction?
Maybe a patient had trauma
Okay.
maxillofacial trauma. So
Mhm.
it's another indication for intubation.
Okay. Eh? Limeweka hapa lakini watu unashangaa.
If there's failure in ventilation.
So failure in ventilation, all right? So basically a person is getting tired, you can see them. Would you rely on the ABG or would you rely on your eyesight and say that this person is getting tired? Would you rely on the ABG, the arterial blood gas, that this patient is failing to ventilate, or would you rely on your physical examination? The physical examination. First physical examination, second would be ABG. Why? Because it will take time for CO2 buildup in the ABG. But with my eyes, I can know this person getting tired, I want to tube in. Okay? All right. So failure to ventilate, failure to protect the airway, like he said, GCS is low. What else? What is our patient suffering? The one that I talked about, that oxygen is not rising. Failure to oxygenate. That's one of the indications. And the last one, or two of them, there are two more. There are two more. In a burn patient who has facial burns, maybe 80% burn and majority of it is the face. Why do we intubate such patients while they are talking to us? Yes, anataka kujibu. Anataka kujibu.
There's a possibility laryngeal edema.
So laryngeal edema, right? So it could be angioedema because of allergic reaction, or it could be burns which is causing the laryngeal edema, or we could have those trauma cases whereby there is a knife here. There is a very good picture of, famous picture of Dr. Ismail on our slideshows, whereby there is a stick going through here and coming out from here on a very thin, timid African guy. I don't know, he will share the story later, but they intubated this patient because of they were fearing that this is a threatened airway. So if you have a threatened airway, if you're failing to oxygenate, if you're failing to ventilate, if you're failing to protect the airway like low GCS, then you would intubate the patient. But there is one more. And that one more depends on the specialist. If the specialist is feeling that I'm anticipating clinical deterioration of this patient, maybe I have a septic shock patient, the liver is failing, the lungs are, the kidneys are failing, and this person is struggling to breathe, I would intubate early. Even though there is no failure of ventilation so far, no failure of oxygenation so far. So sometimes this clinical gestalt of the physician would say, no, I want to intubate. Some other indications would be a patient who is anxious, fighting us, has head injury, GCS ni kama 11 out of 15, and you want to take them for a CT scan. Do you think this patient will atatulia? No, right? So it's better to tube these kind of patients. If you're transferring this patient from Moi to maybe America or somewhere, you need to tube those patients because they are high-risk patients. So sometimes we do that even on transportation. We would tube the patient just to maintain their safety. Okay, so there are two types of blades, as we know. There is the curved blade, Macintosh. Macintosh has a C, so it's curved, okay? And the Miller has L, which is straight, okay? So the Miller blade is straight and Macintosh blade is curved. But I would use the Macintosh for all situations, for adults and pediatrics. If you're used to one of the blades, just go with that. Don't change the blade just because it's a pediatric patient, right? Anesthesiologists wanapenda hiyo blade, right? Yeah. Bado mnatumia? Okay, good. All right. When it comes to intubation, there are a lot of things that are important, but on practical aspects for the nurses, use the mnemonic called SOAP ME. Okay? The mnemonic goes like this. S for suction. Okay, so you need to make sure that the doctor has all the equipments of suction. From the Yonka, from the catheter, is the suction working? Like in, some hospitals, the suctions are not working, right? So is the suction working? Oxygenation is very important. Is the oxygen working? Do we have full tanks of oxygen, right? Airway device, are all my airway device there? OPA, nasal pharyngeal airway. Do I have my ET tubes? Do I have my bougie? Do I have my stylet? Do I have my video laryngoscope? Do I have my direct laryngoscope? Is my direct laryngoscope working? That also comes in the airway. Then P is person. If you're not confident in intubation, don't intubate alone. Intubate with someone who's senior. So if I had a difficult airway, I would wake Dr. Ismail even at 4 a.m. at night, and I'll say, please come, this is a difficult airway. You understand? Okay? So in airway, I would go for that P for person, P for positioning as well. Many of us, we like the coffin position. You know the coffin position? Lying the person straight, flat. Why would you want to kill that patient before even starting the intubation? The patient is failing to oxygenate. It's better the studies are showing that it's better to keep them in the 30-degree position right now. Okay, why? There are 3 reasons why. 1, you're avoiding aspiration. Number 2, you are allowing oxygenation and ventilation physiologically. And number 3, you can see the view properly. When you are while lying them flat, sometimes the positioning is not good and you will not see the glottis properly. Anesthesiologists are very good at positioning the patient. They will put ramping here on the shoulder and the neck and make sure that this tragus is aligned with the sternal notch. And you should also do that even in an emergency situation, so that when you intubate, it becomes easy. So position is very important, okay? Then the P also stands for pre-oxygenation. How do you pre-oxygenate the patient? Anyone who has intubated before? How do you pre-oxygenate? How do you pre-oxygenate the patient? Anyone who has intubated? So you open the airway, 100% oxygen, and you start bagging the patient, right? That's pre-oxygenation. All right. Any other way that you would pre-oxygenate the patient? Let's say if the patient's breathing is not a problem, it's the oxygenation. How would you pre-oxygenate them? Any other way? Can you use non-invasive ventilation for pre-oxygenation? So current studies are recommending that we can use non-invasive ventilation for pre-oxygenation, and it has a higher chance of your patient not going into hypoxia wakati unamintubate. So some people even use non-invasive, and it's very nice. You know why? Because if you use non-invasive, you get parameters on the vent. You get how much tidal volume they need. You get how much respiration rate they need, and you can set it once the patient is intubated, okay? So non-invasive ventilation can be used, high flow can be used, okay? And you can even put nasal cannula while you are intubating so as to give them apneic oxygenation. So basically, you're trying to oxygenate them even when they are being intubated. And trust me, if you do this, hypoxia will never be an issue, because you are already giving enough oxygen to these patients. So then it comes to M and E. There is medication and equipments, right? Medications, sedation first, and then paralytics. Okay? Which sedations would you use? Mention any. Ketamine. The ones which are locally available here, just mention them. Propofol. What else? Yeah? Midazolam. Yeah. What else? Okay, let's shift to paralytics. Which paralytics would you use? Atracurium, suxamethonium, right? So sedation first, then paralytics. Dr. Hoki had a story for us. He always used to mention this patient who was not sedated, but paralyzed first. And the patient was awake during surgery, in terms of the patient is paralyzed and half sedated. And when the patient woke up, or when the patient was revived after the surgery, he said that I could feel everything because they were not managed the pain. Pain was not managed and the patient was not sedated properly. So please, sedation first and then paralytics. Yeah? Okay. And in terms of medication, also remember pain medications like fentanyl. Don't just sedate a patient. If you're using ketamine, fine. Ketamine has analgesic properties, so it's okay. But if you're using midazolam and then you are paralyzing the patient with atracurium, why are you not giving pain medications? You think the patient is not feeling pain? So you need to also add pain medication. It could be paracetamol, it could be tramadol, it could be fentanyl, whatever you want to use. Then in terms of equipments, the tube size, how would you know which tube to use on which patient? Men, women. Is there a particular size we should go for? Does it matter? Okay, let's mention numbers. Men, which size of tube would you keep if you wanted to tube a man? Hi, now pick son up. Yes, tell me. Yes. Which size of tube, ETT tube, would you use for a man? 8 to 8.5. Okay. Anyone else? 8 to 8.5. Matthew. 7 to 9. Okay. The nurses who are preparing patients for intubation, tell us. Okay. So basically, the rule of thumb is that whatever size tube you are choosing, have a lower size and have one size up. So for example, if I'm using 7.5 for a male, I will have 8 and I will have what? 7. If it's a female, I might use 7, 7.5, and then 6.5. But then again, if you're going in, this is what you will see. If you see the glottis openings big, you can even ask for an 8 and you tube the patient. And it could be a female as well. So look at the size of the glottis. Don't just rely on because it's a male or a female, but just have this standard approach of having one size up and one size down. Okay? All right. In terms of equipments, vent should be set up already. Oxygen is working on the vent and everything else. In terms of equipment, check your equipment. Laryngoscope, is it working? Many times the nurses are clever. They put the batteries upside down for us. So then you're saying, laryngoscope is not working. Kumbe, it's working. It is working, it's just the batteries are upside down, right? So let's have that kind of notion, okay? And if it's a difficult airway, if you think it's a difficult airway, which we'll talk about, have a cricothyroidectomy set. And what you only need is you need a blade, you need a bougie, and you need a 6O ET tube. If you are in a limited resource setting, you don't need the Shallies and all that, but you just need that tube and you can do a cricothyroidectomy, which we'll also talk about. All right, so you have checked your equipments. For example, you have checked your ETT cuff for leaks. How do you do that? You just fill air on the cuff and see if it's working or not. You need to know, you need to have your stylet and your bougie. I will teach you some skills with bougie that the bougie can be used like a stylet, okay, when we are in the skill station. Lubricate the top and the cuff of the tube. If the patient's airway is dry, remember it will be very difficult to pass the tube. So sometimes lubricating it is much better. Put the patient in sniffing position. Sniffing position is like this. So let's say if you give me flowers, right? If you give me flowers, I'm going to do this. Yeah? But if you give me something smelly, I'm going to do this. So this is bad sniffing position and this is good sniffing position. So it's extension of my neck like this. Okay, and remember the tragus to the sternal notch is supposed to be aligned. So if you have to put pillows here, put pillows here. Prominent upper incisors. Now this part I'm not going to talk about it because someone is talking about difficult airway in terms of anatomy. So you just by physically looking at the patient, you will know that this patient is a difficult tube. How would you know? Tell me. Just by looking, don't forget the mnemonics, forget everything, just by looking at the patient. Short neck. Who has a short neck here so we know? Oh, sorry. It's okay. Short neck. What else? Old people, right? Dentations problem. Yeah. What? Facial trauma, pregnant women. All these are they're difficult intubations at the end of the day. Okay. So there are so many of them. There are so many mnemonics. Lemon. There is bones, which is for ventilation. There is lemons for difficult airway. But in emergency situation, you might even not even have time. Every airway in emergency is difficult airway. So prepare for it like that. Okay? Or every airway, whether it's easy or not, just prepare for it like as if it's a difficult airway. And if you can use bougie all the time, then use it. Okay, it doesn't matter. There are some people, they are out there who will say, why using bougie? This is not difficult. But I use bougie all the time. And it allows me first pass success 98% of the time. And this is also based on research. It's not just me. Okay, so this is what I was talking about. What I rely on is the tragus to the sternal notch, okay? And this gives me a positioning that if I put my laryngoscope in and I lift, I will see my glottis immediately. I don't need to do anything else in this case. So we all know the steps, right? The steps will be more of a skills, so I'm not going to show you anything, but I will talk about a few things. The first thing is a laryngeal handshake. It's like, for example, if you're tubing the patient with the left hand like this, right? You can use your right hand and provide some movements, okay? Backwards, rightwards, upwards. And you will move the glottis towards the point where you can intubate easily. And you can even sometimes see the glottis if you do that. So you do this, and then you tell your assistant to hold it in that position, and you can tube. So that's one thing that you can do. Another thing you can do is you can lift the head of the patient. Sometimes you have not positioned the patient properly. So if you lift the head, you will see the glottis in view better. And especially in video laryngoscopy, you might have to sometimes lift the head so that that tube can pass easily. Okay? Some people even use two hands. So they use two hands to lift that epiglottis and then direct the force on the left hand. So I'm doing this, okay? And then I'm holding it with the left hand, right? And then if sometimes if you don't see the epiglottis, right? If you see the epiglottis is hanging like this, and it's not just lifting up, you just lift the whole epiglottis. Instead of going to the vallecular area, you go to the epiglottis and lift it completely. That also will allow you to see the glottis better. So here is the proper use. So basically what he did is he went to the right side. This is direct laryngoscopy. So went to the right side. He lifted the tongue to the left. Then he goes to the epiglottis area. Okay, this is the epiglottis. So this is my epiglottis, and this is where I will take my blade. And then I lift my blade like as if I'm lifting towards the ceiling. And this way it will open the glottis area for me properly. And this is the vallecula, as you can see, it's lifting the vallecula straight towards the ceiling. Like you have to make sure that, okay, this is my point. So I'm going to point and lift towards that area. The passage of the ETT tube, please guys, if you look at the ET tube, right, there is a black line. Yeah, there's that black line, I will show you. If that black line is passed, you are already in the carina. Okay, and another way of knowing it is just take the ETT size times 3. And you know this is the distance from the lip where my ETT should be there. Okay? All right. So the securing or positioning 3 times the ET tube. So men is 23, women is 21 centimeters. But what I would use is 3 times the ETT tube size. Okay? There are so many anatomical factors in kids leading to increased complications, which we will talk about it in other lectures as well. Conformation of the ET tube. How many of you have end-tidal CO2 in your hospitals? How many of you have end-tidal CO2? Okay, our hospital has end-tidal CO2. We have capnography, which gives us a waveform, and that can help you confirm the ETT. There is a device which we have. It's purple, and then it changes color to yellow if you're in the right airway. Okay, so that also can be used. You visualizing as a person that it went into the hole. If you have video laryngoscope, then everyone else can even confirm that you went inside the right hole. Okay. And then 5-point auscultation. So first you start here, you bag and start here. If you hear breath sounds, that means you're in the esophagus. But then you go here. And if you see bilateral equal air entry, then you know you are right at the tip of the carina. And that's where your ETT should be there. In terms of X-ray, you can even know where the tube is. So if you do an X-ray, you will exactly know 5 centimeters from that carina, the bifurcation of the carina. That's where your tube should be. And you know that you are in the right position. So, all right, these are the devices that I was talking about. End-tidal CO2 detector. It changes color from purple to yellow. Yellow means carbon dioxide is present. We have complications, right? Some people are new to intubations. You will break the teeth. It goes inside the mouth. Yeah. Something like you can even injure the oral pharynx. Yeah. You can tube the patient in the esophagus and they aspirate and causes aspiration pneumonia now. So these are some of the complications. You can even get hypotension after intubation because of those drugs that you're giving. Okay. Or intubation itself can cause your sympathetic drive to go down. Yeah. So remember that we'll be talking about it in terms of physiological airway and difficult airway, where you will know more why intubation can kill a patient instead of saving them sometimes. All right. So nasotracheal is simply that you are going through the nose. Okay. This is something out of the scope of this section, but I'm just going to briefly talk about it. So this is the nasotracheal coat on the arytenoid, meaning that it is caught on this lower part, okay? And when you twist the ETT, you will be able to enter. So this is one of the main problems that newbies they get, is that we are entering and it's not going in. And when they twist the ETT, they will go in. So sometimes you have to rotate it clockwise so that you can go in easily. So the patient was intubated into the brain. Maybe the patient had a basal skull fracture and this guy went through the nose to intubate the patient. These are some of the things old schoolers used. I don't know if they still use it. Have you intubated with a finger? So people can tactile stimulation, yani unaenda kwenye epiglottis, una lift, and by feeling you enter the, yeah. So previously, it's just interesting, I kept it there. This is how they do it. As you can see, he goes in. This can be done in pediatric patients, but I would not recommend it. Yeah, thank you so much. That was me. Any questions? All right. Any questions, guys? Au nimewa exhaust. All right. Think. Yeah. Let me speak to our boss here. Yeah. To provide video. Video with the whole lecture, we can provide that. Sababu tunairecord hapa sasa hivi. Usijali, tutaongea vizuri mimi na wewe. Yeah. Sawa. Okay. Nani Arina iko? Anayo nani? Ram. Anayo PowerPoint yake? Wapi? Yeah, nimeshaongea hiyo. DSI hapa. Okay. So as we're waiting for the next presenter, let's have some questions. Okay.
Okay. Kwenye package yako uliokuwa nayo, angalia ndani kuna checklists. Mnazo? Angalia hizo checklist. One of the checklists, there are two checklists. One of the checklists talks about how you prepare for endotracheal intubation. Have you seen it? Mayona? Yeah. No, we are looking at the other one for preparation. This one. This one. That one. There are two pinned. Two pinned. Yeah, this one is one.
Me do? Okay. Sure. Oh, okay. Hello. Okay. So we're just going to go through. Everybody's got this in their hand, the checklist. Yeah. Okay. So this is probably one of the most important things. Can you all hear me? Okay. This is probably one of the most important things to go through before you intubate anybody in the ICU or the emergency department. Okay. This is not theaters where everything is set out and everything is very controlled. Anybody you're intubating in ICU or in the emergency department is sick. and you don't have a lot of time. So you want to make sure that you are preparing for every scenario. You've got every equipment you need, because once you start, you give the patient the drugs, and then you realize you don't have the equipment, you're going to be in trouble. Okay. But this is what we use, very similar in our ICU. I'll show you mine on my slide, but this is from the UK Intensive Care Society. So you want to make sure that your patient's drip is working, you've got some fluid running. You want to make sure that whoever is going to intubate the patient, it's a teamwork. Nobody can do this on their own. So you need at least probably 4 people. We usually have 4 people at least. One is the intubator. One is the person assisting the intubator. So between the intubator and their assistant, you need to have made sure they've assessed the airway. So like, Dr. Moyes just said, you want to look at the mouth. Does it look difficult? You want to look at the neck. Have they got dentures? All those things. And it can easily do it in a couple of minutes. If your patient is obviously unconscious, you can't really open their mouth and have a good look. But you can look at their neck movement. Are they big? Have they got anatomical problems on their face that you think might be difficult? Okay. And then you decide. Now, if your patient is being intubated for hypoxia, they might well be on NIV or high flow already. Okay. If they are, pre-oxygenate. While you're still preparing, turn up to 100% oxygen. Okay. If they're on NIV, set everything up and just, while you're preparing, leave them on NIV. So most of us will pre-oxygenate on NIV or high flow. Okay. And then you want to make sure that your patient's position, so physiology. So make sure you've got blood pressure support. Most of our sedatives we give is going to drop the blood pressure. So have they got some inotropes ready or vasopressors? Have you got a nasogastric? Put it on free drainage, aspirate the NG, make sure your suction's working. And obviously it talks about allergies. How many of you use succinylmethonium here? Not very many, a few. So yeah, make sure, you don't always get a potassium level in time. But if you're really concerned their potassium might be high, use another drug. But for most patients, succinylmethonium's fine. Okay. Then there's the equipment column. Have you got all your equipment? How many of you here said you had end-tidal CO2 in your hospital? Can you put your hand up? Nobody. Okay. All right. So obviously for us, that's one of the most important things. So you've got to make sure whatever your absolutely essential monitoring is already in place, especially blood pressure and SATs. So we talked about 2 tracheal tubes here. Often you want to size up or size down. And, sometimes you might want 2 of the same as well. There's a lot of equipment on here, and most of it, you don't need to have it all open and ready, but you need to have a trolley which has that equipment in it. You need to know where it is if you need it. Okay. And then draw up your drugs, whoever's doing drugs. So we have an airway person, an airway assistant. Then we have a drugs person, and that's number 3. And then the 4th person is usually either the team leader who's just overseeing everything, who's also going to help with front of neck if needed, or do the cricothyroidotomy if needed. Or we have a 4th person who is watching the monitoring and just keeping an eye on everything. Okay, so we generally have 4 people. So look at this, they talk about roles, and they might have more in this team than we have, because we don't always have that many people. But make sure if you're in that room, you have a role, and you know what your role is. Okay. So, like I say, usually 2 intubators, a team leader, you need at least 3, and somebody who's doing drugs. Okay. So 4 people at a minimum. If you're, like I say, for us, we always prepare what our airway plan is, which comes in the final one. Just know that your role, who am I going to call for help if I can't manage? Now, some of us are not going to be anesthetists. So how do I go an anesthetist or anesthesiologist, as you call it, if I need to? And then the final one is we usually go through the airway plan with the whole team. So now everybody's done their individual equipment, their drugs, everybody's got everything ready, and now we're about to start. We've positioned the patient, when they call in that, sniffing the morning air or coughing position, you're happy with your patient. We always intubate head up, so 30 degrees is a good amount. And then we go through the plan. Everybody is listening and it's quiet. We try and keep it quiet. What is our intubation plan? So I will say my plan A is going to be, I'm going to keep an NIV. Then once the drugs are in, the patient stops breathing and I'm ready to intubate. NIV comes off. I go laryngoscope. I'm going to go bougie. I'm going to go tube. Okay. But if I cannot, can I have a Goodell? Can I get somebody to help me with bag mask? If I still can't do that, can I have a laryngeal? So usually we'll say, this is my plan A, my plan B, my plan C. Whoever's my assistant knows, everybody in the room knows. Okay. And then our final point is, if I'm struggling with plan A, as I'm going to plan B, can somebody make the phone call to anesthesia to come and help us? Because you'd rather have them there early and not need them than call them too late. Okay. And I say, if I'm heading to plan C, I want the cricothyroidotomy kit being opened, the person who's going to do it ready to do it. And my plan C fails, we need to all move on to plan D, which is the neck. Okay. So we go through all of this before we even start, and everybody already knows. And then we make a start. Is now in every ICU, in every emergency department, everybody has a checklist. If you go online, there's probably 1,000 out there. Every hospital has their own. This is a generic one, but it's quite good and it covers everything. Okay, so I will briefly put ours up when I do mine, but I think it's really important that if you don't have one in your hospital, this is a really simple thing you could do to just make intubation safe where you are. Okay, any questions on this? Good. All right. I'm going to pass on to the next speaker. Yes. Yes. You might have to speak up.
It says here, can we wake the patient if intubation fails? At what point do you apply this?
Yeah, so if I'm intubating in ICU, I'm intubating because my patient needs to be intubated, because either they're a hypoxic respiratory failure and they're too tired, or, they need urgent intervention. Usually I don't have a choice and I have to intubate the patient. We don't generally just intubate for no reason. And often the answer is no, I can't wake the patient up. So, but if you're in theater and it's an elective operation or semi-elective, yeah, I'm going to wake my patient up. I don't need to go ahead. Yeah, because safety is obviously more important. So we have that discussion. And if it's a really sick patient, this is we often don't have that choice and we have to just go ahead. So waking the patient up is not really an option for us, generally in ICU. Yeah. But it's good to have that quick discussion. Okay. We'll pass on. Asher, you're next. Wonderful.
Hi, guys. Can you stand up? Hey, good afternoon. So you can have a seat, please. So we have discussed regarding rapid sequence induction, is it? Once you want to intubate your patient, like in emergency situation or in those patients where you think they have full stomach. So you do rapid sequence induction. So now we are going to discuss on delayed sequence induction, not rapid sequence induction. So which patient, what type of patient do you think will be candidate for delayed sequence induction? ukitaka. Sorry. Au So when you say delayed sequence induction, what we mean? How do we differentiate from rapid sequence induction? Yes, please.
So for delayed, it's usually for patients who it be difficult or sedating the patient. So if a patient probably is too agitated or altered, so you cannot properly pre-oxygenate, you first sedate them and then pre-oxygenate. That's what delayed
Sequence induction. So exactly that if we go for rapid sequence induction, it is more dangerous for those patients. So we have to delay. You can give hypnotics and they take your time, you pre-oxygenate until you are comfortable. The patient is a bit proper for intubating, then you give muscle relaxant, and then with that giving oxygen, or we call apnea oxygenation, then you have few minutes and you can intubate comfortable. Okay? So safe apnea, we have when the patient saturation, duration of apnea until the patient reaches saturation is 88 to 90%. 90%. That below that is not safe. And there are patients who have increased metabolic demands or patients with shunt. These patients, they just desaturate earlier. So you have to make sure they get well oxygenated before you go to give paralysis in order to intubate these patients. So if you observe in this curve, oxygen dissociation curve, sorry. It's working. Yeah. At this side, you have oxygen tension. And this side, you have saturation of hemoglobin. So at the flat part of the curve, where the saturation is between 90 to 100, any drop of oxygen tension up to this level, you are in safe. So if there is a drop of oxygen tension, still you have time to intubate your patients. So you keep on oxygenating your patient, even if your patient is not ventilating. But the oxygen still diffuses from the alveolar to the blood. So you have reserve oxygen. Before the tension drop, to this level. You see, at this level, the acute drop of the saturation. That means hypoxia to the tissue, as we have discussed in earlier presentations. So the advantage of this delayed sequence intubation, you have ample time to oxygenate your patient. Even your patient is apneic after giving hypnotics. But because you have not given muscle relaxant, now even after giving muscle relaxant, still you have this reserve. So you can intubate in a relaxed way. Okay? So as I asked you, which type of patient can be get DSI, as you have mentioned, patient with unobtainable vital sign, patient with head injuries, psychotic patient, patient with head which has lungs but bad brains, and patient with COPD, pneumonia, ARDS, hypoxic, bad lungs patients. So the basic for delayed sequence intubation, you have delirious patient with hypoxia, then you give small dose of hypnotic, you can give ketamine, or if you have said propofol, small dose, and then you pre-oxygenate your patients. Either without CPAP or with CPAP, if the oxygenation is difficult. And then after two or 3 minutes, then you give paralysis. So there is delayment in difference with the rapid sequence induction. Usually we pre-oxygenate, then you give hypnotic, you give muscle relaxant, and you intubate. So the difference here, you have ample time, you pre-oxygenate. And you have sometimes, if you have to give another dose, so you have chance after pre-oxygenation, before giving muscle relaxant, to increase the dose of hypnotic. And then you give muscle relaxant, and lastly, you intubate your patients. So in this case, we have a patient, 44 years old, with minute volume, with possible head injury, maybe with the use of cane, resisting all EMS intervention. This patient arrived at a trauma room, no monitor, no IV, and you have to intubate this patient. So traditional approach is this way. Now for DSI, what can we do? You can use your chart or checklist. What can we do in this type of patients? Okay, so that is the delayed sequence intubation. You put the IV, and then you give the 1 milligram per kg ketamine, and then you place the monitors. You allow the patient to pre-oxygenate with spontaneous breathing or non-rebreathing bag. Then you can even give more, 1 milligram ketamine, repeated, once you are comfortable, and then you give muscle relaxants, and then you can intubate your patient in safe environments. Is it okay? No, let's go to the next case. You have elderly patient, 8 years old, with the COPD, confused, agitated, saturation is 85%. How will we go with this patient? Traditional approach, we go in that way. We give IV etomidate, succinylcholine, and then we intubate. But if the saturation drops precipitately, and then what will we do? What is the alternative? Yes. You have your checklist, please. What will we do? If we have done in the first case, what did we do? What we did first? IV access, then ketamine. How much? 1 milligram per kg, and then pre-oxygenate, is it? And then paralysis, and then intubate. So you give ketamine IV, you oxygenate your patient. If oxygenation is not good in terms of saturation, you can use CPAP. You can also add PEEP, 5 to 15 centimeters of water. And then when the saturation is above 95, the patient maybe start to wake up, then you can give another dose of ketamine, and then you paralyze and you intubate with safe environments. Okay? Next patient, 30 years old male with possible overdosage, found down at home and brought in by ambulance. GCS 12, saturation 85%, confused with all other parameters. Our traditional approach, that one, hypnotic, muscle relaxant, intubate, and then saturation drop, because there was no safe apnea period. So what is the option, or what are the alternative? In this case, what will you do? IV access, then IV ketamine. What else? Pre-oxygenate, paralytic, and intubate. Is it? So ketamine, if I've said earlier, you give oxygen using CPAP, you add PEEP, and then you allow the saturation to set above 95%, timely. You allow the patient to breathe, to denitrogenate, and then you can increase, you can give a second dose of hypnotic, and then you paralyze and you intubate in safe environments. Okay? Okay, that is the next patient. Elderly patient, 85 years old, nursing home patient, saturation 93% with all other vitals, and temperature 38.5. Placed on non-invasive ventilation, tiring out, tolerating non-invasive mask. Traditional approach, etomidate, succinylcholine, and intubate. But the risk of rapid desaturation, and there's a need of BVM ventilation, vomiting, and difficulty reoxygenation. So what is the other approach for DSI? How can we go in this patient? Yes, you know. Speak out loudly. The same principles. To start with, IV access, ketamine, oxygenation with different alternative you can give, CPAP. What else? Yeah. What else? I can't hear you. Oxygen saturation. That is the key point. And then when the saturation is above 95, you are comfortable, then you can give paralytic and you intubate. So you give ketamine, you leave your patient because he could go with non-invasive ventilator, is it? Then you live with that, you give ketamine, then paralytic, you live with that until apnea, you leave non-invasive ventilation on until apnea, and then you intubate. Ketamine leaves airway reflex intact until paralyzed, and you're able to shorter period of non-invasive before intubation attempt. So the most important thing that you make sure your patient does not get hypoxia. Hemodynamically stable. You give enough time for apnea, oxygenation, and then you give paralytic, and then you intubate in safe environment. So apneic oxygenation. When you do apneic oxygenation, the oxygen in the alveolar continue to pass from the alveolar to the blood during the gradient pressure gradient. And about 250 mils of oxygen moves from alveolar to bloodstream during apnea oxygenation. And 80 to 20 mils of carbon dioxide leaves from the blood to the alveolar. And generally, if you doing intubation, as we have said earlier, in this patient, you keep on giving oxygen through the nasal prong. So oxygen tension is still high. So this also prolongs the period of apnea. Safe apnea, because still you have oxygen in your blood. Okay? Those are some equipment for delayed sequence induction, meter, airway, mask, suction. Okay, the DSI protocol you have in your guideline, I think. So those are different equipment: nasal cannula, non-rebreathing mask, and tidal carbon dioxide monitor, ventilator, non-vented mask with strap, syringe, BVM with adjustable PEEP valve, tape and ties. And that is the procedures. How should you go? So important positioning, as it has explained earlier, positioning before intubation, the same oxygenation. If I've said press nasal cannula, you place the patient either on face mask or you can use CPAP. You make sure that if the patient is not tolerating the CPAP, you can increase the dose of hypnotic ketamine to make sure your patient is calm before intubation. You can use CPAP, you can add a PEEP 5 to 10 centimeter to make sure that saturation is above 95%. And then you allow your patient to breathe approximately 3 minutes. And you attach BVM to oxygen source after you paralyze your patient. Then you can intubate safely. During apneic period, you can push your sedative and paralytic. You can remove the face mask, and then you can increase you can increase the flow of nasal cannula to 15 liters per minute. You perform jaw thrust to maintain pharyngeal patency, as we have explained in the earlier presenter, to maintain those 3 axes and facilitate visualization of the glottic opening. And then you put your endotracheal tube. You can you ventilate by using BVM. You attach PIP, and then you make sure there is correct placement of the ETT, and you do all the maneuver which I've explained earlier. You check right placement of endotracheal tubes in terms of depth and position and all hemodynamics. Regarding intubation period, while you are intubating, you can leave the nasal cannula, so to maintain apneic oxygenation, as I have explained earlier. So there is a study which was done in Great Britain. It has been observed that mortality is higher in emergency department and ICU than in operating room. And they were checking the reason why. One of the reasons is there was a failure to plan for failure. You have to plan, you have to plan for failure. But if you fail to plan for failure, that's when the problems comes. And that was due to either the ETO2 was not standard used for every patient, and the large cases which has that failure were obesity patients. A wake intubation was not used in case needed, and needle cricothyrotomy as a surgical, when you go to the algorithm, you should have prepared for needle cricothyrotomy. That was not well prepared. But other thing is one more reason is when they need consultation for anesthesiology, junior resident was the one who was attending this patient, not the senior one, experienced one. So all those factors contributed to that mortality. Okay, sound, I think now you are expert in delaying sequence intubation. Is it okay? You will no longer scare to intubate patients or for nurses to prepare for intubation. Is it? Because sometimes our registrar, when they are called from theater to intubate in ICU, they're really scared, because sometimes nurses are not well preparing, and the situation, and you have no one to help you there, you are alone. So not necessary to go for rapid sequence induction. You have this opportunity or alternative for delayed sequence intubation. Thank you. Any questions? Contribution? Yes.
Can lead to raising, yes, intracranial pressure and cause delayed cerebral perfusion. So how do we go about it?
Well, recent studies show that increase of intracranial pressure was not because of a ketamine. That was because of hypercarbia. So if you maintain your patient in normal carbia and you give that drug, there's no problem. And we are doing that these days. Even emergency department, I think you are intubating patient with the ketamine. Yeah. Before that, people were scared using ketamine to intubate patients. Okay, thank you.
Okay, so we're running very late. So while these slides get uploaded, how many of you have been involved in intubating a patient? Hands up. 1, 2, 3, 4. 4 people, 5, 6. So, and some of you are just assisting, or some of you are actually intubating? Actually intubating. Okay, and some of you are assisting. Okay. How many of you have ever been involved where you couldn't bag the patient? You failed bag mask ventilation. Anybody? Excellent. You guys are very good. Has anybody failed putting an LMA in? No. Okay. And you've intubated the patient. Have you ever had a scenario where you couldn't put the tube in? You couldn't intubate. Excellent. What did you do next? You called for an expert. Yeah. And did they arrive quick enough? And then were they able to intubate? And what did they do differently? Just a different piece of equipment or different positioning? Different positioning. There you go. Okay, excellent. While I wait for my slides, so my talk is going to be very brief, okay? I'm going to try and make up on a bit of time. Is to really talk about what we do when we fail intubating a patient. Now, all of us, there are going to be some patients, no matter how good we are, how experts we are, we're not going to be able to intubate a patient, okay? Or we're not going to be able to what we call oxygenate. So whenever we do bag mask ventilation and whenever we're doing LMAs, our prime aim is to keep the patient oxygenated, okay? We're not trying to keep the CO2 completely normal in that short period of time. We're trying to at least keep the patient oxygenated. So my talk is really on a scenario where now I haven't been able to oxygenate my patient and now they're desaturating and I haven't been able to intubate them. And what do we do next? Okay, so these are borrowed slides. So I'm going to, how do I, just this one? Yeah, perfect. Side ones. Great. That's my colleague from Perth. These are his slides. And so he's just let me borrow them. Okay, so I do have to acknowledge him. Okay, so this is our checklist. So I showed you the one that is very generic. Each hospital makes their own a little bit that's got some slight differences. We've based it around that one. We've just added a couple of things, which is what is the name of what's the number of our anesthetist, okay? And when we prepare for difficulty, you know, we've got a few things that we think are important. We've just made a few different color codes, okay? But it's pretty much the exact same information. And this is what we use in our ICU, in our hospital. And as Dr. Asher has just said, that the audit that came out of the UK said that the majority of failed intubations and failed oxygenations were in ICU and emergency department. One, because these patients are a lot sicker. Any intubation in these areas is always high risk because it's not a well patient looking good who's come from home. It's a sick patient who can't breathe enough, whose already physiology is compromised, and you're working under difficult circumstances. So they're always high risk intubations. And then the other thing is, most of the time, because we're not trained anesthetists, we don't go through those plans in our mind, we don't verbalize the plans, we often haven't prepared for failure. I may have prepared for failure, but I haven't told you the plan, which means when I expect you to give me something else, you don't know what I need. You don't know where I am in my mind. Okay, so that's why now these checklists have come out, but we talk about preparing for failure because there is going to be a time when we have to. We've had a couple in our ICU in the last year or so. Okay, and to be involved in one of those is never a good thing. But if you're prepared as best you can, then you're only going to do your best, and you know that you couldn't have done any more. Okay, so we've got the checklist. This is our airway algorithm. Now, most of you, we haven't done algorithms as much in the previous talks, but there are airway algorithms out there again on the internet. There's probably over 1,000. Use your airway algorithm that is in your hospital, okay? There's the Difficult Airway Society that's got one. I'm going to talk to you about the vortex approach because that's probably what we also use the most of. But this is our very simple way. They need to be really simple, very easy to read. And they've got to be stuff that everybody understands. Okay, so this is our one, and it's color-coded. Okay, so I'm going to talk about what we do when we haven't been able to put in a tube in and we haven't been able to oxygenate the patient through bag mask or an LMA. There are 5 key things we talk about. Having some cognitive aids, so having some sort of algorithm so that people can use, okay, when we're in a crisis. It's what we call a crisis when you haven't been able to, it's a KAICO scenario, we call it a crisis, okay. So I'm going to go through each concept. This is our Anaesthetic College of Australia and New Zealand, and this is their cognitive aid. And I look at it and I think, way too much writing. If I'm going to give it to, I can't read your name there, but I'm going to ask you, Dr. Shamim is my assistant. And now I'm in a scenario where I can't oxygenate my patient. My bag mask is not working. My LMA is not working. And I've not been able to intubate. And she's going through this. It is very hard to read it in a hurry. The writing is small. I don't think it's very clear. It's not clear even when I read it normally. So, you know, we don't like it very much, even though this is what our college has produced. How many of you have heard of the vortex approach? Hands up. Anybody? Okay, so this has also come out of Australia. Another anaesthetist there has brought this out, and he's brought it out because it's very simple, easy to understand by anybody. So if you imagine it's like a vortex, it's like a funnel, okay? If you're looking at the top of the funnel at there, looking down, you want to be in the green zone. Everything is happy, everything is good, all right? So whether you've got the bag mask at the top, you're the LMA on the left, or your ETT on the right, okay? You get that in, you're in the green zone, your patient's safe, all is going well. You tried one of those, you failed, you moved to the second one, you're slowly going down this, okay? But if you can get back into the green zone at any stage, you're good. So they found it very easy because it's a very easy, I guess, picture, colorful cognitive aid to use. Okay. And if you look at the other ones, there's a Difficult Airway Society one in your booklets there, right next to the checklist. Again, lots of writing. Nobody has time to read in a hurry. Okay. You want things to be really simple. So we found the vortex approach now is something that we use in our hospital. So basically, I'll go through it. Each step there, if you're just doing simple bag mask ventilation, if you're not succeeding, it goes through, what can I do to make my bag mask better? Okay, what manipulation do I need to do? Or similar for the airway, LMA, or for the ETT. What adjuncts do I need that are going to help me? Am I using the right size, the right type of equipment? Okay, is it an equipment issue? Is it a suction issue? Okay, and then is it a muscle relaxation or tone issue? So it really simply goes through everything. Why am I not working? So my colleague there at the back said he had a positioning issue. So there's always going to be something you can do better. And this is that table. So if I'm having difficulty with bag mask, at the top, the first line is my patient position right? Now, we should be doing this before we start. I don't think there's any excuse now to not have your patient positioned properly. If you take an extra 1 or 2 minutes to position your patient the way they should be positioned, you will not be in a difficult situation or position. Okay. And I think these days we just cannot excuse bad positioning. All right. Dentures in is good for bag mask because the face has some shape. The minute you remove a denture, the mouth sinks, you can't get a seal. Okay. So if you're having a difficulty with bag mask, maybe stick the dentures back in. However, if with intubating, if you're having a problem with intubating and the dentures are in, it's easier to take the dentures out. It just gives you better access in the mouth. So depending on what the issue is there, you can make things a little bit better. If it's an LMA, pull the tongue a bit forward or give yourself a jaw thrust just to help the LMA go in. Okay. What can we do at the larynx, which has already been talked about? We call about that burp maneuver, backwards, upwards, rightwards pressure. Okay. Always use 2 hands to bag mask. If you're in a crisis scenario, I mean, we've already talked about it, use 2 hands, okay? And then, you know, how you grip is really important to get a seal. We've talked about airways, so I'm not going to go through that. Bougies, fiber. I use a bougie all the time, even if I've got a perfect view. Because sometimes the hardest thing is you've got a perfect view. How many of you have had this? You've got a perfect view, you can't put the tube in. Anybody? Nobody. Okay, well, I get it all the time. My tube does not want to go where my view is. Okay, bougie is perfect. So you use it all the time. And we talked about suction and then muscle relaxation. If your patient is not anesthetized well enough, they're going to fight you. If they've not got muscle relaxant on board, your atracurium is not working yet, the mouth is not relaxed. You're not going to be able to get your laryngoscope blade in. Bag mask. The tone is still like the muscle tone is there. You're not going to be able to, you know, ventilate or oxygenate very well. So you need to check, have I got enough sedation? Have I got the patient muscle relaxed? So these are the things that if you're having issues with, you want to go through. And your colleague, who is your assistant, can very quickly go through these things if you're having issues. Okay. While I talked to you earlier with the checklist, in our thing, if I'm already failing my first plan, I want somebody to be calling for help already. Okay. So on the right, it talks about attempts at lifelines. They talk lifelines are your tube, your LMA, and your bag mask. Similarly, the more attempts I'm having, the earlier you start thinking about doing front of neck access. It's called FONA or, you know, cricothyroidotomy. So you start to prepare for that so that when you've reached the end of all your lifelines, your next thing is already doing front of neck access. All right, and it talks about it vertically as well. So it talks about attempting each lifeline. You don't have more than 3 attempts, okay? And it has to be by the most experienced clinician. One of those attempts, okay? So if you're the trainee and your expertise has arrived, they need to have 1 go at least. But if in total you've had 3 attempts at intubation, don't keep doing it. Move to the next thing, because you're just doing the same thing over and over again that hasn't worked. And you're going to put your patient in trouble. All right. So all 3 lifelines, you've got to give yourself only 3 attempts. You don't keep persevering. Or if your patient's now also desaturating, you need a plan. So once you've got to the point where now you're going to do CAICO, do you all understand what CAICO is? Can't intubate, can't oxygenate. Okay. So we have a simple algorithm that we use for the actual CAICO process, which I'm not going to go through in too much detail, but I think Dr. Moes had already spoken about scalpel, bougie, and a size 6 tube. Pretty much all we need. That's how I've learned. Now I work in Australia. They do a different approach, which I've also had to learn, but my go-to is pretty much a scalpel, a bougie, and a size 6 tube. Okay. And that's all you need to learn. But we have an algorithm for that as well. Again, keep it really simple. It has to be really easy to follow. Yes, no, yes, no. This didn't work. Move on to the next one. Okay, this is our Perth algorithm that everybody in our WA has adopted. So I've gone through cognitive aids. Keep it really simple, things that people can understand. And then we talk about what our aim is. And I said to all of you that we're not here to maintain normal CO2. We're here to keep your patient alive, which is to maintain oxygenation. So everything that we're doing is to try and keep the patient oxygenated until you can get a definitive airway in. Okay. All right, so we'll move on. Good. All right, terminology, equipment, and approach. This should be standardized in your ICU, in your emergency department. So if I'm saying CAICO, everybody understands in my unit. Okay, can't intubate, can't oxygenate. We're doing CAICO, which is cricothyroidotomy. Whatever terminology you use, everybody needs to understand in your hospital. Okay, there used to be different things. People used to say failed ventilation, failed intubation, and all these various CICV and all these various ones. We've just used CAICO, and everybody understands. So you need to have that in your hospital. You need to have a CAICO kit, a little bit of like I say, a little cognitive aid at the front of it, so people know what to do. All right. So this is our airway trolley on the top left photograph there. And this is our little CAICO. It's written in red. You probably can't read it very well, but it's a little packet and it says CICO on it. And basically when we say CAICO, that kit is opened. Everything is in there. Okay. We know where it is. Like I said, we've got a very simple algorithm. Everybody knows we're circling down that vortex. I reached for my LMA, I've reached for my tube, and now I'm bag mask and I'm struggling. People are already opening the CAICO kit. My anesthetist has already been called. Okay. Okay, so the hardest bit now is actually physically leaving the top end and moving to the neck. Have any of you seen this happen before? Anywhere? No, it's quite confronting. None of us are surgeons, okay? And this is not our area of expertise to start, putting a big blade in a neck, okay? So it's confronting for anybody, but the main thing is making that decision to do it and then doing it. And the biggest failure has been where people have not been able to make that decision that we just need to do it and then gone on and done it. That's where the hesitation comes in, because this is completely out of our comfort zone. Yeah? Do any of you get CAICO training? Okay, so that's another thing that's come in our hospital, because it's not something we do again. So like we train in airway stuff, we train CAICO as well in just some models, okay? And we try and just get comfortable with the process of doing it. So when I have to do it in a real patient, I've at least tried it on a model before, and I know what I have to actually do, okay? And so I think those of you that might work in that environment, who are responsible for doing the intubating, you need to probably have a way of training in that as well. And that's obviously, beyond what we're going to do today. So we talk about declaring it, saying it out loud, and then physically doing it, which is moving as well. So you want to move the patient. So when we talk about positioning for airway, to position for the neck is the opposite. Okay, we need to have the neck really extended. So we push the patient to the top of the bed so the head is off the end, and that extends the neck. And it just means access to that is really easy. So once we make the decision, that's it. We don't do anything at the top end. We move straight to the neck. Okay. And this is, like I say, the reason there's been issues is people haven't made a decision early, and essentially time delays. Yeah. So when I've declared CAICO, already in that time, somebody has got the kit out, and whoever we had already planned in our team roles who was going to do it is going to be they're going to be at the front and they're already ready to do it. Okay. And we will have already prepared for this. So we move the patient to the end of the bed. It's called rock and roll. We call rock and roll because we have rocuronium as our muscle relaxant. You have atracurium, I heard you say. We have rocuronium. So we say rock and roll. We put a roll under the shoulder blades, pull the patient up, roll underneath, and then the head is fully extended, and we give rocuronium. Okay, because when you're cutting the neck, you don't want a patient to not be paralyzed. Okay, so we just want it to be really as smooth as possible. So yeah, rocuronium goes in, patient is positioned, and then the actual procedure happens. So yeah, we've already committed. We've said we've got a CAICO, and we're pretty much, it says ready, set, go. I mean, nobody says ready, set, go. We just say CAICO, let's just crack on. Okay, so if you're not trained, but you're in the team looking after the patient, you may be the person getting the KYCO kit, you may be the person calling the anesthetist. So you need to at least be watching what's happening. And whenever we intubate in our ICU, always in that bed space, it's quiet so that everybody that's there is watching what's happening. I'm not having a different conversation in the background and I don't even know when the crisis is happening, okay? So you all need to be watching what's happening. So when you see your colleagues are struggling already, you're helping with, moving forward with the planning. What do we do when the patient arrests? I have to say, we don't usually plan for that. We plan for failure. We don't plan for when the patient arrests, but I'm thinking most people will know to start CPR. Though I don't know how we would go if we can't oxygenate the patient. I'm probably going to stop here purely because there's two ways. The scalpel one is the one I've talked to you about, and it's probably the one you should only ever learn. We also have a needle option, which is the one that they use in Australia, which I've now had to learn. And it comes down to what you're comfortable with and what you've trained doing. So just here, all you have is this scalpel bougie. That's all you should learn. Okay. I think this is in your packs. This is by the Difficult Airway Society. So again, when they bring out these sorts of cognitive aids with too much writing on them, they're not helpful. Okay, they're good to read when you have time, but they're not good when you're in a crisis. But it just goes through the process of what you need to do. There's lots of YouTube videos out there. For those of you who may well be the actual intubators, it's probably worth learning, in some sort of advanced airway course or airway training where how you go through the KYCO process. But there's lots of videos out there as well. And I'm probably not going to go through that today because I think it's not really necessary for the course. Yeah, I've got some videos there, but I'm going to move forward. In fact, I'm going to cut all of this out. Okay, any questions? So just to kind of end on that, I think once you know you're failing, just have, each unit should have a front of neck access kit, and it should have a simple algorithm to follow, okay, with everything in it. And who's going to do it? Any questions? No, okay. All right. I'll probably stop there. I think this is probably a topic that's a little bit advanced, I think, because most of us aren't going to be the ones involved doing it. But it's good to know if you are assisting with your airway, if you're assisting your anesthetist or your ICU consultant who does the intubating and you're the assistant, it's still really important to know so that if you see they're failing one, you need to have the second bit of kit ready and have the third bit of kit ready. Make sure you talk about, all those adjuncts and all those adjustments that can be made. Has somebody gone through them? I do like the vortex. It's very easy. It's good. Whether or not you guys have that in your airway trolleys, I'm not sure, but just have some sort of really good, simple way of going through things when you're struggling. How many of you? Yeah. How many of you have an airway algorithm on your airway trolley? Do you have an airway trolley? No? Okay. Yeah. So I guess, yeah, I think there's probably only a couple of things I would say is that there's a few things I think are probably worth doing. And one is the checklist and maybe having a really simple algorithm for people to follow wherever you keep your airway. It doesn't have to be a whole trolley. But even if it's just a little box, just having a simple checklist so that whenever you're intubating, people are going through the right things, and then having a simple algorithm to follow, whether it's Vortex, whether it's DAS, guidelines, there's guidelines out there, there's various algorithms. I think you've got to look at what you have in your hospital, where your expertise is, and just create something really simple that you can use. Okay. Good.
So definitely it's an eye-opener because the next thing I'm going to do is I'm going to create a airway algorithm for my hospital as well. it is serious, and it's usually if you are working in a place like Muhimbili, whereby you can get such cases maybe every month, whereby you can't intubate and you can't ventilate. It is something that to have, at least a scalpel. I used to, when I was a resident, I used to move around with a scalpel. I know it sounds very weird, but that was the reason, that maybe I would get a crike and I would do it. So we did, in my 3 years, I did twice. And it was something very scary because we didn't have training mannequins or anything. I just went and especially when you cut there and the blood and the patient, if he's awake, that blood that comes out, you know. I've seen some videos whereby they have not paralyzed the patient. When would you do that?
So we would never do a kaiko without paralyzing, but we would do, if we have a threatened airway, a patient's awake, we would do awake tracheostomy with local infiltration, but that's done by ENT with the patient awake, because they're very good at doing a nice tracheostomy and the patient is awake. If we're doing it like in a crisis, the only time we ever do it is in a crisis where we're really desperately trying to get oxygen in. The patient is already hypoxic or, you know, unconscious because you've already given them the intubation drugs. So they're apneic. So, you know, we would never do it in an awake patient. Yeah, that's not our expertise.
Thank you so much. Yes.
Jamani, mtanisamehe tu, lakini nataka kujua kule tunakofanya kazi kule kwenye hospitali yetu za Mwananyamala wapi, hii scenario huwa zitokei, na zikitokea mnazihendo namna gani? Sijui nimeeleweka hilo swali. Umenipata
Basically, it's a real scenario. If it happens, what really happens? What do you guys do? So it's like a regional hospital like Mwananyamala or Amana. You get such a patient, what do you do? That's the question to ask. How many times would you intubate such a patient until you realize that now I have to crack this patient? Yes. You've never done that. Okay. Anyone else? So I'll give you my experience. So we had a patient who was a trauma patient, okay, and had aspirated. I couldn't see the vocal cords. And my friend was ready with the scalpel, a bougie, and a 6/0 tube. So basically the procedure is done like you make a, there are some people who just make a, first you have to identify your cricothyroid membrane. So if you see this is your thyroid, right? I mean your Adam's apple. And then when you scroll down a bit, you'll see a bump. In between that bump and that big bump here, this one and this one, that's the cricothyroid membrane. Okay? Now what I would do, I know the surgeons would not like this, but I would make a long incision here, horizontal one. Then once I'm done, I'll start feeling the bone again. Then I'll make a horizontal. First I'll make a vertical one, then I'm going to make a horizontal incision with my scalpel, and then push it to the right and left. And then I'll take my finger, this finger, and I'll put it inside where I've made the incision. This will help me to pass my bougie with my other hand. Once my bougie is in, I feel some resistance, I take my 6/0 tube and I pass it through. Some people even cut off the 6/0 tube so as to decrease the dead space. I have never done that, but some people recommend that about the ile nani, this is the cuff, right? This is where the cuff is coming out. So about that, you can cut it and decrease the size of the tube, but I have not done that. I always keep the 6/0 and then we send them to ENT, and then the ENT will take care of the rest. If they have to do a tracheostomy, they will do it. And some even leave it. They leave the patient like that only with a cricothyroidotomy done. And after 2-3 days, if the patient wakes up and is all good, they take it out. So that was my experience, by the way. I have not done it many times. I've done it twice in my whole career. And yeah, it was scary for me. But with practice, it becomes like, second nature. Huh? Your PowerPoint. Okay. All right, now we are going to, many times it's not a, I've seen so many of you intubate with that mannequin. So many of you have intubated with the mannequin successfully every time. But when it comes to the real scenario, the psychology is what is messing you guys. So today we talk about the psychology of a difficult airway, and Dr. Ramadan is going to take you from step to step on how to maintain a calm mindset when you are dealing with a difficult airway. Because sometimes the difficult airway is not, it's not the patient, it's you. All right. Welcome, Dr. Ramadan.
Asante Moise, asante presenters wengine. Tumekuwa tukizungumzia airways. We've been speaking about airways. But the basis of speaking about airways is where Ismail spoke about it initially. We want to optimize oxygenation. We want to optimize gases exchange. Doing this, we have to go through many ways to achieve that. While the concept of difficult airway over the years has been coined to anatomical airways, like we have a problem with bag mask ventilation, we have a problem with how you use laryngoscope, you have a problem of how you get the tube down. But there are many ways. Even you being the first time can be difficult for you. That's why most of the time experienced experts in airway, sometimes they say call an expert. So it means even being new, it being the first time can be part of the difficult airway. Even if it could be simple. Sometimes our patient can be under the car, it could be in a very adverse environment. So an environment by itself can be part of you having a difficult. So we're going to demystify that kind of an approach and see. My colleagues have spoken about sleep tracheal intubation, for which they have spoken about you have to give medication to a patient, that patient sleep. And we have spoken many medication. Dr. Moise spoke about it, Rina spoke about it. We have to give muscle relaxant, but we have to understand these medications, and I think many of you, we are going to agree, sometimes you give a particular medication, the patient goes into cardiac arrest. Who has seen that? Have you seen a person after giving medication, they go into cardiac arrest? Have you seen that? Can I see your hand? How many have you seen? Okay. So you give medication, and then upon giving medication, the person goes into cardiac arrest. Right? And how many of you have, when you are trying to intubate a person, you end up not intubating the person, actually dies or goes to cardiac arrest? How many of you? Many of you. Okay. So it means here, that is a part of what we call difficult or failed airway. We were not able to put the tube down, and therefore we fail. So a sleep tracheal intubation of a critical airway patient associated with a small but significant mortality. That's where it is, because we try to make them asleep. Because not all patients you can intubate by making them sleep. Some people have to be intubated when they are awake. Some people you have to delay a little bit. someone who is fighting, you're putting the mask on, is pushing away. Someone who is, let's say, is delirious. How are you going to intubate that person? How are you going to have the tube in? Because key to intubation, key procedure in intubation or key step in intubation is pre-oxygenate that person. But in order to pre-oxygenating a person, they have to be able to get that oxygen in. So either you can make them sleep and give oxygen, right? But sometimes making them sleep, it's dangerous for them, right? Sometimes you may want to give sleep and give some medication, that will make them sleep and be able to pre-oxygenate and continue as such. So all these things actually make you meet with some difficulties based on how the physiology is and how the anatomy is. So peri-intubation cardiac arrest occurs in almost 3%, 3.1% of all patients. And most importantly is that between 30 to 45% of these, when they go into cardiac arrest, the chance of return to spontaneous circulations is 0. So this is where we lose our patients. Yes, it's a 3%, but it's significant. But it's all peri-intubation. Either that you are unable to get the tube in, the person dies, they go into cardiac arrest, or you try to put the tube in and then after that the person dies. So this is peri-intubation. So the risk is around 3%. So wherever that we saw our patient die, it was one of those 3%. But those who went into cardiac arrest, the chance almost 3 to 40%. So 1/3 of those, they never get return of spontaneous circulation. So, as we're going to speak about it later, awake intubation is a little bit, gives theoretically a physiological stability and the safety benefit of a sleep approaches where we have to give some medications. This one, awake intubations, it means we avoid pharmacological induction agents, abrupt shift in intrathoracic pressures, and while maintaining respiratory drive, meaning that the person is awake. Either you are unable to pre-oxygenate this person. There are people, whatever that we give, 60% of saturation is what we can achieve as much. How are you going to make them sleep? Because I can tell you, at a time when the saturations is 60 or 70, at a time when the blood pressure is systolic blood is 80, the person is shocked. This time, usually they do have sympathetic drive that keeps them hanging, right? This is the time when the sympathetic drive that keeps them hanging. Or someone has got acidosis of less than 6. This is the time that actually catecholamine is actually making them wake. The moment you give medication to sleep, they say bye-bye. You will never resuscitate them. So awake intubation that's where you consider you want to give them to put the tube when they are awake. There are so many processes that we have. I think we do have one of the checklists that talks about awake intubation. Awake intubation, this checklist, you can see there are around 7 steps on how you can actually intubate someone with awake intubation. It's a little bit more, it's more a specialist activity. It's not something that someone who just want to know intubation today would like to practice intubating, because there are places where you have to put the tube in when someone is seated. And usually you can't do that with just a laryngoscope. You may have to use fiber optic devices where you pass the camera down there or whatever. But by doing that as well, you may trigger bronchospasms, and then therefore you have actually to numb, either by nebulization. You have to nebulize. Sometimes you have seen those xylocaine sprays of lidocaine. Sometimes you have to numb the vocal cords, or you have to anesthetize. That's what we call topicalizations. So this is actually is a procedure. It is very nice to learn. One time we'll come and actually train on how to actually do something. You can go even on YouTube. You can find even experts doing that themselves. How you can do awake intubation. It's very nice. It's much safer than giving someone ketamine. It's the same thing they will say, oh, ketamine is good for everyone. No medication is there for everyone. Every medication it has got. If you look at Moise, you look at me, look at Rina, look at Dr. Asha, look at Dr. Naima, look at Dr. Ismail, we are physiologically different. We are anatomically different. And the way you treat, you cannot just say, I'm going to give Dr. Chunga ketamine. You have to study what medication fits for me. Maybe it's proper for. Maybe it's just midazolam. So it is usually a sweet spot must be found. Wow, I understand. You see a person dying. Oh, bring the cross cut. We need to intubate this person. The person is collapsing. My friend, sometimes you better let the people fight themselves. They're going to probably survive. Sometimes by doing what we want to do, you're actually pushing them to go. This is what, as I say, sometimes the laryngoscope is a murder weapon. Many of us, when we went through our ranks from junior doctors, we have lost the patients. We may not say here, but I can tell you, we have lost patients because of that laryngoscope. Trying to give ketamine, rapid sequence, and the person dies. One time I had to call my senior, when I was a junior resident, I had to call my senior. It was in the evening. He already left. But that patient actually made me to call. My specialist that time was Dr. Kamel. Dr. Kamel, I had to call him from home to come and assist me to intubate because I was not getting it. He had to come from home just because I knew this is a weapon. The way I do it, if I become more confident, I lose the patient. And good enough, I was afraid doing it. He came, he said, Dr. Ramadan, I think there's something that we need to work it out. Of course, it was actually an obese patient whom we had to ramp. So I ramped the first time, I thought this is enough. I ramped the second, this way I had to do 4 pillows to get that patient up. I thought it's only one is enough. Then we had to use 4 pillows. And I said, oh, I would have lost this patient. And then he came, he just used it. It's because of experience. He just used 5 minutes and he left. And I said, oh my God, what happened here? But it's experience. And most likely you're going to experience the same as we grow and we go. Be humble. Don't rush. I need to intubate today. No, sometimes you have to say, you prepare and say, oh, Dr. Moise, come and do it. For that, let me watch. Losing a patient because of your laryngoscope is very dangerous, and it's not something that you want to take it because you try to help, but actually you're pushing that person to the edge of death. This is not what we should do. So I want to say, while we are teaching you on the use of laryngoscopes, but remember, laryngoscopes can be a murder weapon. Repeat it, a murder weapon. Let's be gentle and let's consider the following. So, as I mentioned, it is not all about difficult laryngoscope, difficult bag mask ventilation, all over difficult. It's not all about that. There could be other things as well we're going to consider. Time, sometimes the patient is sinking so fast. That could be part of you, the pressure that you have for preparation. I think Rina took us through a list of things that we need to prepare. Sometimes you don't prepare all of those. You don't have that time. Sometimes you don't have that time to say, it must be having a system that has prepared it. A crash catch for emergency intubation should be there, which you can just open and everything is in there. Otherwise, if you say to prepare, I can tell you, especially in our system where laryngoscope is in the director's office and probably the tube is in the nursing officer's office. So how can you prepare? You end up being in the middle where you just need to intubate and the person is dying. They were just bloating, he's bleeding, and he's having gush of hemoptysis. You can't have that time, otherwise the person is going to die. And therefore, preparation, it is a system, is there than just one because of the time. Environment as well. Not every places, everywhere you can intubate. Patients' hemodynamic status and respiratory reserve. And this is key to what I would like to speak today. All contribute to the complexity of safely securing an airway and optimizing gas exchange, which is the ultimate goal of endotracheal intubation. We want to optimize that, but all this can affect how you go about it. It's not about, I can have a short neck, I can have Malam part 4, I can have whatever, but all these things have to be. Patient at high risk of tracheal intubation, hypoxemia, hemodynamic status, especially hypotension and metabolic acidosis, can be thought as having physiological difficult airway. So that's how you can actually define it. Of intubation complication include hypoxemia, hemodynamic instability, and cardiac arrest. These are the main things. There are people who started with a good blood pressure is okay, but after giving your ketamine, after giving your midazolam, the pressure goes down. Right? Now you are in trouble. Sometimes a patient, while you are doing your intubation, the patient becomes severely acidotic. That's where the problem started and the patient deteriorates. So not all the time, intubation is going to end up being nice and get the tube down and everything, the patient is fine. And this is also the importance of saying, when you intubate a patient, just put the tube in and you go take your coffee. No, you intubate a patient, and I can assure you, you have an hour to stick around. I don't know how much Rina stays after intubating a patient. I don't know how Ismail stays, but I think an hour, because after an hour is when you want to have your blood gas, and at least you can see how much the hemodynamic, how much is blood gas is going on. Rina, how much do you stay after intubation? At least an hour. Ismail, even more. Dr. Asha, you see. So, guys, I tell you, my junior colleagues, we are all young. We no time to rush when you put a tube in. You intubate, you stay. Tell your husband, tell your wife, I'm intubating a patient. Because if there's a derangement of blood gas, still have to stick around. Because you have to set some ventilator. You still have to get that FiO2 less than 60. Right? Because FiO2 more than 60 after an hour, it's a problem. So you still have to stick around. Hypoxemia patients are at increased risk of intubation-related complication, as I mentioned. How to optimize that? The oxygenation, apneic oxygenation. We all know about apneic oxygenation. Huh? Do you know that? During the apnea time, the time that the patient has stopped breathing after paralysis, that is an apneic phase. Usually is the main area, the main time that actually has an issue. And this depends much on how you pre-oxygenated the person. So if you did not have achieved, let's say, above 95, during that apneic phase, the saturation appears very fast. And the graph, looking at the graph, usually below 90%, the graph is very steep, and usually less than 70% of saturations usually is critical. It is very quick. And less than 70 of saturations for a person like you and me, I should be sure this person is going to cardiac arrest. So apneic phase or apneic time. So whatever you're doing during pre-oxygenation, actually you want that time of apnea. And that's why there are some studies also suggested that you have to put nasocannula oxygen around almost than 15% to promote the apneic phase. To promote the apneic phase so that you can have an oxygen. Awake intubation are also important to optimize this strategy. So hypoxemic patients, you make sure that you have got nice pre-oxygenation, apneic phase has been attended, and if possible, consider awake intubation. Have you met with a hypotensive patient? Yes, many times. Our patients don't come to hospital without this kind of stuff. Hypotension, either because they are not well preloaded, so we have to preload, or maybe they just came because of vasodilatation, so they're hypotensive, and because of that, maybe they need pressors and all that. So optimization strategy include physiological fluid resuscitation, careful pharmacological agent selection, meaning that you have to choose which one. This is not a time for you to say, I'm going to use propofol. Okay, this is not a time to say not all medication. We're going to talk about every medication. It has got an issue with hypertension and lead available pressors and inotropes. I think in your checklist we do have one checklist talks about dirty adrenaline. How do you know? Have you ever heard about dirty adrenaline? Who can tell me when you have got a person with a blood pressure of less than systolic blood pressure less than 70? Here, what are you gonna do? Be sure this person is going to cardiac arrest. Less than 80 cardiac arrest. That is actually what we call is uncompensated shock, right? Or that decompensated shock. So what are you going to do? Are you going to give fluids and wait, or are you going to do something? What are you going to do? Huh? What are you going to do? You give inotrope. So it means we're going to set an infusion. Is that what you're saying? Who else? What are you going to do? Blood pressure is systolic blood pressure is 80. This person is actually crashing. Yes, what are you going to do? Okay. So let's go back. Let's review. You remember those tropes that we are talking about? We are saying inotrope. So what does inotrope mean? There's a chronotrope, inotrope. What does it mean? You're talking about the heart, right? But what's the problem of blood pressure most of the time? Is the vessels, right? So vessels have to be what? They have to be pressed, right? So pressors, right? You need the pressors. But pressors, are you going to have infusion? You know that micrograms per minute per hour. Are you going to do that? You need a push dose. You need to give a bolus. How? How? Have you ever heard about that? Have you ever given someone adrenaline IV? Apart from the cardiac arrest environment, have you given an IV? Who has given IV adrenaline here? Yes, yes. Guys, you have never given adrenaline? You never had a person with hypertensive, life-threatening hypertension? Hey, how do you give it? Tell me. How do you give it? Bolus, yes. How do you give it? Okay. So the issue is dilution. Adrenaline comes in two forms, right? It's one of the cheapest drugs in the world. It comes in two forms, right? It comes as 1 mil in 10,000 in 1,000. 1 mil in 1,000, right? And it comes in 1 mil in 10,000. In Australia, how does it come? Adrenaline. Okay. The adrenaline we have in a small is what? Is 1 in 1,000, right? This is actually anaphylaxis allergy type of adrenaline, right? If you visit the US or something, you do have like syringes. Do you have adrenaline there? They are pre-filled syringes. They are 1 in 10,000. The idea is that 1 mil in 10,000. The idea is that if you add 9 mil, it will become 1 in 10,000. Right? Which is going to be 100, right? 100 micrograms per mil. Right? If you take 1 mil in that 1 in 10,000, right? If you take 1 mil, you add 9, then it's going to be 1 in 10 micrograms in 1 mil. This is a bolus dose. You got that? So you double dilute. You take the one that you have, you put it in 9 mil, it becomes how much? 1 in 10,000. This is actually 100 micrograms per each mil. And then you take another 1 mil from that. And then you add in another 9 mil. It becomes 1 in 1 mil, in 10 micrograms in 1 mil. Then you can use this as a bolus. Never ever use the adrenaline that we have as IV bolus. Your patient will go into cardiac arrest right away. So, eco hapo formula, push those pressures. They are here. The other phenelphrin, I understand. I know here we can even buy it in a pharmacy, but I think this is in a theater. We don't have it. Doctor, I know we can have this in. It's not available at all? Okay. Okay. In here, in our place, sometimes we can have these things in a casually in a pharmacy. One day I had a Amikacin bought in a pharmacy. What? Amikacin. So this one usually they use it in theater. In theater they have this and they use it so much, but what we have is epinephrine, which is adrenaline. Epinephrine is adrenaline. So make use of that and have the practice of mixing it. You remember it's a double dilution. Sorry? So you can give 10 to 20 every 3 to 5 minutes. Is that correct? Yeah. So 1 mil. So if you dilute in 10, so now we can give 10 to 1 to 2 mil, right? It's going to be 10 micrograms. So you can give 10 to 20 micrograms every 5 minutes to push up that blood pressure until when your infusion is already set, or sometimes fluids, because as I say, you cannot have the fluid just 1 liter. The patient is actually dying. So you need to push adrenaline. The adrenaline will get there while your fluid is going in, and then you're going to replace. Or maybe you will set your infusion, and the infusion will take over while they push those. Dr. Ismail, you have a comment on that? Okay. Yes. Yes, you're going to use it. Yeah, of course. In the previous literature, we used to say you cannot give adrenaline, noradrenaline peripherally, but now the current literatures you can use in a peripheral. We use it to be told you need to have a central venous access to give noradrenaline. That is an old adage. We don't go that way. Even myself recently, I've done the same, and I had significant good results without any complication. Rina, in Australia, you also believe the same?
Well, we have started using it, but very dilute.
Okay.
So a tenth of the concentration. So central is 80 mics per mil, but we only use 8 mics per mil for peripheral because we have had issues if you use the same strength peripherally.
Okay.
Yeah. So you just got to be mindful. Dilute even more if you're going peripheral.
Yeah.
Yeah. Same with adrenaline infusion.
Okay. So a little bit of cautious approach. Yes, doctor.
As anesthesiologists, we don't like to go with the single dilution. So you take 1 mil with 9, so you get 10 per cc. Then you take it and dilute it again, and that's when we use it.
Yes.
That way you get better result for your hypertension, but at the same time, it's the safest way of using it.
Okay. Yeah, the same thing, right? Guys, as we say there, 1 milligram in 1,000. If you add 9 mil in that, it becomes 100 micrograms, right? Per mil. If you take another 1 mil, that micrograms, 100 micrograms. If you add another 9 mil to that, it becomes 10 micrograms. Meaning this is the dose for push dose. So double dilution. Okay? Is okay? So okay. So look.
Take that 1 cc of
Yes. Okay.
Yeah. The second dilution, 0.5 ml to 2 cc mils. That will be 5 to 20 microgram will be.
After second dilution, right? Okay, now we have that second dilution. What determines the exact amount to give to the patient in terms of volume?
Okay,
you get
so
question,
the dose.
the dose.
The dose is between 5 to 20, right? Micrograms each every 5 minutes.
Okay.
Right? So the dose depends on your response from the patient. Actually, blood pressure you will see theoretically going up, but that is going to be just because of adrenaline that we're giving. You need to continue going into what caused the situation and it can resolve. If it's a hypovolemia, then you can continue giving fluids. If it is you setting up a nurse actually is setting up infusion, then you continue setting infusion and we take over, because infusion will take time to reach to the peripheral circulations. I think I'm right.
Is seen. I think I'm loud enough. Can you hear me?
Online.
Oh, online. Okay. So that is why we are saying that the second dose is the safest one, or the second dilution is the safest one to go as rapid as possible. Because when you say the single one, it's too concentrated. When you go for the first dilution, it's still too concentrated. You might get now tachycardia and other effects, which you don't want. So when you go for the second dilution, is the safest one, and that is what is recommended in dealing with hypertension. Okay?
Thank you.
Okay. So probably you're going to ask yourself, which type of hypertension? We know that during someone who is bleeding, then giving adrenaline to make the bleeding worse. But we are doing this not because blood pressure is low. This is indicated for life-threatening hypertension. Understood, guys? Life-threatening hypertension, without which the person will collapse. It's not like, the patient pressure is not good. Okay, so let me give this. It's not indicated as such. All right. The other thing with hypertension, we keep saying, between morphine and fentanyl, fentanyl is a little bit is not the one that gives hypertension. So we usually give to people who have got trauma. Or maybe ketamine is a little bit more, has got a little bit of sympathetic drive. When, as I said earlier, all medication for inductions, when a person is hypotensive, they drop the pressure. All medication. There's no medication that doesn't drop pressure. I don't know, my colleagues, is there any medication that does not drop pressure when the patient is hypotensive? Every medication does that. And the main issue is the sympathetic drive goes down, they relax. So midazolam will drop the pressure, fentanyl will drop the pressure, ketamine will drop the pressure, everyone will drop the pressure. So the idea to that is induction agents, the dose that you read in your books, it must be lowered. The dose that you read in the books must be lowered. You may be having another script that I may be shared with you. It has written the induction doses. And that one, it says how much the dose should be. The only one medication that there's no difference is etomidate. Etomidate, whether you drop it up, it's the same. So usually it can maintain the same, but all others, including ketamine, it's the same. You give that, it drops the pressure. So you may want to use the lower dose part of the range rather than the upper dose, right? Muscle laxant is different. Muscle laxant, at this time, you want to use actually a higher dose of muscle laxant. Metabolic acidosis. So usually this may result from apnea. During the apneic phase, as I said, you're not breathing, carbon dioxide does not come out. So anaerobic respiration is a result acidosis. The longer you wait, the more acidosis builds up. And this actually, if there is apnea intoleration, intubation hemodynamic collapse is imminent. So what you're going to do, awake intubation or spontaneous breathing intubation should be considered in a physiologically difficult airway. This is actually a take-home message. When you have got you are unable to assure optimal airway preparation, and you have got a person who is like that, remember, your medication can actually get a person into cardiac arrest. Bring in your best people around. Bring in anesthesiologists or experienced people. Sometimes keep the person, stay while you bring in the people. Patient can wait. There is no rush. Because either you had the patient to the morgue or you had the patient, whatever. You better the person stay there while you continue optimizing the patient, bring other people, even if that person is just passing by. Dr. Ismail, I can see you're passing. Can you please come back here? I've got a person who's different. Please assist me. They can assist you and life will become better. You will save someone's life. What does it mean? It means the hemodynamics, oxygenation, low pH kills our patient. You have to be very sure. When you see those things, know that these are enemies. You have to make sure you optimize this before you actually put your drugs in. And this one, actually, there's one checklist, if you can see. The checklist, this one. Have you seen this one? The first thing it says, when you are considering your airway, first, physio issues considered. Make sure your blood pressure is okay. I remember when I was working in a theater, before they give spinal anesthesia, they give a preload. They preload the patient. They give 1 to 2 liters. Dr. Asha, is true? Yes, because you want the tank to be full. Because otherwise, spinal anesthesia, what it's going to do is going to collapse the sympathetic, and then the patient pressure is going to go down. And therefore, they preload. So first, make sure the physio issues are, and mostly is acidosis, right? Have a blood gas so that you can look at that. Make sure the person is not hypoxic. Make sure the person is actually metabolic. And usually there's a way to intubate a person, but we're going to look in that a bit in a different situation. So how do we stop? How do we stop killing our fringing patient with intubation? Who's going to want to share? Because Dr. Rina has mentioned in the anatomical part, but I'm not going to be speaking. I'm not the best person to speak about this, but I'm going to play you videos. Of course, it's going to take 15 minutes, and then it's going to be the end. What is going to see? How do you get the sound?
Guys, lunch. Ready?
Let's go to lunch and then come back.
Hello, 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 hello. Mbona inaenda? Watu wanaona two people. So maybe hapa na present at the same time those who are eating we can see them. That's it. And hapa we want the same thing happen. Yeah. Huh? Nice. I mean, kuna music nafanya. When it, with the direct idea hapa ona hapa now it's showing two people. So my audience with my mouth. This is being recorded. Yeah. Kuna one part with the money, I think what you got. Kuna exercise and
Hello, 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 hello.
Yeah, this is the same one I like. Yeah,
Yeah, chini, ile chini. Okay. Yeah. Hiyo ni 2 minutes.
Na Rina alikuwa anasema yani hujaweka ile PowerPoint yake. Rina huyo
Sijaweka.
kuna email ametumia PowerPoint yake ya pili.
Ya pili ya sasa hivi. Ndo anakuja kufanya nini? Si Naima. Anafanya Naima kwa. Naima. Naima ndo anafanya basic.
Naima ni kwa download.
Naima.
So how is it what basic this one?
Basic, yeah.
Or this one?
Yeah, that one. And what's it?
The fully shows, yeah. When you go, whenever you have time, 5 minutes, 30 minutes, small thing. Come on. Any happening, but yeah. Yeah. It all comes from time. Yeah. Kuna basi watu walikuwa na hiyo wanataka
On a betrayal head full of zombies. I met a strange lady. She made me nervous. She took me in and gave me breakfast. She said, "Do you come from a land down under?" Together. Line bread from a man in Brussels. Far and full of muscle. I said, "Do you speak my language?" He just smiled and gave me a Vegemite sandwich. He said, "I come from a land."
No, don't like that.
Much to say. I come from Yes.
Okay, guys, we are starting again. As you know, life is short. Hello, ma'am. So you're related to
I don't know whether this was done purposely or unintentionally, but I've been given the first lecture post-lunch, which is not very good time for me. I have to do a more than hard work to keep you alive. And why should I do it alone? So let's do it together. Let's stand up. So I noticed that the second row, you are good. The first row, you're good. The third row is a lone person. The fourth row, you are good. The fifth row, you are a lone person. The sixth row, you people are good. So the one who were alone, they can come and join in front here. In front. So in front, there are only two people. Can you come and join them? Thank you. Some rearrangement. Let's do it. Let's do it quickly. And this is not the part of my lecture. We are just still warming up. Adamji, this should not be counted in my minutes. No. So you are you are alone now. I want to do a mini exercise with you people. I need you to be only two of you are fine. You can join others then. Can you just join the back benches? Okay. So now the first assignment to the groups. So there is group A, B, C, and D. Okay. Are we together? You are four groups. So the first group, arrange yourself in terms of your age. Quickly, you are given only 1 minute. Arrange yourself in terms of your age. Quickly. Start talking among yourself. And whichever group is ready, just point your finger up. Each group. Who's done? Okay, good. Tell us. Okay, exercise is over because one group is already done. One group is done, so it's over now. It's over. Can we listen to the group which was done? Yes. Start. In terms of age. Oh, excellent. Clap hands for them. Okay, now arrange yourself in terms of height. Who's done? Okay, excellent. Can we all look at the back benches? Have they arranged themselves nicely? Yes, okay. Clap hands for them. Okay, lastly, please arrange yourself according to the numbers of the children you have. If you have none, then it's 0. Done? Okay, okay. Okay, so the second row is done. Let's start. Oh. Excellent. Okay. That's enough. Can we all sit then? I think we're active enough now to listen, right? So my work today is to deliver a talk on a basic mechanical ventilation. And as the word written basic, this is really basic. This is for somebody who has been like introduced to ICU for the first time and they are going to see the vent for the first time. So it's really basic stuff and it's going to be very useful for the nurses if you're attentive. Please, there are some mathematics involved here. So stop me when you think that I'm not clear or things are not clear. Okay? All right. This works. So what we are going to discuss today in this topic is a bit of physics, which is not my favorite topic, but a bit of physics and basic concept about the ventilation. And lastly, but not least, about a complication that might one person get when you have kept them on vent. So coming to physics, consider the diagram there. Who can guess what the diagram is about? When we are talking about physics, and I can point to some person who attended the class together, and they can tell me what that is. Shamim? Excellent. So this is all about, when we are talking about this, is about so this one here is from the mouth all the way to the alveolar, and this part over here is alveolar. So when we are talking about ventilation, is like we are trying to, when we talk about mechanical ventilation, is we are giving a vent or a respiration to somebody who's not able to breathe on their self. Either they are breathing sluggishly or they are not able to breathe at all. Okay? So that is where the mechanical work comes to. And when we are trying to do that, we have some pathway to go through in order to make sure that we are giving the enough inflation breath to the person who are we ventilating. So, as Shamim said it quite well, this is the airway pathway and this is the alveolar. So, when we have to go through giving ventilation breath to here, there are some things which we need to consider in the airway, which is flow and the resistance. So, how much flow we are giving and what are the resistance which we are going to face. And then on the alveolar is mostly about volume and the compliance of the alveolar. So, when we are doing the ventilation setting, these are the parameters we are supposed to be looking into in order to give sufficient or successful ventilatory breath to the patient who we are keeping on the vent. Okay, what do we mean by compliance? Anybody? Yes. Yes. Yeah. Just try. It's okay.
Expansion. Like I think it's like the alveolar expansion. Like
Yes. So the ability for the alveolar to accumulate the air is what is known as compliance. Okay. Is that clear? Yes. So, and the volume is the amount of air which is going into the alveolar. So when we talk about When we talk about the inflation pressure, this is the formula which we are going to deal with it throughout our ventilation to the patient. And that's why I told you that there's some of the maths which is involved. So in order to give a successful inflation pressure, we have to look into flow times resistance. And then you add it with the volume over compliance. Okay, so these are the parameters which we are going to use in our setting to alter or to change in order to make sure that we are giving enough inflation pressure. So when we are talking about the pressure of the airway, again, it's the same thing except that we have added the baseline pressure. If you remember that your alveolars are always expanded form, right? They are never collapsed. So there is a baseline pressure which keeps your alveolar in a expanded form. That is called PEEP, right? Do we all know about PEEP? Yes? Can you tell me the definition of PEEP? See, it's okay if you don't know, say, I don't know, pass to somebody else. You want to pass it? I can't see your name. Is it Salima? Who is it? Saliha. Salha. Yes, Salha. It's really fainted for us with wearing glasses. Yes, Salha? No? Okay. Anybody else? What is the definition for the PEEP? Yes? Yeah, try. It's okay.
So PEEP is a pressure which remains in the alveoli to keep them open once gaseous exchange is taking place, so they won't collapse.
Yeah, so what is the long form for the PEEP? What does PEEP stands for?
Positive endo-expiratory pressure.
Excellent. Okay, so are we all together? So be familiar with this terminology because these are the terminologies which you are going to find on your vent. And this is exactly what we are going to change when we want to do the setting for the vent. So this formula is very important. Now, in coming to the next, we have already talked about this. Now, if we don't have any problem with our airway, we have only problem with our alveolar. This is what is known as pressure of the alveolar. Okay, and this is determined by the volume, compliance, and the PEEP. Whereas the throughout airway is like it is measured by flow times resistance plus volume and the compliance. Okay, but when you're talking about the pressure in the alveolar, the only determinant of it is volume, compliance, and the PEEP. Now, when you talk about this formula, there are some variables which you can change, but there are some variables which you have no control over. For example, the one you see in the red ones, right? The resistance and compliance. Usually resistance and compliance is the disease which the patient have. Resistance such as, which disease a patient can have? COPD, asthma, excellent. So those are the things which you don't have any control over them, but you have a control over the flow, you have the control over the volume and also over the PEEP. But when you talk about the compliance, usually which disease a person can have in the alveolar? Pneumonia, ARDS, fibrosis, excellent. So those are the things, right? So as we say that we can change the pressure, we can change the flow, or we can change the volume. And that is where the modes are coming into. The modes of the ventilator, which I think will be talked later on, is either volume dependent or pressure dependent. And this is where we are going to talk about these three variables. Okay, so that we can only change at par, you can change 2 settings in the ventilator and not all 3 settings. Okay, so when you talk about the volume is determined by the flow and time. Okay, and coming to the ventilator, the main purpose of the ventilation is to bring the oxygen in and to get rid of the carbon dioxide. Now, which are the variables which you are going to monitor or alter or play with, in other words, in order to make sure that you are giving enough oxygenation to the patient and you are eliminating enough carbon dioxide from the patient. So those are the two variables. And for the nurses now, here is where you need to be taking care, because the doctor will set the vent and leave. But it's upon you now to recognize. I think we are going to do it tomorrow, the troubleshootings of all the things which are going to appear, which now you need to alert your doctor so that they know exactly what is going on with the patient. I have a very interesting case just 3 weeks ago. The patient came with a status epilepticus and she was pregnant with 35 weeks. Also, the baby died and she came post-delivery. And we managed her and we were able to secure her airway, put her on the vent. She was oxygenating fine. Her feet came under control. But over the night, she passed away. And when we were trying to see the reasons why did that happen, throughout whatever we had managed, however, everything was fine. Her renal were fine, her liver were fine, the feet were under control. She was kept on ventilator, so airway was secured. We were not able to do the ABG at that moment, but later on the nurse agreed that when she removed the tube from the patient, it was full of clot at the end of the tube. And the ventilator, when we went back to the ventilator, it kept on saying high airway peak pressure. From morning, it was Sunday, so no doctor did a ward round during that day. At night, she passed away. So these are the things which we need to know as nurses, so as to alert the doctor, say there is something wrong. Don't take the alarm very lightly. In other words, okay? So let's see the determinant now of what will help us to do a proper oxygenation and what will determine to remove or eliminate carbon dioxide when we are keeping the patient on the vent. So the very three important things in determinant of oxygenation is your inspired oxygen, the one you set in the vent, you know, the FiO2. I think we'll do the practical later. You will see that. And also your mean alveolar pressure is also another parameter which you are going to deal with it. So once you have set your inspired FiO2 and your mean alveolar pressure, you're good to go with your oxygenation. Now, when you come to the mean alveolar pressure, there are three things which you can change in the ventilator setting in order to increase the mean alveolar pressure, so as to increase the oxygen in the giving the oxygen, proper oxygen to the patient. When it comes to the carbon dioxide, is mostly about the minute ventilation, which is the product of respiration rate and tidal volume. So when you want to get rid of carbon dioxide, these are the two parameters in the vent which you can play around, either increase or decrease in order to eliminate the carbon dioxide. But when you come to the oxygen, these are the very three important: FiO2, your mean alveolar pressure, which is determined by the PEEP, tidal volume, and inspiratory time. Okay? This terminology, don't worry if they are very new to you, because we are going to do the practical. We'll even explain more in detail. When you see it, you will understand more. How many of you have seen vent before today? Okay, so most of you, which is good. Okay. Those who have not seen, it's okay. We'll do it during practical. So when we talk about the PEEP, now one thing which we get most of the time in ICU, our patients have diseased lungs. Either they have pneumonia, or they have atelectasis, or they have pneumothorax, or they have any other condition, COPD and stuff like that. So PEEP is the best indicator of increasing the mean airway pressure. Why? Because it overcomes the shear force. Or in other words, it overcomes the trapping of the gas. Okay, so it is the only it's out of those three, the tidal volume together with, what did we say, another one? PEEP. The third one was inspiratory time. So out of these three, PEEP is quite safest to change when it comes to increasing the oxygenation. So improving, what does it do is that it reopens the alveolar and keeps them open, and at the same time it decreases the shunting, which was very much explained by in the morning, the first lecture. Okay. As you can see here, it has increased. The mean airway pressure has increased by increasing the PEEP. The second one, which is the tidal volume, that also raises the alveolar oxygen by lowering the alveolar carbon dioxide. That is how the tidal volume actually helps to increase the mean airway pressure. And the third one is the inspiratory time. Now the inspiratory time is good, okay? Like if you're increasing, remember that inspiratory time is, how do you increase, what ratio do you see in your vent when you're talking about inspiratory time? Is the inspiratory expiratory ratio. So the only variable you can change is the inspiratory time, whereas the expiratory time is the remaining time of breathing. See, remember, we breathe in and then we breathe out. The only problem with that is that it causes the synchrony. Why? Because we are usually used to inspiring in a shorter time, but expiring in a longer time. Now, when you're keeping the patient on the vent and trying to increase the inspiration time, you're actually causing the dyssynchrony. And for that, you need to increase the sedation. Are we together? But at the same time, by increasing inspiration time, what you are doing is you're causing more gas trapping. So those are the two things which you need to focus, also think about when you're trying to increase your inspiration time in order to increase your mean airway pressure. Are we together? Are we together, Yamani? Okay. So, as we said that this is, I think I usually talk before the slides, so I'm sorry about that. But again, this I've talked about. Now, when we're talking about the complications associated with the vent, right? So usually you can divide them into three main groups. One is the nosocomial infection. So the ventilated associated pneumonia, which can happen to patients once they're on the vent. So you can they can get them because of either being on prolonged ventilation or because of the unhygienic way of putting the patient on the like the tubings and not using the humidifier properly, and all those things can cause the nosocomial infection. The second one is the ventilated associated lung injuries, and those are like which ones? They can be one, barotrauma, two, volume trauma, and the third one, shear injury, right? Isn't it? And the last one is the gas trapping. So those are the three main complications which you should look over every day when you're putting your patient on the vent. You make sure that you're ruling out those complications, okay? Are we together? Sir. Okay. All right. I didn't do that. Something happened. Yes. Oh, yeah. We'll talk about it. This is the next slide. So there are also cardiovascular things which we can go wrong when we are talking about the vent. Did I completely? Oh, good. But this thing is working, by the way. Okay. So when we're talking about the gas trapping, okay? Now, what does gas trapping actually do? It's like when you are allowing a lot of inspiration time, or for whatever reason, the gas has been trapped into the alveolar, it causes the expansion of the intrathoracic pressure, okay? And what else is in your chest is the heart, right? So this also goes and affects the pathophysiology of the heart. So what it does is that, okay, these are just the predisposing factors. Okay, before talking about the cardiovascular, let's talk about another concept which is known as inspiratory PEEP, intrinsic PEEP, sorry. So what happens in the gas trapping is that because of the hyperinflation of the alveolar, there is a rise in the end expiratory pressure, which is known as intrinsic PEEP. Now that intrinsic PEEP is the one now which will lead to the cardiovascular problem. So what is the intrinsic PEEP? So what happened is that at the end of, if you have the wavelength that is in your vent, some of the vents, they don't have the wavelengths. So if in your vent there is a wavelength, after the expiratory, inspiratory, expiratory, you cause the pause in the vent. Once you cause the vent onto the pause, you will see if the line appears, comes in here, then there is no what is known as intrinsic PEEP. But if the line tries to go up here, then there is a creation of intrinsic PEEP. This is again a bit difficult concept if you are listening for the first time, but as we will continue talking about, you will finally understand. So in other words, what I'm trying to say is that at the end of your expiration, you cause a pause in the vent. You put the vent on the hold. Then once you put the vent on the hold, if the line appears here, then there is no intrinsic PEEP, means there is no gas trapping. But if the line comes up here, then that means to say there is an intrinsic PEEP. And what you need to know is actually, just remember total PEEP. Total PEEP is intrinsic PEEP plus extrinsic PEEP. Extrinsic PEEP is the one which you have set on the vent. Remember, there is a PEEP sign, right? Which you set either 5, 6, or sometimes 3, 2. But when you find the total PEEP on your machine says more than maybe let's say 16, 17, then you know that there is an element of intrinsic PEEP. Normally it's below 10, but if it is more than 10, then you know that definitely there is some gas trapping. Are we together? As I so told you, this is a difficult concept. It took me over and over to understand. So it will take you time to understand it. But as we'll do the practical, you will understand it more. Okay? You want to say anything? No? Okay. So as I told you that the adverse effect of the gas trapping is the barotrauma and the cardiovascular compromise. So what happens to your cardiovascular effects is that if you remember, there are 3 parts of the cardiovascular which we need to look after. There is a preload, there is the contraction, and then there is a afterload. Okay. So what happens is that when we have the gas trapping, it actually decreases the afterload. Why? Because the transmural pressure in the left ventricle has decreased. And due to that, there is a decrease of afterload. That also causes what? Hypotension. Okay? But at the same time, it also decreases the preload by decreasing the vascular resistance. If the vascular resistance decreases and the preload decreases again, it causes what? Hypotension. Now that effect is good to somebody or a patient who is in a heart failure, because that's exactly what we want, right? We want the decrease preload and the decrease afterload. But in a person whose heart is in a good condition, that will lead into hypotension. Are we together? Okay. So this is exactly what they are trying to say, that this pressure increases, and if it increases, then it causes the decrease in the afterload. But at the same time, it also, the contractivity, it can be either decreased or normal. That now depends on the patient's heart conditions. But if it is decreased, then it will increase the cardiac output, which is good. But if it is in a normal contractivity, then your cardiac output will decrease. Remember, one of the compensation of overcoming the preload and afterload is for the heart muscles to contract, isn't it? So that way there'll be no problem. But if the heart muscles are also not contracting well, then it will cause even more hypotension. So when we are talking about hypotension, consider those cardiovascular problems due to the gas trapping, but also it can also be because of the drug induced. Remember, we use sedations, we use strong painkillers like morphine and fentanyl, but we also sometimes use other medications such as I said, sedation, which can all cause hypertension. But one of the other thing which can cause hypertension is your tension pneumothorax. Remember, one of the complications of your ventilation is barotrauma, isn't it? Excellent. Any questions? So who can summarize for me what I talked about? Was I talking or was I bluffing? Just summarize. Shamim? 1 point. Any 1 point, just say. Excellent. Second? Lamek? Flow. We talked about the flow. Excellent. The pressure, the volume, and the PEEP. Excellent. 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 Anybody else to add on it? What are the complications of the patient who is kept on the vent? We group them into three. One, barotrauma, gas trapping, volume trauma. Okay. So this is summarized by you people very well. Remember, the pressure in the airway, the determinant is the flow, resistance, volume, compliance, and the PEEP. The partial pressure is mainly determined by FiO2 and the mean alveolar pressure by adjusting PEEP, inspiratory time, and the tidal volume. And the partial pressure of carbon dioxide is determined by the minute volume, which is the respiration rate and tidal volume. Asante ni sana.
Yep. That's pain, isn't it? Okay. I think I'll just start. Does it come up when you? Yes. Yeah, I did this morning. But I've sent it to your Hotmail, but I've just sent it to his Gmail. I've sent it to your Gmail as well. Okay. All right. While we wait to get this opened up, sorry about that, everybody. I thought it had gone through this morning. So I'm going to talk about modes of ventilation. Now, all of you have said you've been worked with a ventilator before. So I'm going to try and keep it really simple because it's easier to talk and discuss at the skill stations with the ventilator in front of you than to explain on a PowerPoint. So all of you have worked with a ventilator. What modes of ventilation do you know? How would you classify modes of ventilation? Anybody? What do you set when you have a patient on a ventilator? You want to say something? Tell me, anesthesia, isn't it? What do you set in your hospital? Yes. Pressure and volume. Everybody knows pressure and volume? Really easy. Okay, there's really only two. There's only two mandatory modes that are really the ones you need to know. A pressure mode, you set a pressure. A volume mode, you set a volume. Okay, good. Excellent. Lovely, thank you. So when we talk about a volume mode, we set a tidal volume. What kind of tidal volume is a safe tidal volume? 6 to 8 mils per kilo. Actual body weight or ideal body weight? Ideal body weight, perfect. What kind of respiratory ratio are you setting on the ventilator? How many breaths per minute? Roughly. 20, 18. Yeah, it's a range, isn't it? I mean, usually we would go maybe 12 to 16 breaths per minute, but sometimes we have to go to 20. Okay. So often those are the basic settings, and then you put FiO2. FiO2 initially, you put the tidal volume, you put the respiratory rate. Most ventilators automatically will calculate your IE ratio. Some of them you have to put inspiratory time. If you put your inspiratory time, it will calculate your IE ratio. Okay. What IE ratio do you usually have on your ventilator? 1 to 2, did you say? Everybody's setting 1 to 2 roughly. Okay. Probably most of the time that's adequate and appropriate for our patient. Of course, unless which pathology are you going to have a higher IE ratio? 1 to 4, 1 to 3, 1 to 4, 1 to 5. In which type of diseases? COPD? Which is the other one? Similar. Asthma. So asthma specifically, you put a really long IE ratio, okay? You want them to, because asthma is where gas trapping happens, which we've seen on that slide. So you worry about gas trapping. They need a lot of time to squeeze the air out because there's a lot of narrowing of the airways. So you have to, like, you hear that wheeze. And often they need an expiratory time of sometimes 4 or 5 seconds. So often you just have to give them a respiratory rate of 6 or 8 breaths per minute so that they can have a really long expiratory time and no gas trapping happens. Okay. That's the main danger with asthma when you ventilate asthma is you get gas trapping and then you get hemodynamic instability. All right. Good. So pressure mode. What do you set in the pressure mode? What's a safe pressure? Below what pressure? Plateau pressure we talk about. You're saying something there? Less than 30. Yeah. So plateau pressure and peak pressure are different. Plateau pressure less than 30 is safe. Okay. So we talked about volutrauma, barotrauma that we can happen with just being on a ventilator. So if you do safe volume, 6 to 8 mils per kilo, you're going to avoid volutrauma. If you do safe pressure, less than 30 centimeters of water, you're going to avoid barotrauma. Okay. Do you know the difference between peak pressure and plateau pressure? Anybody? Anybody? No. Okay. Your peak pressure is the highest pressure initially the ventilator delivers to overcome the resistance of the airways. Okay. So if you can imagine, like you're blowing a balloon, you have to put a lot of force initially to blow the balloon out. Yeah. And that initial balloon, so the resistance of the airways, you have to put a lot of pressure. But that peak pressure initially is not the pressure delivered to the alveoli. Okay. So it's peak pressure is essentially to overcome the narrowing of the airway. And then your plateau pressure is the pressure that's actually delivered in your alveolus. Okay. And that is what you don't want to be over 30 centimeters of water. Okay. Good. So plateau pressure less than 30. Very important. Do you ever set a PEEP? Well, now we know what PEEP is. What PEEP are you going to set on your ventilator? You're going to say something, Anastasia? No? Anybody? 5. Does somebody say 5? 5. Yeah. So 5 often is probably not a bad starting point, but most of us, I mean, 5 is just standard. Yeah. And if you have a patient with simple overdose, no respiratory problems, just unconscious patient, 5 is fine. Yeah. But if you have respiratory failure as your cause of intubation and ventilation, then as you saw from that last slide, one of the ways to improve oxygenation is to increase your mean airway pressure. And the way you increase your, mean alveolar pressure, and the way you increase your mean alveolar pressure is to increase PEEP. So if respiratory failure and oxygenation is your problem, you generally go with a higher PEEP. Okay. And what the PEEP does, as we said, is keeps your alveoli open. Once you have bad lungs, you need a greater pressure to keep it open. Yeah. And we talk about the trauma of sheer stress trauma. That's when you have alveoli that are collapsed. You're opening them up. They're collapsing and opening, collapsing and opening. That kind of trauma is not good. Yeah. So you set a good PEEP to prevent them from collapsing. And often you need it higher. So often we would probably go 10 centimeters water, 8 to 10 centimeters of water if they're needing 50% oxygen. Yeah. Probably 10. All right, good. So we've talked about FiO2. What FiO2 do you set when you first put a patient on a ventilator? Sorry. You're going to say something, aren't you? That's okay. No answer is wrong. There's a few different ways to do this. Who sets 100%? Nobody. 50%. Nobody. What do you set on the ventilator when you first put them on the ventilator? How much oxygen? 60%. You try below 60, do you? And are you targeting in SATs? What do you target when you put your oxygen? PO2, so you do gases. Anybody target SATs? Okay. So how many of you do blood gases when you put a patient on a ventilator? 1. Anybody are 2, 3, 4. So a few of you do blood gases. Places blood gases are not available. What PO2 do you target? Do you have a target? 60 to 100. Yeah. So often you have a lower limit, don't you? You don't want below 60. So if it's above 60, you're okay. And if it's really above 100, you should come down on oxygen, shouldn't you? Yeah. So most of us are happy, 60 to 80, we're happy. Okay. We often will also target SATs because we don't do gases every minute or every hour. It's nice to do one at the start. Maybe in a couple of hours you do another one. But as we all know, 1, they're expensive. 2, they're not available everywhere. So if oxygenation is your problem, SATs is a good marker as well. Okay. So depending on the patient, we would just target SATs of 94% for most patients, above 94 and above. 94 and above. If they have COPD, 88 to 92. If they have bad pneumonia and ARDS, 88 to 92. Okay. Because you're struggling to oxygenate them already, you don't need to overdo it. SATs of over 88, your patient won't die. Yeah, if you're on 100% oxygen already, you can't give them any more. But if their SATs about 88 to 92, or even 88 to 90, okay, you're doing enough. Yeah, you try and overachieve SATs of 94%. You're going to you're going to do a lot of harm on the ventilator with the settings to try and get there, and you might not get there, but you'll cause more harm. Okay, so just always when you set your ventilator, you have to have targets in mind. What am I trying to achieve for my patient that's going to keep them safe, going to keep them alive, and not cause harm? Yeah. So we set an oxygen. When I first intubate the patient, often I will be 100% if they're in bad respiratory failure. And then once they're on the ventilator and they recruit on the ventilator for a little bit, the lungs are opened up a bit, the alveoli are opened up after an hour or two, I wean. And I say to my nurse at the bed space, wean the oxygen to a SATs of greater than 94 or to SATs of 88 to 92. And then they will just wean it and bring it down. Okay. Good. All right. So I think that covers most of my talk, but there's a couple of extra settings that are available on a ventilator that you can add. So we talked about oxygenation. We talked about mean alveolar pressure. And the way you can do that is by FiO2, PEEP, and inspiratory time. How do you set inspiratory time, or what do you set on your ventilator if you have to set inspiratory time? Sorry. Anybody? IE ratio. Do you set IE ratio? Anybody set inspiratory time on their ventilator? You just set IE ratio. Okay. So some of the ventilators, so if we talk about increasing oxygenation, you can set inspiratory time. Because some of the ventilators will let you do that. If you don't set it, it automatically defaults. I think the default might be, it depends on your ventilator, it might be 1.2 seconds or something is the default. And it automatically, based on the respiratory rate you have set, the default inspiratory time, it will give you that IE ratio. But if you set an IE ratio of 1 to 2 and your respiratory rate is 20, so let's say you've set a respiratory rate of 20, that means your respiratory cycle is 3 seconds. And then you've set 1 to 2, which means you're going to have 1 second for inspiration, 2 seconds for expiration. Yeah, so it's quite a short inspiratory time. And that might be okay for most patients who don't have bad pneumonia, bad lungs. If you have an oxygenation problem, you could increase your inspiratory time, which means you're going greater time of increasing the amount of time that your lung is in inspiration. And it allows those alveoli that are a little bit more collapsed, that just need that extra bit of time to open. Okay. And so you increase your inspiratory time a little bit, and that's how you can help improving your oxygenation. It helps open your lungs up a little bit. Yeah. Does that make sense to people? Yeah. So that's what we're trying to do by increasing our mean alveolar pressure, is helping those alveoli that aren't opening straight away, that have collapsed in between, to open up. So you want to stay in inspiration a little bit longer. So it's not uncommon that I might set my ventilator. I've got bad pneumonia, bad respiratory failure. I'm on 70 or 80% oxygen. I'm setting my inspiratory time at 1.5 seconds. 1.6. Okay. And often in those scenarios, that means my IE ratio is going to be a little bit less. Might be like 1 to 1.5. Okay. And that just allows my oxygenation to improve a little bit. And I'm not worried about my expiration so much. Because not everybody has asthma, and not everybody has COPD, which means not everybody has to have a long expiratory time. And most of the time, my CO2 will still clear okay. Yeah. And CO2 is not my primary problem. Does that make sense? And sometimes if I've got a really bad respiratory failure and I'm just trying to give enough oxygen to keep the SATs and the PO2 above 60, SATs above 88, I might even allow the CO2 to climb a little bit just so I can maintain oxygenation. Because a slightly high CO2 is not going to kill me, and the patient will tolerate it. Yeah. Okay, so that's pretty much most of the settings that you would put on a ventilator to get them started. And if respiratory failure is not your patient's problem, setting 1 to 2 IE ratio is enough. Whatever the default inspiratory time, the patient will be fine. And you look at your gas and then reassess. Yeah, it's just when pneumonia, like bad respiratory failure is a problem, I do set inspiratory time. Any questions about those? Okay. What happens when your patient starts to breathe? Is there another mode or another thing you can add on the ventilator settings-wise? Anybody? So a mandatory mode is your ventilator doing everything. It's giving 20 breaths per minute, tidal volumes of 400, oxygen 50%. Okay. But now my patient has got better. I'm down to 30% oxygen, 25% oxygen. My patient is starting to breathe a bit because I want to try and wake them up. You want to say something, Anastasia? What do you set? Spontaneous. You have a third mode. That's not a mandatory mode, and that's called spontaneous mode. Okay. The patient starts to breathe. And this can even be during the mandatory mode. Your patient starts to breathe in between. You can set what we call a pressure support. Everybody heard of pressure support? Yes? Good. So we always set a pressure support because there will be a time when my patient starts to breathe in between. And if I give them a little bit of support every time they breathe by setting a pressure on the ventilator, that means that they're getting a bit of help. Yeah? And the more the patient is better and the more I want them to breathe themselves, I reduce the mandatory breaths. I cut the mandatory breaths to 10, or I might even completely switch them over to what we call a pressure support mode or a spontaneous mode. So no mandatory breathing, just spontaneous breathing, where the patient is triggering every breath. What does trigger mean? Yeah. Yeah. Good. Exactly. So trigger means how does the ventilator know the patient is trying to breathe? Okay. What does it detect? And that waveform you talk about, you can set on the monitor, you can set on your ventilator. You can set either a flow trigger or a pressure trigger. There's two ways. Flow trigger is more sensitive, where you set 2 liters per minute. So if I'm trying, I'm going to generate slightly negative pressure or slightly negative flow or flow in the opposite direction when I try and breathe. And that ventilator detects. So you can set it as a pressure of 2 or 3 centimeters of water or a flow. Okay. So if I set a pressure of 3 centimeters or 2 centimeters of water, if I'm trying to breathe and I just generate a tiny bit, you don't need to generate much to get 2 centimeters of water, the ventilator detects it and straight away it knows the patient's trying to breathe. Let's give it a pressure support breath. Let's give it some pressure support. That's what triggering is, how the ventilator knows I'm trying to breathe. Okay? Good. So then it gives me a pressure support breath, and it helps the patient be synchronous during mandatory breathing, or when they're completely on a spontaneous mode, it helps the patient's breath. Okay, so it keeps them supported. And that's how we often will wean a patient. We generally wean a patient on a pressure support mode. Okay, not on a mandatory mode. All right. Good. Okay. How does the ventilator know to go from inspiration to expiration? What is that called? There's a term. Anybody know? Have you heard of the term cycling? No. So on a mandatory, we've already said IE ratio, inspiratory time done, the ventilator goes straight away to expiration. Expiration is passive. Okay. Just as we're breathing right now, our inspiration, we're generating negative pressure, the air is coming in. Our expiration is passive. Similarly, on a positive pressure or ventilator, it's pushing air in, positive pressure, but expiration is passive. Okay. So the ventilator decides if it's IE ratio at a certain time when the inspiratory time is finished, it cycles to expiration. So you can cycle on time based on your inspiratory expiratory time. You can also cycle based on flow. Okay. Now, if I'm spontaneously breathing, which is more relevant when you're spontaneously breathing, I'm inspiring and my flow initially is high, and then my flow is starting to drop as my volume is entered in my lung. My flow starts to drop. And I have set, you can set the ventilator that when the flow drops to 50% of the peak or 25% of the peak flow, you change to expiration and you allow passive expiration to occur. Okay, and that's what's called cycling. And you can change that where it changes based on the pathology. So if I've got bad pneumonia or whatever, and I want to have more time between inspiration and expiration, I might change that cycling flow to be lower. Okay. If I've got COPD and I want to have a shorter inspiratory time during spontaneous and a longer, I might change that threshold. Okay. So that's something else you can set on a pressure support mode. Okay. But otherwise, that's pretty much most of the common things you can do on a ventilator. And then there's lots of fancy things, but we don't need to know fancy because simple is better. The sicker your patient, the more simple you should set your ventilator. Okay. The more we complicate things, the worse we do for our patients. Because then even we get confused and the nurses get confused and we all need to be on the same page. Does that make sense? Any questions? Okay, I think that's my talk done. I didn't go through any slides, even though I wrote all these slides. I'm just going to check that I haven't missed anything. And I'm just going to go to the final slide, which is basically to summarize. Mechanical ventilation in one slide. Okay. Pressure versus volume, we talked about. Mandatory versus spontaneous, okay? So you start in mandatory, as they get better, you move to spontaneous. Oxygenation and ventilation. Ventilation is CO2 control. Oxygenation is keeping the oxygen level up, okay? So it depends what you're trying to do. Don't forget the heart, which I haven't even talked about, but it was on your previous talk, okay? Safety rules. Plateau pressure less than 30. Tartar volume 6 to 8 mils per kilo. Enough oxygen, not too much. So 88%, if you really are bad and you cannot get the SATs up, 88 is enough. Okay? Or PO2 of 60 is enough. Don't overachieve. But as you start to get to the lungs getting better, you can wean a bit more. And yeah, but if you're otherwise managing to go 94, we go 94 as standard. Good. Yes. Yes. How do we wean the oxygen? Is that roughly the question? How would I change it? So often, obviously, if it's bad respiratory failure, if they've just been intubated, often during intubation, they desaturate a little bit as well, and they de-recruit. Yeah? Does everybody know what de-recruitment means? Okay, so de-recruitment is basically where your alveoli have collapsed down again. So when your patient is breathing, they're trying to keep the alveoli open, but through negative pressure and keeping it open. Then we paralyze them, we sedate them, and then we intubate them. So basically everything collapses down. And now we have to open it up with positive pressure. That takes time. So once you put the tube in and you set them up on the ventilator, it takes a bit of time for the alveoli to recruit back up again. So I usually start at 100% and I see where I'm at with my SATs. Okay. If my patient didn't desaturate too badly and their SATs are only 92, 94 after intubation, I maybe set the ventilator at about 80%. Okay, and see where I go. But if they did desaturate, I know I just go to 100. I see what the first hour looks like. I see where their SATs are. The SATs are starting to come up over that hour and they get up to over 94. I start to wean. Okay. I often go, I say to the nurses, now I'm a bit more aggressive. My nurses are a bit slower. It doesn't matter. They may go by 5% at a time. I go easily 10 or 15. Depends on how generous the SATs are. Okay, but you could go slow. 5%, they're still fine after 10, 15 minutes. You can go down a bit further. Okay, yeah. And going by 5% is fine, as long as you're just bringing it down slowly, checking your sats, going further. Yeah. So that's how I would do it. I do start at 100 and come down. And then when I can see that I drop my sats and they drop down to 86, 85, then I know that I've probably gone a bit too low. Then you might need to just go back up again just to find where's the good happy medium. Also, if your patient coughs and starts to become desynchronous, you might find that they desaturate every time, especially initially. So then you just get big dips in your sats every time they're coughing, every time they're becoming desynchronous. But then you might have to just allow your FiO2 to be a little bit higher, just to allow those to prevent the dips to be too low. Yeah. Massive pleural effusion. Yeah. Yes. So compliance, yeah. So compliance is going to be bad. So if you're doing it for respiratory failure, probably most of these patients' compliance might not be so good. So if it's for a pleural effusion and they've ended up intubated, you probably want to drain the effusion, I guess, as best as possible. But yeah, I would still aim for my safe ventilation. And I often, like I say, let's say it's not a pleural effusion and it's just bad ARDS. There's nothing to drain. So then, like I say, I try and accept I'm on 100% oxygen. My sats are only 87%. I do my inspiratory time a bit higher. I have a better higher PEEP, maybe 12 of PEEP. I try a few different things and I accept that my CO2 might not be as controlled at the expense of maintaining oxygenation. So my CO2 might be 55 even because I haven't got enough, expiratory time. But it means that I'm allowing my lungs to inflate and improving my mean alveolar pressure, then it's at the expense of CO2 control. Yeah. So the respiratory rate I lower so I can have greater inspiratory time. Any other questions? Does that all make sense? So we'll probably break out into groups. They're all chatting. So we're going to break up into 3 groups, and then we're going to do skill stations, which is much easier when you have a ventilator in front of you, and we can go through things. So are you happy if I split the groups, Ramadan? Okay, so there's 18 of you. Okay. Yeah, so should we just go the front 1, 2, 3, 4? Yeah. Okay, so you still want to do the 4 stations? Yes, please. Thank you. You move much better at doing it for me. All right, wonderful. I'll start setting up the station.
So what we are doing now is you start counting 1 up to 4, then again 1 up to 4, then again 1 up to 4, okay? So, and then you remember your number, okay? Okay, so all ones, where do all ones go to? All ones can go to that station. Just stand up right now. Only ones, yeah? Only ones stand up and go to that station. Quickly. Okay, all the 2s stand up. Then you go to that station. Okay, all the 3s. No, 2s go to that station. Sorry. 2 that station. Yes. All the 2s gone. Okay, all the 3s now were to this station where Dr. Aisha is. All the 3s stand up. We stand up for our right. Quickly. Okay. 3s are ready. All the 4s. Now you go to the middle station. Thank you. Hiya.
Hello. Hello, 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 hello. Hello. Hello, 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 hello. Hello. Hello, hello. Hello, 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 hello. Hello. Hello, hello, hello.
This station is thinking.
Yeah.
After that, they rotate.
Yeah.
But they have to,
Yeah.
each group has to go through all 4 stations,
Yeah.
right?
Mm. Hello, 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 hello. Okay. Mike. Wait. Tutawapatia nani muda usijali.
Alafu did you know that you can use aid in intubation?
Yeah.
Yeah. So if you are having a difficult intubation case, just insert this one, alafu unatumia kuweka the ET tube.
Which is smaller.
Yes, a smaller ET tube, and then you remove it. Itakuwa inakusaidia difficult intubation. And then it's recommended for single use. But
ndio hivi plasma sterilization.
Yeah, you disinfect, alafu unaweza kuitumia tena. Unaweza kutumia kwa hiyo difficult intubation cases, alafu at the same time kwa hizo short procedures. Recommended.
Sikia. Richard. Yaani hapa hii kamera ilikuwa ili ku move around. Yaani unaonesha watu
Nitegese moja tu hapo nyingine
kwa sababu angalia hapa inatoka sasa.
hii akili imetoka.
Ipo yani pili, yani kama unataka kuweka then we can keep.
Ile pesa.
Okay. Okay. Sawa. Sawa. Okay.
Yeah. So we start with the scenario number 1. Your patient was recently intubated or respiratory failure. So the medical team inform you that on the course post-intubation just X-ray, the ETT is in correct position, but needs to be advanced ventilating. So, tell us, how are you going to do that?
So this is the patient. So then this is the steps after intubation. Yeah, I know we have said that we have to correctly get the where the tubes auscultate, epigastric, 5 points. Okay, and even it is CO2 if it is available. If not available, then it's fine. But later on, at least chest X-ray has to be done like the way Dr. said. Now, the radiologist says the tube is advanced more further. Where it is will be advanced more.
This one, machine.
Sorry?
It has to be precise because it's higher. So it should be 5 centimeters above the carina. That's the
Okay.
thing.
So what are the steps that she's after? Who is the patient? Yeah, so it is secured at 18, yes. And this is totally ballooned up. So consider this is balloon. Okay.
I think you will unload it first.
Yeah.
You will be comfortable.
Yeah.
Then you get five seconds.
Okay.
Have to do the 550 point and then you have to correlate your weight and fats. And then maybe do another experiment.
Nice.
Which
How often should mouth care be performed in intubated patients? Mouth care. This patient is intubated. How often will you use mouth care? Kwa nini ni muhimu nafikiri kufanya hivyo? Au inasaidia nini? Yani kingine muhimu zaidi how about infection? Niambiwa pale kama ya prevent infection. Okay, at least 4 hours, tunasema 3 hours. Kama una staff ya kutosha, you can do that. Now, how do you ensure that it is safe and secure when we position ventilated patient? Mfano asubuhi labda inamuonyesha wagonjwa mnataa nao utahakikisha shughuli yako iko secure. Utafanyaje? Unafanya ufanyaji peke yake? Yeah, because mimi na experience sometimes unajua kule theater yetu ile zamani ndo ICU ilikuwa vile 2 rooms. Sasa tunasaidia kulaza wagonjwa ndio kifika tu sasa tube imetoka, yani siku zote kabla tunaenda kulaza wagonjwa naambiwa tube imetoka. Ndio ile wakati wa kutoa wagonjwa tube ina dislodge. Okay. We arrived at work and are caring for intubated patients. On the morning, medical round vaccine informing that the patient can be intubated. What will you do? Extubate, send your patient. What are the steps? This patient will go into extubation. So what are the steps we saw in order to extubate safely this patient?
Will they try?
Yeah, sure.
So the first thing is to assess the environment. One, to get the patient. So that we can prevent the trying to push back, put in the structure based on after the patients. Also, to make sure that there's no any suppression before extubating. Also, making sure that your body reflected the ETT properly. And I will need to prepare the patient.
You have to prepare extubation for extubate and roll.
Then you
So the course ambayo ilifanya yawe extubated imeshakuwa resolved. What else? Yani kingine muhimu? Kama alikuwa labda anasaidia kuimarisha support zote ziko escalated.
No, I'm not going to situations that everything. Because otherwise, when I used to meet the patient, you have to engage.
And the extubation.
They fail to have batteries which are reusable, or else this would have been a nice thing to have.
Disposable.
Disposable, I think.
Sometime maybe
You can clean this
then it's to get
according to them. If this was metal, it would only be better.
You will intervention with the things cost.
Question?
This is just a basic, at least to get acquainted with all these airway tools.
What you guys need to know is this. How to insert this, insert this. Insert this. First, tell me if this is the correct size.
Yeah, you mentioned about the measurements.
Because I'm Superman.
No. You mentioned about the upper. We can say method. Mpaka tracks. Kwa hii sausage, okay, sausage yake. Hapana, uangalie ingine. Hivyo sana. Chukua tu glue tu.
So glue. Chukua hiyo. Haya, insert.
Consider you have the KYG.
Yeah, you have positioned the patient well. So this is how you place the. So this part, this sharp part should not be facing the septum. It should always be facing away from the septum. Now, this sharp part. But whenever you insert, it's like as if you're doing a COVID swab. So okay, insert from like this, and then it should go straight down until inafika hapa, and you can ventilate through this. It's simple. And oral pharyngeal airway, how do you measure? Sure. How do you measure oral pharyngeal airway?
We measure from the angle of the mouth
Yes. How would you insert it now?
She already mentioned.
Ah, she did. Okay, fine. So the bougie, I mean, that's advanced, like, you know. And let's say you have a tube. Where is the tube? This is the tube, right? So how I would give it is I'll do this. Yeah. Then I would do this. Now this is my stylet. So when I insert, then I can just do this here, like this, then pull that, and then my tube is in. So that's how you can use it as a stylet, or you could do this. Okay. And this one, you have inserted your tube here. Let's say you have inserted your tube here. Now this is my snail's technique. So I'm going here. I enter, okay? Then I will do this. Then I'll insert like that. And then pull out my tube. So those are the ways I can use it. Instead of like putting it in first, then tracing, I can use it like that. So.
All right, time up?
Yeah.
Thank you. Thank you. This is the ETT holder.
It is to unaweka ndani. Yeah, I know.
So this is, not all hospitals have it. So this is just between the teeth. Yes, bite.
Like, what about if it's no dentures?
No, don't. So no point of keeping it.
Like this, and then.
And by the way, this is also painful.
So if your patient is not paralyzed and is just sedated, there is no need. Sometimes there is no need of it. If there is proper sedation, there is no need of this also. As long as if the patient is aggressive, then you might have to put this.
At my place, I put this.
Yeah. All patients.
All patients, especially except for no dentures. No dentures, because what helps, this part between the teeth, so they have an ability to bite. So they bite. Let them bite here.
Yeah.
So let them bite.
So you have this.
Yeah, I have this. But not this. This part is on this side.
Okay.
People are going there.
Karibuni. Karibuni. So try to look around. Okay, so this is an airway station. So these are the devices that from non-invasive to invasive devices are there. So just try to get acquainted. If you have a questions, you can ask, and then later on we can ask you what are these, what are not these. You can ask us. Yeah, or you can. That's right. Best to ask us. Suction machine, right? Perfect. Okay. So for those things that you are aware of, just mention those ones. Okay, mention. Oral. Yeah. Okay.
Stabilization mask.
Okay.
This oxygen mask. This oxygen. This is mask.
Okay.
This is mask.
Yeah. Okay.
Is good.
Okay.
This is toilet.
Yep. That's good. Okay. No.
This is for ETT holders.
Perfect. Yeah, it's ETT holder.
Okay.
He mentioned it. Yeah. It's written here.
Yes,
Combi tube or combination tube.
Before I used to know it's Kingston tube.
Yeah.
Now they say combi tube.
So why is it combi tube? Is because they are two. Like this will go to the esophagus, and this will, like this here, will prevent it from going further.
Okay.
And this here will like balloon up to the esophagus so that betway isiingie ndani. Na hapa kuna holes. There are two types of holes. So whichever part you see chest rise, that's the airway. Whichever part is for stomach, stomach.
You said MCG. You said there is a black line which represents.
This here. If you pass this, yani uingiza this line mpaka hapa, umeshaingia kwenye carina. Yani umeingia ndani. Okay. And then your lip should be here. So this is 8 times 3, 24. So it should be here. This is meaning that this should be near the carina, 5 centimeters above the carina. This one.
Oh, that's what?
This is this is manometer. This is pediatric
No, so this is more of a ventilator sensor. You don't have to. Okay, yes, yeah, very good question. Yeah. Dr. Asha was really eager to ask. Welcome to the trap.
I've never seen. Never seen?
Have you heard of Venturi mask?
Yes.
What can they even more
I've seen them just in different colors. In a vitu kama hivi, blue, red, green.
What do they represent?
I'm not sure. What is the answer? I think it's represent age, like Miss Willis and age something. Yes, age. Oh, so if you want to give 60%, 45, 30% oxygen to your patient.
Are they color coding or there is a number?
Yes.
Yeah, color code. Kuna chart zake zinakuwa na color code. So each color, depending on the manufacturer. So it's like 30% FiO2, 40%, 50%, 60%, 7. So this works on Bernoulli's principle. You know, like if you open up a tap, there's a bomba, the water will flow in smooth. When you apply at the tip, you see a pressure of water coming. So this holes, more smaller it is, more pressure if I choose. So this is our, it's called Venturi mask. It uses Bernoulli's principles. So you
So basically, each there's a mask here.
There is a mask.
Yeah, I know there is a mask. I have a mask.
Like this. Yeah, this is like now you know that this is 50%.
It's written 50%.
Yeah.
Oh, it's written there.
Yeah, it's written.
Yeah, it is printed.
Yeah, come on.
These are mainly for COPD patients where you want to target your FiO2. Yeah.
You guys have it?
We don't even use it now.
Yeah, oxygen. Alafu fungua tu utaona tu kwamba. Yeah. So hapa inakuambia kwamba weka 10 liters kwa minute. Hapa imesema ngapi? Hapa
So this is the water. It's trapped air and then it's used on. So this narrowing is all inside. It is based on like how much air is pushing in. The oxygen.
Yeah, pediatric size.
Right?
Can it be used in pediatric patients?
Yes, yes, it can be.
All patients.
All patients.
It's just about the mask. You take out the mask, you keep any pediatric mask.
So these are all
That's
color
simple as
codes. Color. So some are not color codes. Some are like, you know, those ones you have to rotate. So you rotate like 30%, 40%. So these are, some are like, depending on which manufacturer. So this mele inakuwa na color, kunakuwa na chart. Like lately hapa kuna number. Kuna zingine hamna number, kuna chart, angalia which color is each chart.
I have seen them, but sijawahi kuona mtu yoyote anatumia.
Hapa hamna. Hapa. There are very few centers have it.
Few, yes.
Few centers have it. It's, as you said, COPD is very good. Because you can give a rightful FiO2.
How do we measure? What is that to say opposite? How do we measure?
How do you know this is the correct size?
No. I think that's
The corner of the mouth?
the corner of the mouth.
What is the name of this? And what is the name of this? So oral, now from nose, from mouth. Yes. Where?
On the corner of the mouth. End of the
Yes.
Here. Angle of the jaw is here. Yeah. Okay, that's for open. Huh?
That's for upper.
Yes.
Angle.
Jaw.
Corner of the jaw. Tip of the mouth to the corner of the jaw.
You can even say corner of the mouth, corner of the jaw. Yeah. Yeah.
And for nasopharyngeal.
So it's from, she said it's from the nose.
The tip of the mouth.
Uh-huh.
Okay.
Yes. How many times in reality have you used this?
I've never used it.
So it is useful, especially when you have patients with bloody mouth, you know, like injuries here sometimes. You can try to think about it when you come back.
Yeah, no.
Rebecca, can you use a ETT tube as this?
Okay.
First geuza and then. So normally hapa people are even now saying don't do that.
Yes.
Because wanasema kwamba fanya hii kitu hivi akuweka hii inakuwa easier for the patient. Yeah. Instead of twisting it. Yeah. Lakini hapa I don't know how many times will you have this.
And the track. So just
So how do you insert? So which part is very sensitive on the nose? The inner part or outer part? Like which can be damaged easily? Which part of the nose? This inside here or here? Are you sure?
Here.
Yes. So the pointy part should always be away from that. So if you're doing this, the pointy part should be here. So the pointy part should be here. So that way you know that you're away from the septum. This thing should be away from the septum. Now, whether you're putting right or left, it should be away from the septum. Similarly, some people, ukipata ETT size tube ya 4-3 unaweza kuweka. Yeah, kama huna hiyo narrow size, yeah. It's the same thing. Kuna mtu, I think it was residence, hatujakuwa na chest tube, tukamwekea ETT size kubwa. Naweka hiyo tukaconnect na urine bag, kazi imeendelea. Aha. So ile maneuvers tuoneshe maneuvers. Head tilt, chin lift na jaw thrust. Kwanza jaw thrust, yani head tilt, chin lift. Yeah. Sawa, na jaw thrust. And then ile combination nimekuambia. No, yani fanya jaw thrust kwanza. Fanya jaw thrust yako. Alafu do head tilt now. Yani hivi. Hapa ni muhimu hii kama hii. So, let's say ukiweka hii hapa. Kwanza see this and then this, then this. See, I'm doing head tilt. And hapa kwa hapa huyu, it's not so easy, but you can do this and then someone else bags for you. So even the bag can be like, sijui iko wapi bag ya ile haina nani. Yeah. So kama hivi, and then I'm doing this and someone else will bag for me. So that way I'm creating myself, at the same time I'm using both the maneuvers to help me. Yeah. Hizi ni nini? Combi tube. So you insert blindly just like an LMA. So hii LMA.
You're fresh, you chill, then you open.
Hii una insert insert. Sasa hapa umeweka kama vile. Yeah. So look, this is your nasa hapa. Make sure first you deflate. So he deflate and create like as if a depression hapa. Alafu lubricate this part. So, then wakati unaingiza, unaenda na fingers hapa. Alafu unaingiza paka una hit resistance. Hit resistance unajua umeingia. Yeah. Yeah. No, bas inatosha. Yeah. So open the mouth. Yeah, yeah. So guide with your fingers kabisa, yani unaingia ndani. I use double gloves up. I wear double gloves. 5 minutes. You can keep. You can keep. Hiyo yani ni kubwa sana kwa mtoto. Huyu ni doli. So, yani that's the way you intubate, unafungua mdomo, unaweka, unaingia kwa hard pellet mpaka unaingia kwenye nani. Like you follow the curve of the patient. This is bougie. So bougie even has two parts. Look at this part. Mona, this is the part you want to use. And sometimes if you feel like your bougie is not going, fanya hivi kwenye kitanda ili iwe na curve. Then one person holds this part and you unafanya hivi, unaingiza ndani. Ushaingiza, then the other person anakusaidia kuweka chini. Sawa? Yeah. Or sometimes unafanya yes, dilate, yeah. Ni kama hii kuwa tu ETT unaweka ndani hivi and then hivi. So sometimes inakaa, sometimes haikai, so inategemea na ETT sometimes. So you can even put it like this, yeah. Then you unatoa it. So the good part of this is that in stylate you cannot come out like this. In this one you can come out paka hapa. Naona? Weka. Yeah. Angalia. Shaingia. Beg. Sasa tuone.
What is this called?
Video laryngoscope. Beg. Lakini hata tumbo inalia hapa. No, hizi. Hii ni medial forceps. Tunatumia hii kwa ajili ya foreign body. The reason why inakuwa curved is because you can get the idea. Yani unaweza kuona foreign body. Like ukiingia, ingekuwa sio curve, you cannot see kwa hapa. So it's just like yani umeputa laryngoscope.
So you can use laryngoscope when you visualize the foreign body.
Unaitoa. Yeah, unaiacha. Una tube. Yeah, hata nazi. Yeah.
Inakuwa inaning'inia tu kule ndani. Kwa hivyo unachukua hii, unaisogeza pembeni. Hapo hapo.
So
Yeah.
what's the between bougie and stillate?
Mimi naona bougie.
But stillate is hard. It's nice.
Hii bougie yani ni flexible, so unaweza lenga hivi. Unaweza kulenga in such a way. Alafu unaweza kubend pia, overbend this. So that way kama nani glottis iko anterior sana, unaweza kulenga hivi. But with stylate inakuwa ngumu.
Okay, you have a patient. This is after round. Ready for extubation.
It's ready for extubation.
What procedure are you going to do in order to extubate safely this patient?
Hello.
All right. So our first speaker is going to be Dr. Ismail. I've already introduced him.
It's low inspired. Low inspired, which commonly happens in patients or no, or if you maybe climb to high altitude. What happens to the high altitude? The pressure is lower compared to what you are.
CO2. Yeah, that is the thing. Of getting rid of carbon dioxide in your body. From my lecture, what are the two parameters you can set in? One is tidal volume, not inspiratory time, no IO ratio. Sorry? Yes. It is that's why I'm so loud, yeah? So it is the inspiration, sorry, it's the tidal volume and respiration rate. Which can give you 5 to 10. Okay. All right. Anything else? Then if I were to, you can leave it at 21. If the patient is saturating well. But when you intubate for the first time and put the patient on the vent, how much FiO2 do you want to leave it to? About 50. About 50, 80. You can start at 100%. Yes, start with 100. What is the problem? Yeah. Okay, but this one, because this vent is not connected to the oxygen, so that's why this will not go up. Even if you want to try to make it go up, it will give you the triggers if we keep it up, sour, because there is no oxygen. Okay, start now ventilating your patient. Start the ventilation. Where do you start the ventilation? Yes. And let's see if there is any problem, yeah? Okay, so remember, when you're doing the volume mode, you are giving the volume and the pressure what? It's generated by the vent. So this is the pressure which is being given, okay? And this is the volume you are giving. Okay? So you can see our patient has a good, there is no alarms ringing, there is no problem, and the patient is saturating well. So what is the indicator which will tell you that you are doing good with your patient in terms of monitoring?
So first the peak pressure, which should not be more than 30. So if it is more than 30 means there's something wrong. Either there's a blockage somewhere or there's accretion. That's why the pressure is higher. Then also you can look at the saturation, yeah. But also the waveforms. So if you can also look at the fluorescence.
This is complicated stuff. What else? Like what other monitors? Because remember, this is an intracerebral hemorrhage. What is the most crucial monitoring in this patient, apart from your pulse oximetry?
Blood pressure.
Plus or minus? Sorry? So end-tidal capnography is very important, yeah? You need to have it between 35 to 45. It shouldn't go above, it shouldn't go below. That is very important for this patient to monitor, okay? Are we together? Okay, for just practice terms, let's choose the pressure support. Okay, let's change the vent and let's go to the pressure support. is the volume. So that is with the volume is VAC and VSIMV. There's so many other different modes, but for today we will concentrate with those two modes. Okay, is it clear? So now there is no problem. And another one thing you should always remember that whenever you're keeping the patient in the pressure support, always have the pressure support trigger. Okay, this is the trigger which you have kept. So when the patient will start breathing, this much pressure it will be given to the patient. Okay, you understand? So let's say I am not breathing, the machine is breathing. When I start breathing, the machine will support me with this much pressure. So always set this one also. Okay. So usually we keep it up to 10, yeah. That's it. Okay. All right. Thank you. कल हम ना यो वेंटिलेटर है वो मैं हॉस्पिटल ही है other dispensary.
You can do aggressive. Aggressive in your approach. So, aggressive is in your approach of care. How you want to achieve results immediately. Because a person is dying, how are you saying, oh, let me just wait for 5 minutes. Let me just wait for 5 minutes. You cannot do that. So you start, you hit hard, and you taper down your approach when the patient is getting better. But the issue of a PEEP, you have to start low because you want to get the patient's compliance. Because positive pressure is coming on the face of the patient, right? It doesn't mean you put 2 and you run away. You put it 2. The patient is getting more toleration, you titrate up until you get to the number that you are interested.
Okay.
Right? So in emergency, you hit hard and titrate down.
Time.
All right.
Thank you very much, Dr. Chu.
You're welcome. Can we get a book of this? Yes, you can have. All right. Where's the other book? Another group? Another group? Okay. Now we're going to look at that patient who is in your ward. You have tried to give nasoprong oxygen. You're titrated from 4 to 6, right? And the patient actually is taking that oxygen away, that nasoprongs away. You have changed the patient, put on a breather mask, and is taking that away. Right? Why do you think that is happening? This patient is hypoxic. Saturation is 75. Right? But you're giving rebreather mask, he's taking it away. You're giving nasoprongs, he's taking it away. You try to titrate it up to 15, still in the wall, it pops out. But the person actually is putting out. Why do you think that's happening? Kwa nini inatokea that way? Okay. The answer is the patient is telling you the method that you are giving me is not enough. Anakwambia kwamba hii njia haitoshi. Sasa na haitoshi, kwa nini haitoshi? Haitoshi kwa sababu tunasema inspiration is an active process. Inspiration is an active process. Expiration is a passive process, meaning that in order for you to have an inspiration, there should be a pressure generated, which is inspiratory pressure. So there is a peak inspiratory pressure that has to be generated. Sasa mgonjwa anapokuwa yuko tachypneic, sawa, maana yake peak inspiratory pressure yake inakuwa iko juu. As a result, ile nasoprongs ambayo tunaita low flow, nasoprongs tunaita flow mpaka 4 or 5, haiwezi, unafanya kitu kinaitwa air entrenchment. Sawa. Air infringement maana kunakuwa kuna ina mixing of air ambayo ana expire na air ambayo unampatia. Kwa mwisho wa siku resultant air nani anayopata inakuwa na less nani, inakuwa iko mixed. Kwa as a result yeye hapati oxygen kama alivyokuwa wewe unaotarajia. Kwa hiyo kumbe hapa the problem is the method that unaotumia kwenye nini, kwenye oxygenation. So what option do you have? The option that we have, we can change from the low flow setup of a rebreather mask or nasal cannula into a high flow setup. So the high flow setup that we have, tuna high flow nasal cannula, tuna CPAP, tuna ventilator. Lakini kwenye CPAP, kwenye hizi machines kuna non-invasive na invasive. You want to consider that as early? No. You want to consider the non-invasive form. Sindio? Na hapa ndipo sehemu ambayo tunataka kujifunza. Sawa. Lakini cha kwanza tutaanza na high flow. Sasa kwenye high flow, hii ni machine ambayo either can be incorporated with the ventilator au it can become a single kama hivi ilivyo. Sasa high flow ina vitu vikubwa vitatu. Kuna flow rate, kuna FiO2 na kuna temperature ya humidification temperature ambayo unaweza kuset. Kwa kinachofanyika ni kwamba hii machine unaiconnect kwenye oxygen, kwenye wall oxygen kama kawaida, na hapa kuna nani hapa ambayo inakuja ya fluid ile ambayo inakuja kwenye humidification. Mind you, the fluid that comes here sio normal saline. Sio any salt containing fluid. It's a distilled water. Kwa sababu the salt containing fluid is coming here. Kwa unataka upate nini? Distilled water ndio inakuja hapo. Sawa? Kwa unaweka hapa kwa inakuja mpaka inafika kwenye that level unaiacha. Sawa? Then level here. Then unaiwasha, ukiwasha hii umeme unapasha.